you're seeing my presentation.
Please confirm that you are seeing my presentation.
Yes, sir. Just you can enlarge your PPT.
You hear me?
Yes, yes. It's
okay. Okay. I'm Dr. Ahmed Masoud from Egypt. Today I will talk about a new invented drug for treating complications of diabetes mellitus, for which I have obtained a European patent. The drug is fermented deglycerinated licorice containing alpha amylase enzyme and flavonoids. Before I start, I would like to recall a movie called Sleuth that was produced in 1972. Only two actors were involved in the movie, namely Sir Laurence Olivier and Michael Caine. Laurence Olivier wanted to take his revenge from Michael Caine, who was in love with his wife. So he played a murderous game on Caine, but Caine then took over and avenged himself. Olivier couldn't stop the defeat, so he eventually shot him dead just as the police arrived and caught him red-handed. What concerns us here is several characters played by Michael Caine, who disguised himself as Big Plump Inspector Klopp, as a clown, and as a police constable. And he finally revealed himself to Olivier. Our analogy here is with Michael Caine as pancreatic amylase, the Big Plump Inspector Klopp as glycogen phosphorylase, the clown as glucokinase, and the police constable as hexokinase. All these enzymes here are the disguised pancreatic amylase enzyme. Diabetes mellitus is one of the most prevalent chronic diseases in the world. Diabetes is a serious threat to global health that respects neither socioeconomic status nor national boundaries. According to the International Diabetes Federation, the global diabetes prevalence in the year 2019 is estimated to be just under 500 million, that is 463 million people. This number is projected to have 25% increase by the year 2030, that is 578 million people, and 51% increase in the year 2045 to be 700 million people. There are 3 new diabetic patients every 10 seconds, about 10 million every year. 1 diabetic patient dies every 6 seconds. 50% of people living with diabetes don't know that they have diabetes. In hyperglycemia, only 40% of diabetic cases are controlled by drugs. In controlled and uncontrolled cases, complications by time persist and they become more severe and intensify. Complication of diabetes may be acute or chronic. Chronic complications may be vascular or non-vascular. The vascular complication may be microvascular or macroangiopathy or macroangiopathy. These 2 angiopathies progress simultaneously as continuum. Glucose catabolism provides energy through glycolysis in cytoplasm and citric acid cycle in the mitochondria. The first step in glucose catabolism is phosphorylation of glucose with formation of glucose 6-phosphate by hexokinase enzyme in all tissues and glucokinase enzyme in liver cells. Glucose catabolism is a series of oxidative reduction reactions needing nicotinamide adenine dinucleotide phosphate and nicotinamide adenine dinucleotide as coenzyme to produce energy. In normoglycemia, only a small amount of non-phosphorylated glucose, about 3%, enter the polyol pathway to form a small amount of sorbitol by the action of aldose reductase enzyme. Also, a small amount of reactive oxygen species or free oxygen radicals will form as a byproduct of sorbitol formation with the help of cytochrome oxidase enzyme B45. Hyperglycemia in diabetes mellitus due to depressed insulin formation or action, besides the impaired glucose catabolism, which decrease the energy production, will lead to shift of glucose to polyol pathway with increased levels of sorbitol and increased level of reactive oxygen species and a decreased level of reduced NAD phosphate and oxidized NAD. Excess sorbitol causes cellular damage by increased osmotic stress, increased oxidative stress, increased formation of advanced glycation in the products, and the receptors for advanced glycation in the products. Sorbitol inside cells cannot diffuse easily across the cell membrane, so it accumulates inside cells, and as it is hydrophilic, it draws and attracts water into cells, which will swell and cause osmotic stress on cell membrane and cellular damage. Osmotic stress will cause cellular damage to cells of retina, lens, nerve cells, kidneys, blood vessel cells, and striated muscle cells. Increased sorbitol formation by aldose reductase enzyme will increase the consumption of NAD phosphate hydrogen. Decrease the level of NAD phosphate hydrogen will impair formation of the intracellular antioxidant reduced glutathione from oxidized glutathione by glutathione reductase enzyme, lead to increased reactive oxygen species and oxidative stress. Increased fructose formation from sorbitol by sorbitol dehydration enzyme, which is the second component of polyol pathway enzymes, will lead to decreased oxidized NAD and increased formation of reduced NAD. The later, NAD hydrogen, acts as a substrate for NAD hydrogenase oxidase to produce superoxide anions, which produce oxidative stress and decreased oxygen species. Hyperglycemia by itself increases reactive oxygen species. Increased glucose, sorbitol, and fructose will glycate proteins, lipids, and nucleic acid, which increase the formation of advanced glycation in the products and the receptors for advanced glycation in the products, leading to increased oxidative stress and increased oxygen species. Oxidative stress played the main role in the development of diabetes complications, both microvascular and macrovascular cardiovascular atherosclerotic disease. The initial step in development of diabetic complication is hyperglycemia induced mitochondrial superoxide overproduction in endothelial cells of both large and small vessels, and also in myocardium, with activation of pathways involved in the pathogenesis of complications. Polyol pathway, advanced glycation in the products, receptors for advanced glycation in the products, protein kinase C isoforms, hexokinase biosynthesis, hexosamine biosynthesis pathway, and the vascular endothelial growth factor. Consequences will be increased intracellular oxidative stress and angiopathy, leading to increased permeability of basement membrane of endothelium, angiogenesis, atherosclerotic plaque, leukocyte adhesion, increased contractility of smooth muscles and myocardium. Normally, glucose catabolism is the main source of energy for cellular processes. Diabetic complications start by disturbance of glucose metabolism with increased energy production and excess glucose accumulation. Diabetes mellitus complications may occur before hyperglycemia at the beginning of disturbed liver metabolism in non-alcoholic fatty liver disease. Hyperglycemia with its consequences alone may not be the only etiology for complications of diabetes mellitus. Metabolism, including glucose metabolism, is a series of enzymatic reactions. Metabolic syndrome, which is the first risk factor for diabetes mellitus, is a disturbance in enzymatic reactions. Diabetes mellitus is a main entity of metabolic syndrome, so enzymatic deficiency is related to metabolic disturbances in metabolic syndrome and the diabetes mellitus complications. Energy releasing processes from glucose catabolism inside cells is under the influence of cascade of enzymes in the cytoplasm, glycolysis, and in the mitochondria citric acid cycle to produce ATP. Diabetic complications are hardly controlled even with meticulous and direct control of blood sugar level by insulin, which is almost 100 years old. And the enzymatic defect would be a more logical answer to this energy shortage rather than insulin deficiency and hyperglycemia alone. So to treat and prevent diabetes mellitus complication, besides controlling hyperglycemia, we have to study the main role of enzymes in metabolic reactions in general and in glucose metabolic reactions in particular. The invented drug contains big amounts of amylase enzymes, besides the lipase, as a product of fermentation, and the flavonoids, which are component of licorice. First, I will talk about the first important component of my drug, which is alpha amylase enzyme, and its role in carbohydrate metabolism and controlling diabetic complications and hyperglycemia. Amylase is one of the most important enzymes concerned with carbohydrate metabolism. It was believed that amylase is a digestive enzyme only. By now, it has a metabolic effect as well. Recently, it was discovered that alpha amylase secreted by pancreas is absorbed in the intestine by active transport and reach the liver. Hepatocytes identify amylase enzyme and receive it from the blood through specific receptors, mannose receptors, on the hepatocyte surface. Liver captures 80% of the absorbed amylase, which with back reabsorption of 20% by pancreas. So we have enterohepatic pancreatic circulation of amylase. Hepatic amylase expressed in human liver has high affinity to liver glycogen in hepatocytes, and it might have a very important role in glycogen metabolism and energy production in hepatocytes and all body cells. In spite of the high affinity of amylase to liver glycogen, amylase has a very low enzymatic activity. Here we have some inquiries to be answered. Why is amylase absorbed from intestinal lumen if it has no substrate in the human body cells to act upon? Amylase acts on starch, and no starch exists inside animal and human cells. Carbohydrate is stored inside cells as glycogen, which provides glucose by glycogen phosphorase enzyme. This strongly suggests the metabolic role of amylase in carbohydrate metabolism inside cells. Why the liver absorbs selectively 80% of the absorbed amylase and they recycle only 20% to be sent back to pancreas? Liver then excretes amylase with bile. Why human liver amylase has high affinity to liver glycogen, although its enzymatic activity is very low, but steady? Why glycogen phosphorylase has no trace in serum, while amylase has a constant level? So from where does glycogen phosphorylase inside cells come? Nobody knows. Amylase enzyme has been found in 22 different tissues other than salivary glands and pancreas, as liver cells, fallopian tubes, striated muscle, adipose tissue, kidneys, and lungs. Could amylase perform a job in these sites? To explain these contradictions or conflicts, researchers depend on the imaginary Jockey evolution theory of natural selection and replacement of Darwin and Alfred, which is rejected by many people. They assume that in the evolution and development, the liver may previously have had high levels of amylase activity, which played a role in glycogen metabolism in the liver. They assume that liver amylase may be ancestral, first to occur, isoenzyme, and salivary and pancreatic amylase may be isoenzymes developed then after, according to the evolutionary theory of natural selection and the replacement of Darwin and Alfred. I think all facts are ancestral, without evolutions, without replacements, and without natural selection. We discover facts bit by bit. The evolution is in our discovery of the constant facts. Alpha amylase is not hormone dependent. So when left to act upon glycogen, it will not stop until all glycogen substrate is consumed. Glycogen phosphorase under hormonal control, which predominates requirements and needs. Now we'll assume more logical and more acceptable hypothesis. All the above put together raises an assumption that pancreatic amylase could be used to manufacture glycogen phosphorylase. We may assume that 4 molecules of amylase incorporate by a specific gene to form 1 molecule of glycogen phosphorylase. The primary enzyme of starch metabolism to produce glucose is alpha amylase. The primary enzyme for glycogen metabolism to produce glucose 6-phosphate, which is the first step of glycolysis, is glycogen phosphorylase. Both alpha amylase and glycogen phosphorylase act on one and the same link. Both catalyze the specific cleavage of alpha-1,4 glycosidic linkage, both in starch and in glycogen. The difference between both is that starch is made up of straight chains of glucose molecules coiled upon themselves, while glycogen is highly branched and much larger. Besides, amylase is nearly 1/4 glycogen phosphorase in the number of amino acid residues, as well as 1/4 glycogen phosphorylase molecular weight. It is quite rational to assume that 4 molecules of amylase might incorporate to form 1 molecule of glycogen phosphorylase, which is the primary enzyme for glycogen metabolism in the liver and muscles and all other tissues. Glucokinase in liver and hexokinase in most tissues catalyze the phosphorylation of glucose into glucose 6-phosphate, the first step in glycolysis and glucose metabolism. Glucokinase is almost identical with pancreatic amylase, nearly with the same molecular weight and the amino acid residues. Hexokinase is an isomer of glucokinase. Sorry. Pancreatic amylase may be the source of enzymes mentioned above: glycogen phosphorylase, glucokinase, and hexokinase. Michael Caine disguised himself. All these enzymes responsible for phosphorylation of glucose and hexose molecules, and this is the rate-limiting step in glycolysis. Whether the hypothesis of utilizing alpha amylase to form glycogen phosphorylase along with enzymes of glycolysis and citric acid cycle is fact or illusion, the fact remains. Alpha amylase deficiency was recorded by many authors in complicated diabetes, and the degree of deficiency correlated well with the severity of complications. Besides, alpha amylase supplementation ameliorates diabetic complications. Amylase activity was low in diabetic patients compared with controlled, and the degree of amylase deficiency is proportional to the severity of complications. Reduction in serum pancreas amylase and lipase was recorded in both types of diabetes, being more significant in type 1. Low serum total amylase levels are associated with metabolic syndrome, obesity, and type 2 diabetes. Amylase may be helped to predict metabolic syndrome and the development of cardiovascular disease. Low serum amylase is associated with metabolic syndrome and diabetes, and this is recorded in a community-based study. Low serum amylase may reflect the pathophysiological conditions of obesity, a fundamental cause of metabolic syndrome. Low serum amylase is associated with decreased basal insulin levels and insulin secretion, as well as high insulin resistance. Serum amylase levels were significantly lower in non-alcoholic fatty liver disease, which include the spectrum of simple steatosis to non-alcoholic steatohepatitis, metabolic syndrome, and systemic insulin resistance. What causes amylase low? In type 1 diabetes mellitus, it is settled that now insulin is a potent enhancer of the secretion of the exocrine portion of the pancreas. Thus, hypoinsulinemia will cause hypoamylesemia. Also, the initial insult, which affected the islet cells, could have also damaged the exocrine portion as well. In type 2 diabetes, eating fast and junk food devoid of enzymes is a major suspect. Poor feeding habits, including irregular timing of meals and taking one large meal per day, will interfere with the proper function of intestinal transporters responsible for amylase absorption, which is also affected by emotional factors like depression, frustration, and stress. Deficiency of amylase in diet for a long time may cause deficiency of metabolic activities all over the body, including energy production from glucose. In diabetics, oral glucose tolerance tests at 1 and 2 hours showed significant increase in plasma glucose, significant decrease in serum amylase. Glucagon administration caused a decrease in serum amylase. This decrease was not observed in patients with hepatocellular damage. The development, the development, the development of liver damage in rats by chemical reagents depressed the amylase activity in serum and liver. This may indicate that liver may be the major source of serum amylase rather than rather than the pancreas or the parotid glands. Although that these findings were reported in the early 60s, they were not confirmed by further studies, as such were considered as solitary findings that could not be related to each other. Nevertheless, they confirm our understanding of the pathophysiology of diabetes mellitus in relation to amylase enzyme. There is another extra-digestive action of pancreatic amylase. Internal amylase enhances intestinal glucose metabolism by the gut tissues, with consequent reduction of glucose absorption from the gut into the systemic blood. Insulin secretion is consequently decreased. That will aid in prevention of development of obesity and diabetes. We can support that the use of amylase as a factor to slow down the development of or to treat obesity and diabetes should be considered. Gut mucosa may be the third main glucose metabolizing component of the body, in addition to muscle and fat, in an amylase-dependent, insulin-independent manner. As regards the flavonoids, the other component of the drug, many experts stated that flavonoids are the most promising compounds for prevention and treatment of diabetic complications. They are aldose reductase inhibitors, they are antioxidants, and some of them have hypoglycemic effect. Flavonoids are aldose reductase enzyme inhibitors, preventing sorbitol accumulation in different tissues, preventing diabetic complications. Flavonoids are very potent antioxidants. They prevent oxidative stress, which is the most important factor in development of diabetic complications. Some flavonoids have hypoglycemic effect, for example, gallic acid, glabridin, and amorphoroteins. Many researchers developed the importance of licorice flavonoids in controlling diabetes and its complications. Herein, there are 13 of them. In an attempt to validate the role of oral replacement therapy, amylase enzyme amylase in diabetic patients, I managed to produce a drug formulation rich in amylase and acid lipase, prepared by fermentation of crude licorice root, then deglycerination to get rid of hypertensive effect of glycyrrhizine, yet sparing the rest of the licorice root rich in flavonoids. To finalize the powder form of the drug, concentration and lyophilization by freeze drying was done. I received a patent for this formulation from the European Patent Office, and herein the European patent specification. The drug is approved from Committee of Medical Ethics of Al-Azhar University. For safety, acute and chronic toxicity studies have been done for the drug in Pharmacology Research Unit in Egyptian National Research Center and proved to be safe even at 100 times the therapeutic dose. We have published 2 papers last year in international journals regarding the efficacy of the drug. In the first paper, we have studied the therapeutic effect of the drug on diabetic keratopathy in rats. These are photomicrographs of corneal sections taken from normal diabetic and diabetic treated rats. Diabetes caused apparent decrease in the thickness of the corneal epithelium with vacuolation of cytoplasm of some cells with sloughing and separation of the epithelial surface cells. Subepithelial vascularization decrease in the thickness of stroma with wide separation of collagen bundles, which are irregularly arranged instead of being regularly arranged and compact, thick and wavy Descemet's membrane. All these changes were normalized after treatment by our drug, and the cornea became more or less comparable to the normal group. In the second paper, we have studied the therapeutic effect of our drug on gastrocnemius muscle and sciatic nerve of diabetic rats. Gastrocnemius muscle of the diabetic group showed discontinuity and destruction of myofibrils and widening of the interstitial spaces between muscle fibers. And this may be the pathogenesis of diabetic myopathy. These changes were normalized after treatment and they became comparable to the normal group. In sciatic nerve, the normal myelin sheath is regular and compact without splitting. In diabetic group, the myelin sheath is irregular with splitting. In diabetic treated group, the myelin sheath showed dramatic improvement. It returned regular and compact without splitting. Clinical studies showed marvelous improvement in sensory and motor polyneuropathy Results have not been published yet. Here, the drug effect on different complications mentioned in the patent, showing marvelous improvement of the majority of them in a short time. Quickly, I will view just two cases with dramatic response as examples. A 20 years old female could hardly tolerate walking or working for few minutes. After 1 hour, she got extremely exhausted. She used to receive 100 units of long-acting insulin per day with a blood sugar level over 300 milligram per deciliter. Required hospitalization. In short, her life was miserable and she was severely depressed. With the use of the new drug, she showed marked improvement within 2 to 3 weeks. She could work normally and walk for long distance. Her insulin requirements dropped and her blood sugar not exceeding 200 milligram per deciliter. A 45 years old male had frozen shoulder. He was subjected to manipulation under general anesthesia, which failed. Using the new drug for 3 weeks, he could move his shoulder without pain and in a more or less normal way. Thank you.
Any questions?
Yeah. Hello.
Yes, yes. Any questions?
Yeah. Sir, this is very interesting because, evolutionarily, pancreas and liver seem to have some very intimate relationships. And I wonder if it was one organ sometime back. And the same thing seems to be going on between exocrine and endocrine functions of the pancreas. They are so correlated. And now, are you suggesting that what is your guess or mechanistic proposal for improving tissue level, cellular level improvements because of this? Is that because of flavonoids or the other aspect?
I am Dr. Shawarbi, associate of Dr. Masoud, and I would like to answer some of your questions. Uh, what we are interested in is the effect of the enzyme produced by fermenting licorice. This enzyme is pancreatic amylase. The flavonoids only act as adjuvants to this main substance. This enzyme has a role that has always been overlooked. It actually uh, is the mother enzyme for the three enzymes that Professor Masoud mentioned, which is glycogen phosphorylase, glucokinase, and hexokinase. Now, how is this possible? Oh, everyone knows that each enzyme has a specific substrate. In this case, pancreatic amylase has a substrate which is starch. We all know that. Glycogen phosphorylase has its substrate too, which is glycogen. There is a resemblance, a great resemblance between starch and glycogen. Both of these are composed of glucose molecules arranged together side by side. Carbon number 1 in the first glucose molecule is joined to carbon number 4 in the adjacent molecule. This is known as the 1,4-glucosidic linkage. Since both starch and glycogen phosphorylase act on this specific active site, so they have to have the same active site just as well. In case of enzymes, we call that the blade. The blade of the enzyme is that part of the enzyme which cuts through the substrate. In this case, both enzymes, amylase and glycogen phosphorylase, have the same blade. They only differ in the rest of the molecule. The rest of the molecule acts as a hub, according to enzymologists. It is used to fix the substrate while the blade cuts through. In case of amylase, the molecule of starch is much smaller than that of glycogen because there is no branching. In case of glycogen, there are branching points, and accordingly, the glycogen molecule is very big, exactly in the active site of the substrate. As I said, in this case, we have the same blade or the same active site in both glycogen phosphorylase and amylase enzyme. Now, amylase is absorbed through the intestinal wall, gets to the liver, and is retained in about 80% of its quantity absorbed, and only 20% is recycled, apparently recycled. Okay, what does this signify? If starch has no substrate inside the human body, only glycogen, what is amylase doing inside the human body? If it is a question of recycling and conserving energy, well, it could have been stored in a pouch in the intestine, simply something like the gallbladder, for instance, to be uptaken and then reused. But to be absorbed and to take the trouble of absorbing it and recycling it to the pancreas, this is a long story, particularly if we know that the enzyme which is launched back in the circulation is hepatic amylase and not pancreatic amylase. This means that recycling is not the purpose of absorbing pancreatic amylase. Now, what is it that we make use of when we absorb starch, or I mean pancreatic amylase? If we take a close look at the enzymes, those two enzymes, amylase and glycogen phosphorylase, we will immediately notice a relationship between both enzymes. Glycogen phosphorylase is 4 times the specific, the molecular weight of amylase. At the same time, the number of amino acid residues in the glycogen molecule is again 4 times that of amylase. So it would make sense to think or to consider that 4 molecules of amylase are incorporated by the liver in the manufacture of glycogen amylase, of the glycogen phosphorylase. This will offer the new molecule, which is glycogen phosphorylase, to become bigger in order to engulf the huge glycogen molecule, and it will have 4 blades. Those 4 blades will cut through the substrate, which is glycogen, rapidly in order to satisfy the needs of the body whenever it is needed. Now, this is a presumption, okay? What I'm going to provide now is actually a logistic evidence of the relationship between amylase and glycogen phosphorylase. This is the first step, which is the resemblance between the molecular weight and the amino acid number of amino acid residues. If we come to the to agree about this assumption, then the next step would be, does this take place all of a sudden, or it takes place in steps? It would be reasonable to consider that this takes place in steps. The first step would be to change the affinity of the amylase enzyme towards glycogen. When this happens, we get a new enzyme, which is the hepatic enzyme. The hepatic amylase is an enzyme retrieved from liver extracts, okay? But apparently, it doesn't share in any metabolic function inside the liver. So what does it do? It actually is used either to be secreted by the bile to help starch digesting glycogen inside the gut, or it is sent back through the circulation to reach distant tissues and not only the pancreas, because it is sent as hepatic amylase rather than pancreatic amylase. Do you hear me? Hello?
Yes,
Do
yes,
you
sir.
hear?
Yes, sir.
Yes, sir.
Okay. Now, as I said before, if it were recycling, the liver would have sent the amylase in the form of pancreatic amylase, which is not true. What is present inside the circulation is actually hepatic amylase. Why so? Because distant tissues will use this amylase, hepatic amylase to form glycogen phosphorylase inside the cells, because glycogen is too big to be transferred through cell membranes. What is being transferred is actually amylase enzyme. Am I making myself clear? Hello?
Yes.
Do you hear me?
Yes, yes, sir.
Yes.
Okay. Yes.
Proceed, sir. Proceed.
Okay. So, as I said, the liver sends hepatic amylase to the distant tissues to be assembled inside the cells to form glycogen phosphorylase, because we know that glycogen is present inside every single cell in the body. Okay? Glycogen is present inside every single cell in the body. So we need to prepare glycogen phosphorylase enzyme in order to be able to deal with this glycogen. It is the liver which sends this hepatic amylase to be assembled in situ, inside the cells, to form glycogen phosphorylase. That's the purpose of absorbing amylase and then changing it into hepatic amylase and then launching it back into the circulation. Okay, now during the steps of manufacturing, you hear me? Hello?
Yes.
Yes, sir.
During the manufacture of glycogen phosphorylase, we have to go through steps. The first step was to form a hepatic amylase which has more predilection towards glycogen. The second step is to be able to render this enzyme capable of phosphorylating the glucose molecule. Because we know that glycogen phosphorylase enzyme acts on glycogen, producing glucose 1-phosphate, which is then turned to glucose 6-phosphate to start glycolysis. So the liver has to be capable of rendering this enzyme capable of phosphorylating the glucose moiety. In this case, we're going to get a new enzyme, which is the glucokinase enzyme present in the liver. This glucokinase enzyme has the same molecular weight as amylase, which is about 50 kilodaltons, and only differs in about 10 amino acid residues, the amylase being 475 amino acids, and the glucokinase is only 465 amino acids. It goes without saying that the isomer of glucokinase, which is hexokinase, is also manufactured from amylase enzyme. So what do we come up with at the end? We come up with amylase, as my colleague Dr. Ahmed said, which is represented by Michael Caine, is the parent drug. It is disguised in the form of glycogen phosphorylase, in the form of glucokinase, in the form of hexokinase, but it is essentially amylase. Where does this take us? Phosphorylation of the glucose moiety is the first and rate-limiting step in glycolysis. Without this step, there is no glycolysis. And that's the mainstay of the drug. Without amylase, there will be no glycolysis. And without glycolysis, there will be no citric acid cycle. This is the main problem which causes insulin resistance. It's a physiological sort of resistance and not a receptor kind of resistance. It's a physiological resistance caused by the deficiency of amylase enzyme. Now, what happens when glycolysis is delayed or becomes really insignificant? What happens is that the energy production inside the human cell all over the body will be affected. There will be low production of energy inside the body. You hear me?
Yes.
Hello?
Yes, yes,
You
sir.
hear?
Yeah.
Yes, yes.
Yes. Okay. Now, if glycolysis has to be appreciated, what is the role of glycolysis inside the human body? Besides being the preparatory and the mandatory step for the citric acid cycle in order to break down not only carbohydrates but also lipids and amino acids, it's a very important process for those cells that have no mitochondria, like the red blood cells, for instance. The red blood cells have no mitochondria. They depend entirely for their energy sources on glycolysis. Glycolysis will not only produce the red blood cells with the energy, but they will produce a very important enzyme or a very important substance inside the red blood cells, which is called 2,3-bisphosphoglyceric acid. 2,3-bisphosphoglyceric acid is that substance which renders the hemoglobin generous in order to release its oxygen at relatively high oxygen tensions. So the absence of glycolysis or the poor glycolysis which takes place inside the red blood cells will affect the ability of the red blood cells to do their proper function. If we add to this point that glycolysis is the main source of energy during strenuous exercise, because there is no time for oxygen cycle inside the citric acid inside the mitochondria. So the main source of energy during strenuous muscular exercise is from glycolysis. If we put these two pieces together, we will now notice why diabetic patients have very low tolerance to exercise. They cannot exercise themselves and they cannot lose weight if they want to. The second important or very important site which will suffer from no glycolysis or low glycolysis are the eye components, the three eye components, the cornea, the lens, and the retina. They depend almost entirely on glycolysis because they have non-functioning mitochondria. And this explains why the eye components, those eye components are commonly affected in diabetic patients. And they constitute a very important complication in diabetic patients. Now, the last and also very important are the white blood cells. The white blood cells depend almost entirely on glycolysis. And this also explains in part the low immunity in diabetic patients. Now, what causes actually this hypoamylasemia, which actually precedes the hypoinsulinemia? In diabetics of the first type, the problem is simple. The insulin, the hypoinsulinemia, which occurs in type 1 diabetes, will affect the exocrine portion of the pancreas, will affect negatively this portion of the pancreas, causing low enzymatic absorption or secretion. In diabetics of the type 2, the problem is much more complicated. It may be related to the type of food that we ingest, the fast and junk foods. It might be related to the timing, the proper timing, and the amount of meal that we get every time. But to my mind, the most important factor for hypoamylasemia in diabetic patients is the low absorption from gastrointestinal tract. Every system in the body has its reserve. That's well known. For instance, the heart can beat at 72 beats per minute during rest, but can exceed that 260 or 170 beats per minute whenever needed. This is the reserve. When it comes to the gastrointestinal tract, this reserve has always been overlooked. Nobody cares for the reserve of the gastrointestinal tract. But actually, what happens is with time, there is diminution of these reserves, resulting in poor selective absorption of the nutrients from the gut. This manifests itself in those substances with high turnover rate, like, for instance, amylase, like magnesium. We can easily notice that many of the complications encountered in diabetic patients could be related to the poor absorption from the gut rather than related to hyperglycemia or related to water and electrolyte balance and so forth. But nobody has even been paying attention to this, but it is a very important aspect of hypofunction of the gastrointestinal tract, and this may turn out to be a very important cause of many of the diseases that we see around us. Now, to put the pieces together finally, amylase enzyme is the main precursor of those three important enzymes: glycogen phosphorylase, glucokinase, and hexokinase. And these three enzymes are the bottleneck of glycolysis. When there is not enough amylase, these enzymes will be short, and we will get low energy production because there is no glycolysis, and this will be reflected on the citric acid side. This is, in short, what my colleague has been trying to say. The new drug thus formed from the fermentation and deglycerinization of licorice is rich in both alpha amylase and an acid lipase, along with the remnants of the crude licorice root, which is about 50 types of different types of flavonoids. Together, they will definitely improve the energy production inside the cell. Amylase in the glycolysis, and flavonoids act as hydrogen acceptors inside the mitochondria. The problem with oral enzymes is that they have to be absorbed through special receptors in the intestine. And these receptors are guarded by immune cells. Those immune cells are something like the customs. The enzyme that will go through has to go through the customs, has to be accepted by those immune cells, because otherwise it's going to be antigenic and it will raise antigenic problem inside the body. So not any oral enzyme given will be readily taken inside the body. Only those enzymes or those substances that will be allowed in by the immune cells. This is an important aspect to remember. There is also a very important aspect to remember, which is the fact that the licorice is a demulcent. It actually has been used as a demulcent for gastrointestinal tract for a long time. So this drug is ideal from this aspect. It does not initiate any antigenic reaction, it is easily absorbed, and it works perfectly well. That will be all. If you have any questions, please ask.
Hello.
Have you heard my talk?
Yes, yes, sir. Any questions to Dr.
Any
Masood?
questions?
Yeah, I heard. Yeah, I listened to what you said. So looks like you are trying to say that when cells are starved because of diabetic um, issues, whether it be insulin resistance or whatever, you have a parallel pathway to improve the energy at cellular level. Is that what you're saying? That seems like
No,
the
I know,
summary.
no, I'm not trying to improve the allergy. No, all I'm saying is that the new drug prepared by fermenting licorice is devoid of antigenic reaction. It does not initiate any allergic reaction. But the main, hello?
Yes, yes,
You
sir.
hear? The main item in the new drug is the amylase replacement. It is a kind of amylase replacement therapy in diabetic patients. This hypoamylasemia in these patients cause physiological resistance to insulin, and this explains the presence of hyperinsulinemia in the pre-diabetic phase. In this phase, the diminution of amylase takes place with time. And the pancreatic cells are consumed because of the hypersecretion of insulin all the time. Until it comes to a point when there is only 40 or 50% of the islet stock cells are left, you start to develop frank hyperglycemia. But the process of diabetes or the metabolic syndrome has been going on for years, and this explains the presence of diabetic complications in insulin resistance syndrome without actual elevation or without actual hyperglycemia, without frank hyperglycemia. But the process has been going on. You heard me?
Yes, yes, sir.
Okay. Is there any question you want to ask?
We can discuss offline. So.
Yes, sir. Fine. So we have got a question from Mr. Aishman Sarif. Just he raised his hand to ask the question.
What question?
Okay, I think it's not asking. Any questions?
No. Do you have any questions?
Yes. Thank you, Dr. Ahmed, for this interesting presentation. My question is, licorice is known to cause salt and water retention, which is contraindicated in patients with hypertension and congestive cardiac failure. So
Yes.
whether this medication...
That's true. All this is due to the substance.
Excuse me, I didn't finish my question.
Yes.
So
Yes.
what is the side effect? Is it contraindicated in patients with hypertension and patients with heart disease? That's my first question. Second question,
No. Yes.
what is the dose of this herbal medication, or how frequent, and whether it is approved by FDA? Can you answer these three questions, please?
Yes. As for the first question, this is a deglycerinated licorice. The glycyrrhizine is the substance which has a cortisone-like action. This has been eliminated altogether. So there is no problem with adjusting this enzyme. You got that?
Yes. So it has no
Okay. It has no side effects. No, it has no cortisone-like, because this is the substance that has been eliminated,
Okay.
which causes salt and water retention.
So what are the doses, the frequency, and whether it was approved by FDA in your country?
Yes.
Yes.
As Dr. Ahmed said, this drug, the safety of this drug has been tested in the National Institute of Research here in Egypt. The drug has no side effects up to doses of 100 times the therapeutic dose that we use. So there is nothing wrong with ingesting as much as you want from this enzyme. It is well known when it comes to oral enzymes that you can take those enzymes 5 or 6 times a day if needed. There is no harm whatsoever. No side effects.
Whether approved by FDA?
It hasn't been in the market to be approved by the FDA or not. We just got the patent from the European Union, but we haven't produced this drug as a in the market.
Can be used in two types of type 1 and type 2?
It has to be used in type 1 and type 2. As a matter of fact, the response in type 1 is far better than type 2. Why? Because those patients have sound and intact gastrointestinal tract. So their absorption is marvelous. And that's the case that Dr. Ahmed referred to. You heard that?
Yes,
Yes.
yes, sir.
Thank you.
It has a fascinating effect in type 1. In type 2 diabetes, the response will depend on the timing of intervention because this is a replacement therapy. Some of the complications will be reversed and some others will not respond. You don't know. You just try it and hope for the best.
Duration for treatment?
I beg your pardon?
Long.
Huh?
The duration, for how long the patient has to
You have to
continue?
take it for good until you make sure that your amylase enzyme in the serum is of acceptable levels. Then you can stop and then try again later if you need it.
So it can be followed up by checking the amylase level in the blood?
Yes,
mean?
yes, in the amylase level in the blood. This is a solid marker of what's going on.
Interesting. Thank you.
Yes. Any more questions?
Any more questions to Dr. Mohammad Masood? Any more questions? Okay, thank you for always speaking up in the team meeting and providing a unique perspective. Thanks for sharing your tips with us, sir.
Thank you very much.
Thanks, Doctor. We have enjoyed your speech. We appreciate your speech. Thank you very much.
Okay. Thank you very much.
So, next we welcome Dr. Abhishek Srivastava from R&R Hormone Clinic from India to start his presentation. Yeah, sir, you can go.
Yeah, hello, everyone. Can everyone hear me?
Yeah, yes, sir.
Okay. So, good morning out there. It's evening here in India, so a bit of time difference. But anyway, it's been a pleasure, and I want to thank the organizers for inviting me in such prestigious webinars and putting my words, putting my ideas in front of all the esteemed researchers, consultants, and the legends of the Middle East world. I'm very much thankful to the conference organizers. And let us start today's talk. And my talk would be on the management of diabetic patients during the COVID-19 infection. Basically, it's a hot topic now. And most of the physicians do find it very confusing and difficult as to how to manage diabetic patients during the COVID-19 infection or the diabetic patients who are suffering from COVID-19 infection, how to manage their blood sugar spikes, what are the medications which have to be used, what are the medications which have to be avoided during this ongoing pandemic condition. And today I'll be talking more or less about all these things. So we all know by this date, previously last 5 to 6 months, we were unaware about the virus outcomes, the comorbidities, the problematic complications which will be occurring in the later stages of the virus life. But we all know most of the things we all know about this COVID-19 infection. And COVID-19 basically is an infectious disease which was caused by the recently found known virus, novel SARS coronavirus, which was basically originated in Wuhan, China in December 19. So in last 10 months, a hell lot of the world has changed. Everything has changed, our way of thinking, our way of living, our way of eating, and our way of treating also. Everything has changed drastically. And I think this would last for around for the next 1 year also. The same kind of mindset will be there in the general public as well as in the physician's mind also. So basically, we all know. Next, please change the slide. And this is the novel SARS coronavirus, which was discovered 10 months back. Previously, we had SARS-CoV virus and MERS-CoV virus. SARS virus was invented in 2003. This was severe acute respiratory syndrome virus, and MERS was Middle East respiratory syndrome coronavirus. But the previous two viruses, SARS and MERS, had not so much of probability complications about had not a very severe probability complicatory methods, which right now we are seeing with this novel coronavirus. And basically 10 months back, we were not aware about this virus also. But as the outbreak happened, as the complications occurred, and as the problems occurred, we came to know that how difficult this virus is to treat and what are the problems which this virus is causing in an individual people, basically those who are suffering from diabetes and blood pressure or thyroid. Why I want to say about this SARS virus, coronavirus, is that it basically affects the lungs. The most common problematic pathological condition which is causing this virus is the acute respiratory lung syndrome or the lungs failure. And this is the part which we'll be discussing in the later slides. What is happening to the SARS virus, what is happening to the lungs, why it is causing most of the problems, and what are the things which should be avoided. Next. And we can see in this slide mortality rate by age. As the age increases, the mortality rate also increases. But if we look at the slide where the median age is around 50 to 59 and 60 to 69, the mortality rate is around 50%. But if a person is suffering from diabetes or hypertension or thyroid disease, this mortality rate increases by the next 10 to 15%. That means a person who is at the age of 50 to 60 or 65, and he has some comorbid conditions like diabetes or hypertension or coronary artery diseases, the mortality rate almost rises by almost 1.5-fold. So this is the problem where we always say to the patient, if you are suffering from any comorbid conditions, do take proper care of yourselves. Don't go out, do take proper sanitization methods, wear masks all the times, don't go into the public places, avoid as far as possible. This is the problem where we are facing right now. Next slide. Now, WHO definitions of COVID-19, what is basically in what we are doing right now in India is we are treating the suspected patients also as a COVID patients, because basically what is the recent trend we have seen in the last 3 to 4 months is that even if a patient's RT-PCR values came to be negative, but his HRCT thorax status shows us a wide-grade pneumonia. So basically what led us to this treatment protocol changes is that even a suspected case with typical symptoms of acute respiratory illness like fever or respiratory distress or breathlessness or cough or shortness of breath, basically we should treat that patient as a COVID-19 positive patient. That has changed a lot of things, and that has decreased the mortality rate also, and the recovery rate has increased drastically when we have adopted this kind of method. But basically suspected cases, what a patient with acute respiratory illness, fever and at least one sign and symptom of respiratory disease, example cough, shortness of breath, and a history of travel. Basically travel is out of the context right now. It was 3 to 4 months back where we were looking about the history of travel to any country where this pandemic has occurred, but right now we have surpassed this stage. So basically patient with acute respiratory illness and signs and symptoms is a suspected case, or a patient with acute respiratory illness having been in contact with a confirmed or probable COVID-19 case. these patients can also be taken as a suspected case and should be treated as a COVID-19 treatment protocol. And the third criteria could be a patient with severe acute respiratory illness with fever, at least one sign symptom of respiratory disease, example cough, shortness of breath, and requiring hospitalization, and the absence of any other comorbid conditions. So these are the basically three criteria of a suspected case, where we should directly think of treating those patients as per the COVID protocols. Next. Now, what are the probable cases? A suspect case for whom testing for COVID-19 virus is inconclusive. But inconclusive is why? Because he has had a fever in last 2-3 days, but his RT-PCR is negative. Then we can say, okay, this is a probable case, but the symptoms, but the tests are inconclusive. Or a suspected case on whom testing could not be performed for any reason, reluctance of the patient, or any conditions where the swab could not be taken. And third is the confirmed cases in whom laboratory confirmation diagnosis has been proved to be COVID-19 positive. So these are the few criteria which I wanted to discuss and which I have discussed. So these patients should be taken as a COVID-19 patient and should be treated accordingly. Next. Now, a definition of a contact. A contact is a person who experienced any one of the following exposures during the 2 days before and 14 days after the onset of symptoms of probable or confirmed cases. This is a definition of a contact in whom the COVID-19 virus has been diagnosed RT-PCR positive, and you came in contact 2 days before occurrence of symptoms, 2 days and the 14 days after the onset of the symptoms. So these definition could be termed as a contact. Then face-to-face contact with a probable or confirmed case within 1 meter and more than 15 minutes. This is the point where I want to tell you, probable face-to-face contact within 1 meter for more than 15 minutes. This is the point where I want to tell masks come into play very, very importantly. If a person is wearing mask, COVID-19 patient wearing mask, you are also wearing mask, the chances of infection are almost reduced by 50%, for 60%. If you are wearing mask, patients are wearing mask. If you are standing 1 meter wide difference, chances decrease by almost, comes down by almost 20%. Now, if you are wearing mask, patient is wearing mask, probably following all the hygienic conditions, contact less than 5 minutes, the chances are almost less than 10%. So that is the reason why we've always tell the patients, tell the people, public, do wear masks all the time and proper follow all the hygienic conditions which are directed to you by the government of India and all the where. Now, direct physical contact with the probable or confirmed cases, direct care of a patient with probable or confirmed COVID-19 diseases where the healthcare professionals are in direct contact, like the staff nurses, the doctors, the duty doctors. These are the criteria, or the laboratory technicians or the pathologists. These are the persons who are in direct contact with the patients. And other situations are indicated by the local risk assessments. Next. Now, symptoms, we all know: high fever, tiredness, dry cough. But what I want to say is high fever is considered as a temperature more than 100.4 degree Fahrenheit. Tiredness, excessive body tiredness, the body feels completely tired and without energy with body ache. That is also I want to add, body aches or the pain in the body parts with tiredness. And dry cough is almost seen in almost 80 to 90% patients. Mild dry cough is also indicative of the COVID-19 infection. But what are the basic laboratory tests which are to be followed? CBC with ESR, especially CRP, C-reactive protein, then D-dimer. These are the few tests which we have to look for when we want to suspect a patient, whether he is RT-PCR negative but he has suspected symptoms. Then these hematological tests come into play along with these symptoms. Now, other symptoms also the sputum production and diarrhea. Diarrhea is seen in almost 3 to 5% of patients, but acute diarrhea with pain abdomen with fever is highly suggestive of COVID-19 infection in present scenario, pandemic scenarios. Next. Now the timeline of the coronavirus: 0 days, almost 7 days, no symptoms, nothing. But suddenly on the 7th day, if you feel like breathlessness or high-grade fever or severe body ache or extreme weakness, do not take it lightly. Go for test immediately. Go for various hematological tests, HRCT thorax. The most important diagnostic marker right now in India is basically has become HRCT thorax. It is not basically recommended or indicated, but as per the situational outcomes where RT-PCR are coming negatives, but even patients then are suffering from acute respiratory illnesses, then the HRCT thorax comes into play, and the signs of pneumonia, viral pneumonia is highly suggestive of, with ground glass appearance is highly suggestive of coronavirus infection. So basically by the 7th day, if you feel something from the onset of symptoms, 0 to 7 day, if you feel anything, such symptoms, then do take proper care of yourselves and immediately go for various diagnostic tests which can confirm COVID-19 viruses. Next. Now, emergency warning signs in adults: difficulty in breathing or shortness of breath, certainly. Persistent pain or pressure in the chest, certainly. New confusion or inability to arouse, and bluish lips or face. Bluish lips or face can be termed as the basic marker, because the hypoxic condition where we can see is are the bluish lips or the blue face. That means your saturation point or the oxygen level has come down drastically. Now, what is the optimal oxygen level which you should look for in a patient is saturation point less than 90%. Then you should be aware this is an emergency sign where you should go for various diagnostic test criteria. Next. Basically, I'm going it very fast because I want to talk to you about the diabetic drugs which we have to use during the COVID-19 infection. Now, very important part: what is the interplay between SARS coronavirus and ACE2 receptors? Basically, what is there? And all this summary about various diabetic drugs revolves around this only. So basically, SARS-CoV virus and ACE receptors, what is the interplay? What is the relation between these two? Why it is important? Because COVID-19 might enter the human body via this angiotensin converting enzyme 2 on the surfaces of type 2 alveolar cells, which are basically found in lungs. That is the reason why all the patients, those who suffer from viral pneumonia, viral pneumonitis, nowadays, it is via this receptor, this COVID-19 virus enters. And we should avoid such drugs which offers the sensitivity, which increases the sensitivity of this ACE2 receptors. So there are certain drugs which we have to avoid during the COVID-19 infection in diabetic patients, because these drugs do increase the levels of ACE2 receptors. Now, the virus may exhibit pathogenic activity by attacking type 2 alveolar epithelial cells expressing ACE2 receptors. And previous studies, basically previous studies with SARS or MERS virus have also shown that during the SARS pandemic time, this ACE2 virus has found to be the main receptors where the SARS virus entered and caused the alveoli pulmonis through surface spike protein, then caused lung damage and even lung function failure. And probably ACE coronavirus and novel coronavirus and SARS virus has almost 90% similarities, 90% identical to this SARS virus and coronavirus. So that is, we can predict that as much as SARS virus behave, COVID-19 virus also behaves in the same manner, and most probably the route of entry 90% of times in the lungs is due to these ACE receptors. And ACE2 is likely to be the cellular receptor of COVID-19, but whether it is the only cellular receptor remains to be further investigated. Now, basically, I'll talk something about this ACE2 receptors. By 2003, ACE2, when SARS virus was identified, this ACE2 was identified as a functional receptor for a severe acute respiratory syndrome coronavirus, basically, and which mediated the process of infection and transmission independent of its catalytic activity as a peptidase. And the efficacy of the infection was tenfold increased when the SARS virus was applied onto the apical surface of the cells which expressed ACE2 receptors. So this alarmed everyone. And as per the previous history also, the same method, the same methodology was applied to this COVID virus also. And it was hypothesized that as SARS virus behaved, the same way coronavirus also behaved, and in this way it attacked the lung alveolar cells, and that caused acute lung injury. Now, basically there are a lot of things to be told. The genomic sequencing, then the full genome sequence of the COVID-19 virus, which had been identified recently, and these genomic sequences has also shown that it has close relationship with SARS-like coronavirus, and as SARS behaved, the same way COVID-19 is also behaving. So basically this is the point which I wanted to say. Next. So interplay, why I want to say is that because angiotensin is converted to angiotensin 1, then angiotensin 1 to angiotensin 2, angiotensin 2 then gets converted to angiotensin 1 and 7. Now this ACE receptors is the play. Now angiotensin 2 is converted to angiotensin 1 and 7 via this ACE2 receptors, and this is the place where SARS coronavirus or COVID-19 virus also been hypothesized to attack. And when the ACE2 and when the SARS virus is attacked, when this ACE2 receptor is attacked by the SARS virus, angiotensin 1 doesn't gets converted to angiotensin 1 and 7, angiotensin 2. And when this doesn't happen, then what occurs? There is the pro-inflammatory cytokines are released, like interleukin 6, interleukin 1. All these cytokines are released. Fibrosis occurs, oxidative stress increases, and when there is an oxidative stress, endothelial dysfunction occurs, permeability increases, and vasoconstriction occurs. So all these things happens when the SARS virus attacks ACE receptors. The efficacy or susceptibility of the ACE2 increases, and this hampers angiotensin 2 to gets converted to angiotensin 1 and 7. So basically this is the point I wanted to tell about the pathophysiological condition which is causing lung injuries during this COVID-19 infection. Next. This is the same part which I wanted to say. Next. Next. So common comorbid conditions with COVID-19 infection. Basically, if a person is suffering with diabetes, hypertension, coronary heart disease, or cerebrovascular disease, the comorbid conditions, hypertension is the most common, where patient who is suffering from hypertension with COVID-19 infection, the mortality rate increases by almost 20%. Diabetes mellitus patient, the mortality rate increases by almost 16 to 20%. With coronary heart disease, it is almost 5.8%, and with cerebrovascular disease, it is 2.3%. So basically, why we should be worried of is the two main important disease, hypertension and diabetes mellitus, where if cumulative effect we see, the mortality rate is almost around 35 to 40%. So this is very important part where we have to look at the conditions. That is the reason why we always say that whenever a patient who is suffering from diabetes or hypertension, he should take proper care of himself. Next. That is the reason why diabetic patients face a higher chance of experiencing serious complications from COVID-19. And the most important complication is acute respiratory lung injury or the viral pneumonitis. Next. Now, the Research Society for the Studies in Diabetes, RSDI India, has also given us some guidance for people with diabetes on COVID-19 infection for healthcare professionals. These guidelines were given in March 2020. And as per the guidelines, I would like to tell you about the treatment protocols. Next. Now, people with diabetes are more likely to experience severe symptoms. If diabetes is well managed, the risk of getting severely sick from COVID-19 is same as the general population. And having heart disease or other complication in addition to diabetes could worsen the chance of getting seriously ill from COVID-19. And people with diabetes do face an increased risk of decay, diabetic ketoacidosis or hyperglycemia. That is the reason why we should be very much cautious about ketoacidosis problems also and hypoglycemia also. We have to make a proper balance between the average range of blood sugar levels which we want to keep in a patients who are suffering from COVID-19 with diabetes or hypertension. Next. Basically, there is no clarity between COVID-19 infection and difference in the risk between type 1 and type 2 diabetes. But type 1 patients do generally have people's the probability or the prevalence rate is not that much high. That is the reason why we target basically type 2 diabetic patients. And people who already have diabetes related health problems are likely to have worse outcomes than people with diabetes who are otherwise healthy, whichever type of diabetes they have. And most important is that people with either type of diabetes vary in their age, complications, and how well they have been managing their diabetes. That is most important. That is most important. Next. These are the when should a diabetologist or an endocrinologist should suspect COVID-19 infection? That a diabetic patient might be suffering from COVID-19. The symptoms are gradual, mild, approximately severe, mild cases or severe cases where fever almost persists since last 10 to 12 days, runny nose, sore throat, body ache, difficulty in breathing. But basically, few common things which we should follow is difficulty in breathing, cough, fever, and onset of the symptoms. The onset of symptoms are gradual in coronavirus subtles. Whereas if we talk about the general flus, which we were suffering from last several decades, the symptoms are actually abrupt and it is very acute. So we can differentiate from the symptoms whether a patient would tell you, would come and tell you that he fever of around 99 to 100 Fahrenheit was there, then it gradually increased in last 3-4 days. Now I'm suffering from cough, now I'm suffering from difficulty in breathing. So all these symptoms which we have to look for it. Next. Okay, so guidelines on national news. Why I'm showing this slide is because it is very important, which from my point of view, basically any person, any physician who is in an OPD or in a hospital sub-setup, what precautions should he take when he is consulting the patients, when he's, whether it is in OPD or in the registration counter or in the holding area or the ICU facility or the dead body packing transport or mortuary or sanitary staff. Basically, what should a person should do? A triage area in OPD where a doctor is treating in an open area where the ventilation is proper, the risk of exposure is almost moderate. So N95 masks are extremely compulsory with gloves. No need to wear the whole PPE kit. If you are in an OPD, simple N95 mask with gloves will work. Do not use gowns, do not use goggles, do not use head cover, shoe cover, anything. These two things will work. Whether you are in a registration counter or a holding area or doctor's chambers in OPD, these two things will possibly be work. But basically, those who are in ICU facilities or a dead body packing or a SARS ward or a COVID ward, then they should take proper care of themselves. That is the place where they should be using the PPE kits all the time. No need for a physician to wear PPE kits when he is looking patients in an OPD or in a triage area in an OPD. But basically, the condition should be, it should be well ventilated. It should not be in a small area, and the patient should be not be overcrowded. Patient should be minimally accessed with a proper distancing from a physician. Next. So, give suspect patient a triple layer surgical mask, direct patient to separate area and isolation room if available, keep at least 1 meter distance, instruct all patients to cover nose and mouth during coughing or sneezing, and perform hand hygiene after contact with respiratory secretions. Next. Apply droplet precautions. Basically, these are the simple methods which we all physicians should. We all know right now what are the mild precautions, moderate precautions, severe precautions which we have to take. Next, I'll directly come to the slides where we should directly come, because the time is less, where I would like to tell you about the drugs which we should use in a diabetic patient during COVID-19 infection. Next. Change the slides. Next. 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 Okay. So basically, I directly came to the point where I wanted to tell you about what are the drugs which we can use in a diabetic patients during COVID-19 infection. So firstly, I would like to tell you about insulin. Basically, insulin reduces the renal ADAM7 expression in diabetic mice, thereby reducing urinary ACE2 shedding and increasing intrarenal ACE2 expression. So, but there are no human data to support poor outcome. So the most important thing is, whenever a person who is suffering from COVID with diabetes, insulin should be used in precaution, as there are no proper data to support whether insulin is the best drug of choice to use in a COVID-19 patients. But basically, long-acting drugs are quite useful against the short-acting drugs. But a combination therapy of premix is the best protocol treatment which we should use is a diabetic patients who are on the ICU or are admitted patients. Basically, those patients who had no symptoms, or those who are not facing any respiratory distress symptoms, those who are well quarantined inside their home, basically insulin should be avoided in those patients. Insulin should be used only in those patients, those who are admitted in a hospital. And premix insulins are the best insulin which should be used at a proper rate. Now, what are the doses which should be used? Because see, basically the steroids are also used when a patient is in hospital setup, just to reduce the inflammatory markers and just to reduce the severe inflammation which occurs due to coronavirus. So basically, the amount of insulin is almost 1.5 to 2 times which a person was using before getting admitted to the hospital. That means if a person who was using 20 units almost on admission onto the COVID ward, the dose becomes around almost 32 to 35 units. That means around 1.5 to 2 times. This is the normal. Now, 35 units, 2/3 daytime and 1/3 nighttime. This is the ideal protocol which we should follow to a patient, those who are admitted in a ward. Next, SGLT2 inhibitors. Now, very good drug SGLT2, but before SGLT2, let me talk about the DPP4 inhibitors, because let's go to the next slide where DPP4 inhibitors are there. Next. DPP4 inhibitors, very good drug. Now, DPP4 inhibitors, basically, why I want to tell you about DPP4 inhibitors is because DPP, dipeptidyl peptidase 4 inhibitors, also known as gliptins, represents, these are relatively a new class of oral anti-diabetic drugs that blocks the inactivation of distal gut deprived insulinotropic hormone GLP-1. So basically DPP-4 inhibitors, they increase the half-life of GLP-1 enzymes. Now, by positively affecting glucose control with minimum risk of hypoglycemia. This is the most USP part of this DPP-4 inhibitors. Now, these drugs basically gained popularity. Why they gained popularity as a second line option for managing type 2 diabetes after metformin? Because of its cost effectiveness right now and various positive effects like minimum risk of hypoglycemia, because with sulfonylureas we had a major risk of hypoglycemia was there. Now, we all know how many types of DPP-4 inhibitors are available in the Indian, European or the Western market, and basically all of them have same specific pharmacodynamic property with potentially relative implications for patients affected by liver or kidney disease. According to mechanistic studies, DPP-4 enzyme, formerly known as a T-cell antigen, if I elaborate it, T-cell antigen CD26. Now, this was a multifunctional soluble cell-bound protease in serine protein. And they are abundantly expressed in lymphocytes and adipocytes, as well as many other cell types, including the endothelium and the epithelium, and which plays a critical role in modulation of inflammatory responses or glucose homeostasis. This is the point which I want to say is, so interestingly, DPP-4 was identified as a functional receptor for human coronavirus. This human coronavirus Erasmus Medical Center, the virus responsible for MERS, Middle East Respiratory Syndrome virus, and which genetically which was close to SARS virus, and SARS virus is genetically close to COVID virus. So that means this COVID-19 virus also has very close relationship with DPP-4 enzyme. Now, why I'm saying is, if any drug which can block this DPP-4 enzyme, or which can which any drug or any antibody which is directed against DPP-4 could impair this EMC-CoV infection, which I previously said you, EMB, Erasmus Medical Center human coronavirus. Now, if any antibody or any drug which can inhibit DPP-4 can be of great benefit to this coronavirus pandemic problem. That is the reason why I want to say, most importantly is DPP-4 inhibitors from my point of view has a very good anti-inflammatory role in COVID, and due to this anti-inflammatory role, its use of drug in diabetic patients with COVID-19 virus can help to decrease inflammatory responses also and control blood sugar level also. Theoretically, DPP-4 modulation might help offset the cytokine-mediated acute respiratory complications of COVID-19. Very important point I want to say. That is the reason why metformin with DPP-4 inhibitors right now, from my point of view, is the best drug of choice. After DPP-4 inhibitors, we can use sulfonylureas or any other drugs. But DPP-4 is the best drug of choice in COVID patients if you want to use it as a drug of choice. Now, let us go to another drug. Previous I want to say about SGLT2 inhibitors. Previous slide, SGLT2. Now, I told you about liraglutide, no, SGLT. I told you about DPP-4 inhibitors. Now, another drug, SGLT2 inhibitors, which in a recent time has gained a lot of popularity due to its positive effects on the heart, due to its positive effects on the kidneys. So, basically, SGLT2 inhibitors on glucose homeostasis, the best drug of choice. But if you talk about the COVID era, if a patient who is suffering from COVID-19 infection with diabetes SGLT2 inhibitors should be avoided, because the chances of diabetic kidney acidosis increases almost 3 to 4 times when a person who uses SGLT2 inhibitors with metformin. So DPP4 inhibitors, best drug of choice. SGLT2 inhibitors should be avoided. So theoretically, risk of poor outcome, however, no data on human pulmonary ACE2 expression, but due to its chances of DKA, diabetic ketoacidosis, SGLT2 inhibitors should be avoided. Now, let's come to next drug. Next, GLP-1. Next, GLP. Previous, GLP-1. Yeah, liraglutide. This one. Next one. Liraglutide. Now, liraglutide, why liraglutide is important? Because it upregulates ACE2 in cardiac and pulmonary tissues of diabetic rats. So theoretically, risk of poor outcome, however, no data on human pulmonary ACE2 expressions. Liraglutide or GLP-1 analogs are thought to upregulate the ACE2 receptors, but basically in cardiac and pulmonary tissues. That is the reason why liraglutide is also not a good option. Insulin basically should be used cautiously, but only on those patients, those who are admitted in COVID-19 wards or hospitals, and those who are under IV steroid doses. SGLT2 inhibitors should be avoided. Liraglutide or GLP-1 analog should be avoided because it upregulates the ACE2 receptors in cardiac and pulmonary tissues. DPP4 inhibitors, till now, best drug of choice with metformin. Next, hydroxychloroquine. Basically, hydroxychloroquine has been widely used till date because of its reduction of viral load in COVID-19 infection, but it can be considered as a third line add-on drug in patients with poor glycemic control, but should be used in very cautiously mode because the risk of QT prolongation is very high in hydroxychloroquine. That is the reason why it is kept on the third line drug after metformin, after DPP4 inhibitors. If insulin cannot be used, then hydroxychloroquine should be considered. But basically, hydroxychloroquine right now is being used to treat the COVID-19 infection also. But any patient who is suffering from diabetes with hypertension, with coronary artery disease or congestive heart disease, then hydroxychloroquine should be avoided. Its only benefit is it reduces the viral load. It reduces the viral load in the pulmonary area. The most important part, the only usage of hydroxychloroquine is it reduces the viral load. But basically, there are no strong background studies which can prove that hydroxychloroquine is a definitive treatment in reducing the viral load of COVID-19 infections. Next, metformin, sulfonylurea, pioglitazone. Metformin, I've already told you, no concern. Sulfonylureas also no concern, but sulfonylureas, due to the risk of hypoglycemia, the usage of sulfonylurea should be reduced. So metformin, DPP4 inhibitors, sulfonylureas, and insulin can be used safely in those patients who are suffering from COVID-19 infection with diabetes, hypertension, or coronary artery disease. Now, pioglitazone also should not be used. Basically, why? Because it upregulates ACE2 receptors in insulin-sensitive tissues of rats. That is the reason why pioglitazone should also be discontinued. As you diagnose a patient with COVID and you see that patient is using pioglitazone, then it should be discontinued immediately. But basically, theoretically, these are all the studies which were done on the rats. No human trials are there, but still, as we know that we don't have any foolproof data about the COVID-19 disease also. it's regulation, it's down regulation, it's up regulation. So basically we have to be theoretically up to date, and theoretically we have to follow the protocols. So theoretically pioglitazone has poor outcome, therefore it should be discontinued. But no human data is there to show that pioglitazone increases the ACE2 receptors in human pulmonary alveolar cells. Next. That's all I wanted to say today. If any questions, please, I'm open to it. Thanks a lot. I hope you liked my slides and liked my talk.
Any questions?
Sorry,
Yes, sir. You can ask.
can I raise a question?
Yes, sir.
Thank you for this nice informative presentation. What about hypertensive patient on ACE inhibitors? Where are they? They are susceptible to
Yes, the data. I'm sorry to interrupt. The data are there that the patient who had extensively using ACE inhibitors or ARBs, their susceptibility has increased in getting COVID-19 infections, basically. But there are no specific data available till date which can show that the usage of ARBs or ACE inhibitors have increased the susceptibility. But basically, we don't have any choice. ARBs are the only drug of choice, or ACE inhibitors, which we have to use it right now in hypertensive patients. But basically, initial studies have shown that it increased the susceptibility for COVID-19 viruses.
Any questions? Sir, we have got a question from Dr. Suman Hemant Chaudhary.
Yeah.
Can COVID-19 itself cause diabetes? Question mark. In this case, what is the extent of pancreatic beta cells injury caused by COVID-19? Question mark.
No, basically what happens is COVID-19 infection basically increases oxidative stress by increasing pro-inflammatory cytokines, pro-inflammatory regulators, or pro-coagulatory factors also. So basically it itself cannot cause diabetes. What it can cause is it can cause thrombolytic changes into the bloods, because it increases the procoagulatory enzymes also. So basically those patients who have been suffering from pre-hypertension, like say blood pressure of around 140 or systolic 140, diastolic 85/90, then they should take proper care of themselves, because the chances of thrombolytic the chances of cardiovascular or cerebrovascular diseases increases. Itself it cannot cause diabetes, because it has no data have till date shown us that it directly affects pancreatic beta cells, or basically it only affects the places where ACE2 are highly expressed. That means cardiac, lungs, and kidneys. Okay. What about the effect of COVID thyroid dysfunction? See, basically COVID thyroid dysfunction, no data still now about to tell you about this thyroid dysfunction, but basically Hashimoto's thyroiditis or De Quervain's thyroiditis, they probably get affected with more severity of sore throat and more severity of dry cough, basically. But these data are also very preliminary. We don't have much data to look upon that. But yes, we can say that thyroid dysfunction can occur during the COVID-19 infection, but to what extent we don't know till date.
Any questions further? Thank you very much, sir, for such informative tips. Thank you very much for your nice speech. This was a great video. Thank you sharing with your tips. Thank you very much.
Thanks
sir.
a lot. Thanks a lot.
Yes. Next we invite Dr. Mohammad Chayed Hamoudi Al Nohimi from Al Ghadi International College for Applied Medical Sciences from Saudi Arabia. Hello.
Okay, do you hear me?
Yes, yes, sir. Just you can upload your PPT and you can start your presentation.
Okay. Just a minute. Bismillah ar-Rahman ar-Rahim. In the name of Allah, the most merciful, the most gracious, before I start my talk, I would like to express my deep appreciation and thanks to the Inovine Scientific Committee for their excellent organization of this virtual diabetes conference. Is that okay, sir? You hear me okay?
Yes.
Do you see the PowerPoint as well?
No, sir. Yes. Sir.
Can you see the PowerPoint?
Yes.
Okay. Our talk will concern the triglyceride and high-density lipoprotein index as a new diagnostic biomarker to differentiate between type 1 and type 2 diabetic patient. The research has been done by Professor Muhammad Jamil Habbal and myself. Muhammad Jamil Habbal is a consultant internal medicine, MRCP UK, FRC Edinburgh, FRCP London, and he's now working in the Adel Al Medical Complex in Dammam, King, Saudi Arabia. Myself I have MBCHB from Iraq, Mosul, and I have a PhD in endocrine physiology from Newcastle upon Tyne in UK. I'm working at the moment in Al Ghad International College for Medical Sciences in Najran, King, Saudi Arabia. Today, in fact, is the 23rd of September. And this is what a coincidence, in fact. Today is also the Saudi National Day. So we dedicate this work to the 90th Saudi National Day. Introduction. Global prevalence of diabetes mellitus. The WHO estimates that diabetes mellitus was the 7th leading cause of death in 2016. The increase in the prevalence of diabetes mellitus globally is in parallel with an increase in prevalence of obesity. The global diabetes prevalence is increasing at an alarming rate. And you can see in 2009, there was about 3,000 million having diabetes as the International Diabetic Federation, while in 2018, it's about 500 million. This is a very simple table showing the increase in the alarming, in fact, increase in the diabetes mellitus. In 1980, 108 million represent 4.7%. In 2014, 422 million, which represent 8.5%, and this increased to 500 million in 2018. WHO estimate that, as you say, that the diabetes mellitus is the 7th leading cause of death in 2016, and about 3.7 million deaths occurred in 2016 from diabetes mellitus. In Saudi Arabia, the prevalence of diabetes mellitus, according to the WHO organization, Saudi Arabia is the second among the Middle East countries with the prevalence of diabetes mellitus. The second in the Middle East and the 7th globally. it is estimated that about 7 million of the population are diabetic in 2020. Furthermore, there is about 3 million who are pre-diabetic. So this will represent about 25% of the population. The point is that diabetes mellitus and obesity as well, they are increased in the younger age population. This is referred to the change in the lifestyle, diet, less of exercise, etc., etc. Diabetes mellitus, as we just said, represent about 25% of the adult population, as the latest research done by Dawish and Robert in 2020. And this faces many challenges in Saudi Arabia, including the rising prevalence, principally among children and young, micro and macrovascular complication, lifestyle alteration, delayed diagnosis, low degree of awareness, and the expensive cost of the treatment. This is a simple table which shows the increase in about 10-fold of diabetes mellitus in the 80s in comparison with the 2020, from 2.5 to 25%. This is, in fact, an alarming increase rate. And they suggest that in 2030, 50% of the adults will be suffering from diabetes mellitus. As you just said, you can see that about 2%, 2.5% in 1982, which increased gradually up to, which might reach to 50% in 2030. Diabetes mellitus. Diabetes mellitus initially considered, as you know, as a carbohydrate metabolic disease, but now it is described as a disorder of multiple etiologies, with disturbances of carbohydrate, lipids, as well as the protein metabolism. Diabetes mellitus, especially type 2, is associated with dyslipidemia, and now it is nominated as diabetes mellitus, which, as you know, will lead to atherosclerotic vascular disease. So it is considered at the moment as well as a cardiovascular disease. According to the latest American Diabetic Association, type 1 diabetes mellitus and type 2 are heterogeneous disease in which clinical presentation and disease progression may vary considerably. Classification is important for determining therapy, but some individuals cannot be clearly classified as having type 1 or type 2 diabetes at the time of diagnosis. The traditional paradigm of type 2 diabetes mellitus occurring only in adults and type 1 occurring only in children are no longer accurate, as both diseases occur in both age groups. To differentiate between, as we just said, type 1 could occur late in adults, or type 2 could occur in children and young. So we have to have something to differentiate between the two. So there are a diagnostic marker, especially C-peptide and autoantibodies, to differentiate between the two. There are mainly 4 autoantibodies which occur in type 1 diabetes, as the islet cell antibody, autoantibodies to glutamic acid decarboxylase, GAG, insulin autoantibody, and insulin autoantibody to protein tyrosine phosphate And there is some others, but these are the main, in fact. Material and method. The hospital lab measure these items using the kits from these companies. We depended on the American Diabetic Association to diagnose diabetes mellitus. As you can see, hemoglobin A1C less than 5.7 considered as normal, more than 5.7 up to 6.5 pre-diabetic, and above is diabetic, and so on. Fasting plasma glucose less than 100 milligram is normal, 100 and more up to 126 is pre-diabetic, and more than 1 to 6 milligram per deciliter of diabetic. And oral glucose tolerance test less than 140 is considered as a normal, while more than 100 equal or more than 140 up to 200 milligrams is pre-diabetic, more than 200 are diabetic. So also we follow this American Diabetic Association in the diagnosis of our patient. The normal lipid profile, also according to WHO and the American Diabetic Association, you know, these the triglyceride should be less than 150, LDL should be less than 100, total cholesterol less than 200, high density cholesterol, if it's low, should be below 40, and as a normal or high, more than 60. Statistical analysis, we use the SPSS software version 20, independent samples t-test was used, and data are expressed as mean and standard deviation, as you see in a few seconds. The aim of this work, in many areas in the world, these diagnostic autoantibodies are unavailable, or the results will come after weeks, which will delay the diagnosis and the choice of a treatment. Therefore, we have to think for an alternative diagnostic marker that is available in almost all diabetic clinic and hospital, which could differentiate between the odd cases, as we just said, type 1 in adults or type 2 in children and young, in odd cases of type 1 and type 2. Furthermore, the diagnostic autoantibodies are very expensive, while triglyceride is very cheap. In fact, some of the patients, they don't have medical insurance, and when they go to do these tests, it's expensive. They refuse to do it. So this will give us a problem. Result and discussion. In this research, we use the measurement of triglyceride and the high-density lipoprotein as a diagnostic parameter to differentiate between type 1 and type 2. We have found that in the newly diagnosed diabetic patient, the level of triglyceride is significantly high. P-value is less than 0.001 in 61 type 2 diabetic patients, of course, after excluding other causes as thyroid disease. In comparison with 20 type 1 diabetic patient, while high density lipoprotein is significantly low in type 2 in comparison with type 1 patient. But there were non-significant differences in the level of fasting blood glucose, hemoglobin A1C, cholesterol, and low density lipoprotein in both types. And this table will show that the main significant difference between type 1 and type 2 is triglyceride. You can see type 1 about 70, while type 2 about 236. Very high level of triglyceride in type 2 in comparison to type 1. And also, very low level of HDL in type 2 in comparison with type 1, while the other are non-significant difference, LDL, cholesterol, hemoglobin, A1C, fasting blood sugar. In the current result, lipid abnormalities in type 2 diabetes mellitus, specifically the high level of triglyceride and the low level of HDL, are in agreement with almost all the previous investigators, as such and such. In fact, our result is not a new finding. It's agreed with almost all the research concerning the diabetes mellitus. In a newly diagnosed type 2 diabetes mellitus, we demonstrated a significant increase in triglyceride and a decrease in high-density lipoprotein, while there were non-significant changes in the level of cholesterol, LDL, in comparison with the normal control. You can see these are the control, and these the type 2 diabetes. You can see the very high level of triglyceride in comparison with the normal, and the low of high-density lipoprotein in comparison with the normal, while there is no significant difference in cholesterol and low-density lipoprotein. Also, we done a comparative study between type 1 and the normal control individual. The level of cholesterol and low-density lipoprotein were non-significant in type 1 diabetes mellitus in comparison with the normal individual, while triglyceride was lower, significant in type 1 diabetes mellitus, and high-density lipoprotein was significantly higher in type 1 in comparison with the normal individuals. As you can see in this table. As you can see here, that high triglyceride, so our main concept, triglyceride. Triglyceride in the control, 98. In type 1 is 69, or say 70. So significantly lower. High density lipoprotein, significantly higher. While cholesterol is lower, non-significant, yes, and also LDL is lower but non-significant. This will give us the impression that patient in newly diagnosed type 1 diabetes mellitus, the patient showed lower concentration of atherogenic lipid like cholesterol, LDL, and triglyceride. While on the other side, it shows a higher concentration of anti-atherogenic lipid, as HDL. And this also in agreement with the most of other previous investigators, as shown in the following table. But put in your mind, you will say it is well known that type 1 diabetes mellitus has dyslipidemia. Yes, but this is usually not a newly diagnosed. This is usually in the chronic and poorly controlled type 1 diabetes mellitus, we have the dyslipidemia. But in the newly diagnosed type 1 diabetes mellitus, as we will see in the following table. As we say, we are not presenting a new data. Our data is quite in agreement with the previous studies. But as you can see, triglyceride in comparison with the normal in type 1 is low since studies in 2005, 2009, 2010, 2020, and the current study. But in our current study, in fact, you find lower significant. Here, lower, 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 but not significant. And as well, high density lipoprotein, higher in type 1 diabetes mellitus in comparison with the normal control. And also, we found a significant higher, and only one study is also found a significant high HDL. Cholesterol, low, low, just one study high, low, low, LDL, low, 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 low. So as we just say that there is a decrease, low concentration of atherogenic lipid in type 1 and increase in anti-atherogenic lipid. We have also followed up our patient for 6 months, especially type 2, 34 patient type 2 diabetes mellitus after anti-diabetic therapy. And you can see that triglyceride is the main lipid which demonstrates a significant reduction after 6 months follow-up, while there is a non-significant difference in HDL, cholesterol, and LDL. Pre and post treatment of type 2 diabetes, after follow-up of 34 patients with type 2 diabetes, there were a significant reduction in triglyceride, p-value 0. After treatment with anti-diabetic therapy, only here we have to stress that no anti-lipid therapy, is only anti-diabetic therapy, while no significant difference in HDL and other. Oral anti-diabetic drugs are not only affordable and effective hypoglycemic agent, but can also decrease serum lipid and thereby aid in the prevention and minimization of atherosclerosis and cardiovascular complication in type 2 diabetes mellitus. Well, in conclusion, although the lipid profile in type 1 and type 2 diabetes mellitus has been reported in many papers, our results is not a new result, but none of previous report has used this lipid variation as a diagnostic parameter between type 1 and type 2, especially as in our cases, as we just said in the beginning. Triglyceride as an early parameter to differentiate between type 1 and type 2. Differentiation between type 1 and type 2 diabetes will provide an opportunity for early intervention and the choice of treatment. While furthermore, after follow-up of type 2 diabetic patient, after treatment with only anti-diabetic for 6 months, we concluded that as well, triglyceride can also be used as a parameter for improvement and control of the disease. In type 1 diabetes mellitus, high fasting blood glucose, high hemoglobin, but low triglyceride, which is a reciprocal correlation. While in type 2 diabetes mellitus, high fasting, high hemoglobin A1C, but also high triglyceride. And this is a parallel correlation, which is just the opposite. Increase in triglyceride with severity of type 2 diabetes mellitus and vice versa has been demonstrated after treatment. The more uncontrolled type 2 diabetes mellitus, the more high level of triglyceride. And After control with antidiabetic, there is decreased blood glucose and decreased triglyceride. Therefore, after follow-up of type 2 diabetic patient for 6 months, we concluded, as we just said, that triglyceride can also be used as a parameter for improvement and control of the disease. And almost finally, it seems that triglycerides start to be elevated in as well prediabetes. It could indicate that elevated triglyceride is a warning sign to the development of type 2 diabetes mellitus, i.e., we can detect, diagnose cases of prediabetes by the elevated triglyceride. And the WHO recommend to start anti-diabetic treatment in prediabetes and treat them as a diabetic patient. Therefore, the elevated triglyceride is an indication as well for treatment of pre-diabetic patients. In our pre-diabetic cases, which is not reported in here, we noticed that only triglyceride is elevated. And thank you very much. Any question, please?
Any questions? Any questions? Okay. Thank you very much, Doctor.
You're quite welcome.
You want to compliment on your topic. Thanks for sharing your tips with us. Looking forward to meeting you next time.
Thanks.
So now we will have a short break for 5 minutes and rejoin the event again. Meanwhile, we asked Dr. Nazarian Ghazil to prepare with a PowerPoint presentation. After 5 minutes, we will rejoin the event again. Hello. So we are going to continue the program, sir. Now we ask to Dr. Nazreen Ghazil from Dr. Sulaiman Al Habib Medical College from UAE to join the event and start a presentation.
Hello, good afternoon.
Yes, yes. Is it your PPT, madam?
Yeah, I will share my slides.
Yes, yes.
Is it showing?
Yes, yes.
Okay, so will I start?
Yes, 1 minute now. Yes, yes, madam. You can continue. Almost all everybody joined.
Okay. So good afternoon. Thank you very much for the invitation. Thank you for connecting. I'm presenting now about gestational diabetes, and we're going to focus mainly on the updates in the literature and what does the future hold in terms of innovations and updates. So originally I come from Beirut, Lebanon, and I'm currently working in Dr. Sulaiman Al Habib in Dubai, UAE. However, I started my career in an OB clinic, and hence I gained the interest in gestation and diabetes and thyroid in pregnancy. This is a very brief outline of what we're going to discuss today. The prevalence, pathophysiology, some risk factors, prevention, screening, where are we in terms of OGTT, management, and we're going to touch very lightly upon complications. So basically, gestational diabetes is any diabetes that diagnosed basically in pregnancy, but mainly second and third trimester, that was not clearly overt diabetes prior to gestation. So any A1C at an early pregnancy of more than 6.5, or any OGTT 2 hours more than 200, or any symptomatic fasting sugar of more than 126, this would qualify as overt diabetes. Gestational diabetes affects around 6 to 10% of the pregnancy in the USA. And there's like a 35 to 60% risk of developing type 2 diabetes in the coming 10 to 20 years. And we all know the number, like 50% of them will likely develop diabetes type 2 in the next 10 years. This is some International Diabetes Federation data that shows that GDM is the highest in Southeast Asia, followed by Middle East and North Africa, followed by Europe, and then Africa. This is some CDC number showing the increasing gestational diabetes by age, of course. So women more than 40 who are pregnant, 13% of them will have a likelihood to develop gestational diabetes, according to this 2016 data. Other risk factors were not very different in terms of percentage, but then we go to obesity. As obesity class increase, as the risk of gestational diabetes increase, and women who have a BMI of more than 40, almost like the biggest percentage, a big percentage of them, around 14%, they would develop type 2 diabetes. And we're going to touch upon obesity many times in this presentation. Just for research purposes, gestational diabetes has been divided into an A1 gestational diabetes, means treated by lifestyle, and this is almost 80% of gestational diabetes. And A2 gestational diabetes requiring pharmacotherapy, being injectables or oral antidiabetics. Then moving on to pathophysiology. So if we're going to ask if gestational diabetes looks more like a type 2 or a type 1 profile diabetes, definitely we're going to go to type 2. But despite that, there is some pancreatic beta cell dysfunction or a delayed response of the beta cells to the glycemic levels. And this is mainly seen in phase 2 insulin secretion, and mainly in obese pregnant women with diabetes. So this second phase of insulin secretions that starts at least 10 minutes after food is enhanced in obese patients with gestational diabetes. And hence we see some pattern of very high blood sugar directly after meal, probably because of a lower phase 1 and some hypoglycemia later after the meal, probably because of an overshooting phase 2. But the main mechanism will be a marked insulin resistance, secondarily to placental hormones. Mainly, we're talking about the human placental lactogen, the HPL. But other hormones will also play a role, such as growth hormone, prolactin, CRH, progesterone, etc. And the way they act is mainly through insulin resistance and secondarily hyperglycemia. But the main actor here is the HPL. HPL is a growth hormone-like. It diminishes glucose uptake at the peripheral tissue, causes molecular alteration of the beta subunit insulin receptor, causes diminished phosphorylation of the tyrosine kinase, and remodeling in the insulin receptor substrate, and phosphatidylinositol triphosphate kinase. This is a very nice diagram that shows a pregnant woman without GDM in green and pregnant woman with GDM in orange. And we see that at baseline, pregnant women who will develop gestational diabetes will have more non-functional and insufficient levels of insulin, so they're like more prone to hit this threshold of developing hyperglycemia. And then there are alarming numbers about the risk of developing gestational diabetes in a second pregnancy if we had a gestational diabetes in a first pregnancy. And the average is 60% of those women will develop again GDM in the second pregnancy. And now we have a lower threshold even and more insufficient and non-efficient insulin. And thus, after the second pregnancy, we're very close to the threshold of developing diabetes. This, of course, assuming a high glycemic index diet, a sedentary lifestyle, genetic factors, etc. Now, a very nice diagram also, we will start here at the placental hormone levels. So placental hormone secretion coupled with genetics, because genetics are linked to developing gestational diabetes, and a lifestyle mainly of high glycemic index food and sedentary lifestyle, will cause a state of insulin resistance, which, if not compensated, will cause hyperglycemia. Glucose goes to the fetus. High glucose in the fetus will trigger hyperinsulinemia in the fetus, and this is where this fetal programming starts, and the risk of developing metabolic syndrome starts as early as this phase. Just to note that insulin does not cross the placenta, nor in nor out. We talked about the beta cell problems in gestational diabetes, but we should not forget the inflammation role. A higher BMI causes a low state of chronic inflammation, and this is manifested repetitively by a high leptin, high TNF-alpha, and low levels of adiponectin. Chronic inflammation will secrete xanthuronic acid. Xanthuronic acid is a diabetogenic agent. It just antagonizes insulin and therefore predisposes to gestational diabetes. So we have two main pathophysiological events, insulin resistance and inflammation. Moving on to risk factors, we start with the basics. Overweight, we talked about overweight and we will talk again. Polycystic ovary, preeclampsia has been shown to be an independent risk factor to develop gestational diabetes. Stress, antidepressant use, many research about genetics, and some genes are linked to our predisposition to develop gestational diabetes. Age, again, for every successive year after 18, the risk of gestational diabetes increases tremendously, like 7.90% for Asians, 12.7% for European, etc. Obesity, again, pregnant women who are obese or overweight are much higher risk to develop diabetes. And then the prevalence of GDM would be 0.7% for a normal weight, 2.3% for overweight, 4.8% for obese, etc. And then we saw that the obesity class also increases the risk of GDM. More importantly is central obesity. And we know the classic link between insulin resistance and central obesity. And here we're presenting a meta-analysis of 11 articles by Yao et al. of 27,675 pregnant women, showing that all those with GDM, not all those, like mostly those with GDM, they had central obesity, and the odds ratio was plus 2.76. Sleep. Sleep has been studied as a risk factor. Indeed, a short sleep duration during pregnancy was not associated with the risk of GDM, mostly, and this is different from a type 2 diabetes, but a long sleep duration was associated with the risk of gestational diabetes. And here I'm referring to this study that I put in the reference of 18,203 patients meta-analysis. Vitamin D. So many studies on vitamin D. And here I'm presenting a late one of 53 articles showing that gestational diabetes patients have lower vitamin D, and there's a negative correlation with the HOMA-IR. Again, gestational diabetes patients, lower vitamin D. So again, with the risk factors, now we have obesity, we have vitamin D. I just mentioned selenium because of this interesting study. This is a meta-analysis of 6 observational studies showing that selenium, the essential trait element with a role as antioxidants such as glutathione peroxidase, has some anti-diabetic functions. And therefore, this meta-analysis, and I emphasize those were only observational studies, showed that gestational diabetes patients have lower levels of selenium. Therefore, here we stop and we see what are our opportunities to break the cycle and not to develop gestational diabetes. We start this young woman with diabetes, or she's at high risk. Our first window to prevent this is to prevent obesity, polycystic ovary, maintain a healthy BMI, a normal blood pressure. If this is not met, then she will develop gestational diabetes, possibly or not. Then at the level of gestational diabetes, we have a second window of opportunity, which is to control hyperglycemia in pregnancy. And this, not to have the infant exposed to high levels of sugar and subsequently producing much insulin. And this is an epigenetic and genetic predisposition to obesity and diabetes in the adulthood. After that, when the baby of a gestational diabetes woman is born, we have the third opportunity to break the cycle, and that is to prevent obesity and diabetes in toddlers and in the youth. Now, this is interesting. Leptin. Leptin, our commonly known satiety hormone, can act as a metabolic switch. So, leptin is produced by the placenta and centrally, mainly in the hypothalamus. Obesity causes inflammation, mainly hypothalamic inflammation, which will mediate leptin resistance. So therefore, the obesity, which will trigger this leptin resistance in its turn will act for the mother through this JAK2 STAT3 pathway and causes more insulin resistance and hyperglycemia, and therefore gestational diabetes, but also have a direct effect on the placenta, causing and mediating macrosomia. And here there are those studies and the big roles of all those anti-inflammatory food that will break this leptin resistance and improve secondarily hyperglycemia in pregnancy, mainly polyunsaturated fatty acids, coffee bean extracts, probiotics, lycopenes, which are like the red colors that's found in fruits and vegetables. Mediterranean diet has been found to prevent and control gestational diabetes more than other diets, and polyphenolic compounds such as berries, vegetables, legumes, tea, etc. So anti-inflammatory diet. Gut microbiota. Some of them are associated with higher risk of gestational diabetes. For example, a higher number of bifidobacterium species and lower proportion of staphylococcus species. This shift is more pronounced in obese pregnancy and in women with overweight gain during pregnancy. And then we're going to talk about probiotic role to prevent this. Pollution. This is a strong risk factor for gestational diabetes. I'm presenting this meta-analysis of 33 cohort studies showing the association between SO2 exposure in the first trimester and gestational diabetes. How to prevent that? It goes without saying, exercise. 100 minutes of moderate to vigorous will reduce it to by 9%, highest probability and biggest impact in obese women. Myoinositol, this is heavily used by obstetrics and gynecology. It's a polyol. It's a pseudo-vitamin, and we call it the vitamin B8, and it's produced from D-glucose from the liver, kidney, and brain. It has an insulin-like effect on metabolic enzymes and naturally is found in beans, nuts, and cereals. However, the highest concentration is in citrus fruits, vegetables, and some food, including seed. Now, if you want to take it from outside, like chemically, this is a review of RCT showing that myoinositol supplementation at 2 grams per day will reduce the rate of GTM in both overweight and obese, as well as in those with a family history of gestation and diabetes. So this is a good way to prevent GTM in high-risk patients. Again, on probiotic, naturalization of the gut microbiota will increase intestinal permeability, regulate pro-inflammatory mediator, controlling the inflammation, improves glycemic control in pregnant women. So probiotics, myoinositol, exercise, and now metformin. Those, and I have repetitive trials on metformin for prevention, and I'm presenting also a late one of 11 eligible trials, showing that metformin had no effect in preventing gestational diabetes alone. And this might seem counterintuitive, but it's repetitive in many trials. Screening. Now the big hub on screening is that the research is trying to avoid this OGTT that is quite bothersome to most of the patients. And they emphasize here early screening rationale because they think that some women are really underdiagnosed as having any glycemic impairment or even type 2 diabetes at the beginning of pregnancy. And here, the ADA focuses on high-risk patients that should be screened early on for gestational diabetes or any glycemic problem. So first degree relative with diabetes, high blood pressure, low HDL, high triglycerides, PCO, physical inactivity, pre-diabetics, previous history of GDM, etc. So early screening to detect mostly previous glycemic non-control. What about A1C? When done at less than 20 weeks, and if it's more than 5 or 7, and then this patient should be taken care more because she has a higher risk of gestational diabetes. But more than 6% in this study identified all those with gestational diabetes, and this can be a good marker. CRP, we know it's high in obesity. Most studies showed correlation with gestational diabetes. It can be a marker. It's non-specific. New studies about branched-chain amino acid, leucine, isoleucine, valine. Abnormal levels were found in diabetes in metabolic syndrome. However, this meta-analysis showed higher rates in GDM, but had studies heterogeneity. Moving on. Some molecular markers, all those are just trying to avoid the OGTT, make a more simple tool to diagnose GDM and an earlier tool. Molecular markers like SNP, single nuclear polypeptides, DNA methylation, and microRNAs are mainly expressed in the blood, so it's a blood study. Many studies provided evidence to support those as the use for GDM. All are impacted, however, by ethnicity, environmental factors, and need more refining studies. So we all know the basic OGTT. We have the one step that is backed up by the ADA, the Endocrine Society, that needs fasting. It's a 75 grams of sugar that and a 2-hour test. And then we have the 2-step tests. One should not be fasting. The first one, the 1-hour test, the cutoff will be from 130 to 140. And then if positive, we do the 3-hour test. This is backed up mainly by ACOG. Now, also touching upon the presentation of Dr. Muhammad, triglyceride glucose index have been interestingly showed that it can be a marker of gestational diabetes. And this is a study of 140 patients showing that this index has an 89% sensitivity of detecting gestational diabetes. The problem in those who had bariatric surgery before, those are very prone to hypoglycemia. They have a higher rate of small for gestational age because they have more hypoglycemia and less insulin. And also the OGTT for them, 90% of them will develop a 3-hour hypoglycemia. Therefore, for those patients, we recommend just checking the sugar during 3 to 7 days at 24 to 28 weeks of pregnancy and using glycemic targets based on the AGA. CGM, continuous glucose monitor, is mainly used when there is too much variation and that we cannot conclude what to change in the treatment of the patient, and this is endosociety. For glycemic variation, we just mentioned it's better to use CGM. Other ways to decrease glycemic variation, a low GI diet, dietary consultation, and some studies on myoinositol. Management, we all know this famous table about how much a pregnant woman should gain weight if she has gestational diabetes and then decreases as the weight increases. Omega-3, interestingly, has shown to reduce fasting plasma glucose and improve glycemic control. So this can be part of the management. And this is a meta-analysis of 4 RCTs. Low glycemic diet, a glycemic index diet, goes without saying, improves glycemic control. Exercise, at least 20 to 50 minutes, a minimum of 2 times a week, moderate intensity will ameliorate the glycemic control. Despite all the studies on oral antidiabetics, as per ADA 2020, insulin is still the first line to treat gestational diabetes. I'm going to talk about metformin concerns, why it's not the first line, because this is what's been used daily in the clinic. Metformin is mostly seen as first line. Now here there is starting doses. We're not going to go into them. Basal insulin dose, 0.2 units per kilo per day, and then it increases per trimester. This is the same table showing the requirements of insulin per trimester and how it increases slowly. Metformin, and this is one of my take-home messages. Children that are exposed to metformin are heavier and taller than those exposed to insulin. At 2 years, they also showed higher metabolic risks. By 9 years, they have larger waist circumference, largest waist to height ratio, BMI, and tricep skin fold. And those were comparing gestational women treated with insulin to gestational diabetic women treated with metformin. Also, up to 9 years, children treated with metformin were heavier than control. There's a theory that this metformin is interfering with fetal programming. True, it's beneficial during pregnancy in terms of preventing pregnancy-induced hypertension, large for gestational age, maternal weight gain, fetal hypoglycemia, and the patients are more satisfied if they're taking an oral antidiabetic. But long-term effects require more study and should be kept in mind whenever we see a patient with diabetes and pregnant. For the starting dose, and this is ACOG, is 500 milligram every night for 1 week, and to increase slowly, checking baseline creatinine for a maximum dose reaching 3 grams, which we usually do not use in clinical practice. Glyburide should not be used in place of insulin. Starting dose 2.5 to 20. The concerns are macrosomia and birth injury, and up to 30 milligrams is okay. Usually we give it to patients who are intolerant to metformin, who do not want insulin, and who have an acceptable fasting blood sugar. The last slide about complication. So many complications are known for the fetus, for the neonate, for the child, for the adult. But here I want to focus about the mother. The mother who had gestational diabetes should be followed very closely throughout after delivery with an OGTT first at 4 to 12 weeks and then every 1 to 3 years thereafter. It has also been shown that she's at high risk for diabetes, and we know that, but she's at a higher risk for atherosclerosis. And this woman, and that we say the pregnancy is a window to the later health, should be followed maybe a bit more closely in terms of metabolic risk factors than other women. So gestational diabetes, finally, is highly and increasingly prevalent. It's mediated by insulin resistance and an inflammatory state. Known risks include high BMI, polycystic ovary, preeclampsia, low vitamin D, genetics, and air pollution. There's a potential to break the loop. prevention through healthy lifestyle, through exercise. There's room for myoinositol for prevention, for probiotics to normalize the gut microbiota. Studies favoring early screening on the way, not yet in the universal recommendation, branch-chain amino acid, molecular markers, early A1C, triglyceride over glucose ratio. We're trying to head towards a simple test as compared to the bothersome or the cumbersome OGTT. First line after low glycemic index diet and exercise remains insulin. OAD, oral antidiabetics, more patient satisfaction, but more risk, and specifically later on in life. Metformin interferes so far as we have data with fetal programming, and women with gestational diabetes should be followed up regularly postpartum and every 1 to 3 years thereafter. Thank you.
Any questions? Any questions to Dr. Nisrain?
Sorry.
Thank you.
Hello.
Hello.
Yes, sir,
No.
you can.
So there is, you may thank you for this interesting and
Thank you.
informative presentation. But you mentioned interesting thing which is comparable and corresponding to our study about triglyceridemia.
Exactly.
So can you, yes, can we use this parameter also for early diagnosis for early diagnosis of gestational diabetes?
Yes, so the study had around 140 patients, and they compared the triglyceride over sugar. And since the pathophysiology of gestational resembles more type 2 diabetes, they found a higher ratio as compared to patients who don't have any gestational diabetes. Sensitivity was very remarkable, 89%. Specificity was low, but they had a very high negative predictive value, up to 93%. So if this is negative, we are almost sure that this patient has no abnormal glycemic control during pregnancy.
Okay, so it is useful.
It's very useful actually, but it's still not in the ADA or in the Endo Society or recommendations.
Can you make it clear whether metformin is better than insulin? I didn't understand your conclusion about this point.
So actually, so far, the first line is insulin. Insulin for all the patients, starting with basal, usually detamir, and adding rapid insulin if the sugar postprandial remains high. Metformin is mainly used for those that are refuse insulin idea, and that's it, with high fasting sugar. And those are mainly at risk maybe for overweight. But in the recommendation, if we have a patient in front of us, we will try to convince the patient for insulin before heading to metformin if we face any resistance.
Okay, thank you.
Thank you.
Yes, doctor. We have hand raised from Dr. Ravi Mupirala. Any questions, sir?
One moment.
Yes, sir.
I was just going to remark that, in line with my talk, exogenous insulin also might create some issues also for the progeny. But again, this needs more studies because essentially the underlying phenomena is hyperinsulinemia. And so anyway, we can talk more later on this. But this is very interesting because it shows the connection between epigenetics and causing hyperinsulinemia early in life can also have repercussions. Yeah.
Thank you. So we will be waiting for the talk.
Yes, sir. We got a message from chat from Dr. Ravi Mupirala, excellent. Dr. Magdi Alam, excellent. Dr. Sumain Rahman, Chaudhary, excellent presentation. Okay, thank you very much,
Thank you
Doctor.
so much. Thank you.
Thanks, Doctor. We have enjoyed your speech. Pleased with your
Thank you.
topic.
Same here. Thank
Looking forward to meeting you again next time.
you. Sure.
Now we ask Dr. Suman Chaudhary from Chattagang Diabetic Center Hospital from Bangladesh to join the event and start presentation. Yes.
Good afternoon, everyone. Can you all hear me?
Yeah, yes, sir.
Firstly, I'd like to thank the organizers, Inovine Conferences, for giving me an opportunity to present my paper today.
Thank you.
My topic is on the risk factors for depression in Chinese youth population with untreated Graves' disease. It's a retrospective as well as a prospective observational study. I'm Dr. Shuman Rahman Chaudhary from Chittagong Diabetic General Hospital, Bangladesh. It's 10 o'clock at night here right now. I guess it's afternoon there in the States and Middle East. So firstly, I would like to acknowledge where I've conducted my study. This study was supported by the National Natural Science Foundation and the China Postdoctoral Science Foundation grant of Shandong University. You can see a picture here of my university where I completed my master's in endocrinology. And the study was conducted in Chilu Hospital, which is one of the biggest hospitals there in the Shandong province. On the right side, you can see where I currently work in. It's Chittagong Diabetic General Hospital. It's a 150-bed tertiary hospital. We deal with diabetic complications and consultations, as well as endocrine consultations. We have a whole diabetic medical team consisting of nephrologists and diabetologists, dietitians, and others. So today's agenda is pretty simple. I'm going to talk about an introduction, methods and materials, the results of the study, and discussion, and the conclusion. So in order to start my introduction, I'd like to talk about Graves' disease. We know that Graves' disease is one of the most common forms of hypothyroidism. In fact, 100 to 200 cases are present every 100,000 patients per year. Especially in the US, you can see that it's almost up to 1 in 200 patients suffer from Graves' disease as a consequence of hypothyroidism. Mostly female. We know that it's around 7 to 8 to 1 female to male ratio. And the highest prevalence is in the 20 to 40 years groups. And the younger groups, that's mostly where we have done our studies. So patients with Graves' disease usually present with psychiatric symptoms. Those include emotional instability, impatience, irritability, insomnia, restlessness, nervousness, etc., weight loss. And in elder patients with Graves' disease, depression or the coexistence of anxiety and depression were observed. So in most of the cases of GD, especially in young cases, we see more of the neuropsychiatric symptoms. But in older patients, we see more of depression as well as depression and anxiety as a whole, and some bipolar disorders too. So 15.2% of the patients still showed mental disorders, even ones who were believed to be euthyroid. So even though they were euthyroid, 15% of the patients still showed signs of depression and other mental disorders. In fact, in some studies, 50% of the patients actually had elevation of symptoms, improvement of symptoms after the improvement of Graves' disease. And 34.6% actually had some mild improvement of symptoms. So there are some promising studies that are being conducted there. And 350 million people around the world suffer from depression. That's quite a high number. I was just researching through that and found out that almost 20% of the world population is suffering from depression. And especially during this COVID era, first I'd like to recall those healthcare professionals that have given their lives for serving the patients. In Bangladesh, we have lost already over 100 doctors and other healthcare professions. 3,000 healthcare professionals are already suffering from COVID. Day by day, this number is increasing. And depression also, post-COVID depression is also very much prominent now. So the incidence of depression in patients in hypothyroidism in different studies was 31 to 69%. So it's quite a high number. So the materials and methods, what were the objectives and subjects? Now the basic aim of the study is to find out the risk factors for depression in Chinese youth population with untreated Graves' disease. So these people were randomly collected with the Graves' disease, the newly diagnosed Graves' disease, and we looked at the what are the risk factors in this youth population. So basically, patients, around 1,158 young patients and outpatients over a course of 10 years, from 2008 to 2018, we conducted the study. According to WHO criteria for young patients, we analyzed patients from 14 to 45-year-old patients, newly diagnosed, untreated Graves' disease in the hospital, in the Chilu hospital that I was talking about in China. And there were 261 males as opposed to 897 females. So the male to female ratio was around 1:3.4. Obviously, there were more female patients in the study. Like I mentioned, that the prevalence of Graves' disease in females is almost 7 to 8 times higher than in males. The inclusion criteria involved typical clinical manifestations of GD. We know what are the typical clinical manifestations: nervousness, irritability, emotional distress, and others, weight loss. And the thyroid functions were assessed. The level of FT3 greater than 8.5 picomole per liter, or level of free tetrahydrotilene, or FT4 greater than 25.5 picomole per liter, the level of TSH less than 0.5 IU per ml, and the level of TRAb greater than the thyroid receptor antibodies greater than 1.75 international unit per liter. The latter two were essential conditions. The TSH and the TRAb were essential conditions. The exclusion criteria, we excluded other causes of thyrotoxicosis like thyroiditis and others, and all subjects that had not used anti-thyroid drugs and depression-related drugs, so previously not treated for hypothyroidism or depression, and a history of thyroid diseases and mental diseases. These were excluded. The epidemiologic data was collected, and demographic characteristics including gender, age, marital status, occupation, education level, income, alcohol consumption, smoking, family history of thyroid diseases, and the body mass index and other demographic characteristics were collected from the patients. And the thyroid functions were assessed. The FT3, FT4, TSH, and TRAb was measured in fresh fasting plasma. Almost 3 ml blood was collected at 8 to 10 a.m. Electrochemiluminescence actual immunity analyzer was used, Alexis 2010. That's the machine that we used. Intra-assay and inter-assay coefficient of variability was less than 10%, so less chance of error. And proptosis was accessed using a Hertel exophthalmometer. We did this in a collaboration with the ophthalmology department of Chilu Hospital. And the diagnosis of Graves' ophthalmopathy or orbitopathy, Graves' orbitopathy, was confirmed in patients with no specs 2 to 4, according to no specs classification. We use the no specs classification here. And the goiter size was graded according to the criteria recommended by WHO, grade 0, 1, and 2. Family functioning, we use the APGAR questionnaire. APGAR basically stands for adaptation, and growth, and affection, parenting, as well as resolve, partnership, as well as resolve. And it was a closed questionnaire, is designed by Smilstein in 1978. Life event stress was assessed using the normal Chinese life event stress questionnaire, done by the China Scale Cooperative Group in 1987. And of course, the depression was accessed using the Hamilton Depression Scale, which is the most commonly used depression scale. According to the demarcation criteria, depression was confirmed when the score was greater than 20 points. So this is basically the results, the distribution of the socio-demographic profile in Hughes disease patients with depression. Now, if you look at the age, we basically confined them to 4 different age groups. One is less than 20. The other one was 20 to 30, 30 to 40, and 40 to 45. And different number of subjects in the male and the female. And we looked at the number of patients with depression and the prevalence of depression in all age groups from 20 to 45. And what were the results that we found out? That we found out that in male patients, and specifically in male patients, we see a higher incidence of depression in the lower age group, less than 20, as opposed to the female. You can see 38.5% as opposed to 10%. When the ages were increasing, we see a negative correlation. We see more female patients suffering from depression in the 20 to 30, in the 30 to 40, and the 40 to 45 age group. Here you can see the highest number of patients with depression were in the 40 to 45 age group, And especially in the female group, you can see 79.8% in the female group of 40 to 45 as opposed to 53.2%, which was statistically significant. Also in the 30 to 40 age group, you could see higher incidence of depression, almost 64.4% for females as opposed to 56.9% for males. So most statistically significant in the 40 to 45 age group. Marital status also played a role in the formation of depression in patients with Graves' disease. We looked at unmarried status, patients that were married and patients that were divorced. And here we can see the highest incident of cases of depression, especially in the divorced group. Here you can see in the females, almost 74.4% as opposed to 68.9% in the males. And the lowest was also obviously in the unmarried group, where only 24% females and 30.3% males suffered from depression. So marital status and age, we could see there's statistically significant differences. Education level also plays a role when we look into the parameters for depression. And here we looked into junior school, those that graduated from junior school, those that graduated from senior middle school, those that graduated from college, and those that have finished their post-graduation. And the results that we can see over here, that the majority of the patients who have a lower educational background suffered more from depression. As you can see over here, almost 59.8% females and 58.1% males, as opposed to, if you see those in the postgraduate group, you can see a lot less, 39.6% in the female group and 21.7%. But later on, we did a logistic regression analysis, and then we found out that education did not exactly, was not in the forefront of depression, and it could be related to social habits and basically genetic ethnicities. The income was also taken into consideration. People with substantially low income, here we have given the currency in yuan. 1,240 yuan is equal to around $180 per month, which is a very low income status. And this is basically the lowest income status in the case of Shandong province. And reasonably good is from 2,400 to 4,000 yuan per year, which is roughly around $400 to $500. Here we can see that in the income categories, the lower income categories where there were higher incidence of depression, which is in correlation with other studies that have been done on the low income socioeconomic status and Graves' disease. But again, after doing the logistic regression analysis and taking out the variables, we found out that income also was not such a big confounding factor when it comes to depression in Graves' disease. So age, marital status were the most confounding factors, and we did some more tests. So basically, we did the APGAR score with youth's Graves' disease patients with depression. APGAR, like I mentioned, is a family adaptation, partnership, growth, affection, resolve, and questionnaire scores. And here you can see that people with low APGAR scores had significant depression statistics compared to, if you compare with the higher APGAR scores. From the 0 to 3, you can see that 76.3% females suffered from depression and 68.5% males suffered from depression. 0 to 3 is basically severe depression. We categorize 0 to 3 as severe depression, 4 to 6 as moderate depression, and 7 to 10 as mild form of depression. So here we can see that there were more cases of severe depression, more so in the female patients, in those with Graves' disease. So then we performed a logistic regression analysis. We used the depression scores as the dependent variable, and we took into consideration the age, the marital status, the income, the level of FT3, level of TSH, level of TRAB, the Graves' ophthalmopathy, the stressful life events, and family functioning. And we found out that these were the independent variables. We did a correlation analysis to find out if there is any correlation with depression. And After that, we did a binary logistic regression analysis, and we found out that age, marital status, income, level of FT3, the TSH, these were all, these were all risk factors for depression, and TSH and income and family functioning were actually protective factors. So there were a couple of risk factors like age, marital status, income, level of FT3, Graves' ophthalmopathy, level of TRAB. These were some of the risk factors, and the others were protective. So some of the key points, if I would like to mention, the overall incidence of depression was 54.6%, male 54%, and female were 54.7%. The prevalence of depression in this 40 to 45 years old group was 72%. So the highest depression statistics were in the 40 to 45 years old group, and especially in females, around 80% of the patients suffered from depression. And like I mentioned, they were, when we did the ABGA scores, there were significantly higher number of patients with severe depression as compared to moderate and mild depression. Less than the 20 years old age group, the prevalence of depression in male patients was higher, significantly higher than in the female patients. So the discussion, if I'd like to say what is the correlation between thyroid disease and depression, we know that disturbance of thyroid metabolism in the mature brain may profoundly alter the mental function, which could affect cognition and emotion. In fact, if you look at some of the studies that have been done with Graves' disease, and we've seen a high incidence of depression in these cases, and we know that Graves' disease is the most frequent cause of hypothyroidism. And here that we see that most of the neuropsychiatric disorders, which I'll explain a little bit later, neuropsychiatric disorders are mostly prevalent in the younger population, and anxiety and depression are correlating with both are prevalent in the older population. So genetic and environmental factors play roles in the pathogenesis of GD, just like diabetes. Graves' disease also has a genetic and environmental factor background, and we know it's an autoimmune disease which affects the thyroid receptor antibodies, TSH receptor antibodies, and many reports concluded that emotional stress was related to the onset of GD. So it's very important actually, and it's very tough to analyze the patients, that some of the patients already had emotional stress and depression prior to the onset of Graves' disease. So there was a couple of factors that we had to take into consideration that did the depression or the emotional stress precede Graves' disease, because it's very difficult to predate the actual onset of Graves' disease, because some of the neuropsychiatric manifestations of some of the neuropsychiatric diseases may occur, mental disorders may occur early in case of GD before even being diagnosed. There's also a tendency of recall bias. Most of the patients that we questioned, the patients somehow managed to remember the negative effects, most of the depressive moments rather than the good ones. So there's a chance of a recall bias, and the thyrotoxicosis itself could cause depression in these patients. So it was very difficult to sort out those due to Graves' disease or thyrotoxicosis itself. So this survey included 1,158 patients, like I mentioned before, in youth populations with untreated Graves' disease. Among these patients, 54.6% of them developed depression, and there was no significant difference in the prevalence of depression between male and female. So we looked at all the statistics, and like I mentioned, only in the younger age group, like in the less than 20 years age group, the male patients, there were more prevalence of depression, but they were not significantly higher as if you compared with the other population statistics, like I mentioned in the 20 to 30, 30 to 40, and 40 to 45 age group, did not show any differences between the gender. So the male and the female ratios were pretty much similar, even though the female patients were significantly more, like I mentioned, 1:3.5 as compared to males. Depression mainly occurred in those patients who were older than 30. So what were the mechanisms related to depression in Graves' disease patients? Like I mentioned, the neuropsychiatric disorders caused by the thyrotoxic condition. In fact, most of the anti-thyroid drugs and beta blockers, when we start the anti-thyroid drugs, and most of the studies that have shown that when you start anti-thyroid drugs and beta blockers, they could improve the symptoms of the neuropsychiatric disorders which we see with emotional lability and nervousness, irritability that we find with in patients with Graves' disease with psychiatric manifestations, because we know that Graves' disease and thyrotoxicosis have their own beta potential effects. Long-term emotional stress, depression, and intense grief. So these were also in the background of those patients who are suffering from depression in Graves' disease patients. These could be prior to the onset of Graves' disease or after Graves' disease was diagnosed. And in most of the untreated cases, we've seen a background of long-term emotional stress, depression, and intense grief in these patients. Patients' characteristics also play a role. Patients' characteristics differ from patient to patient, from ethnicity, in different ethnicities, different socioeconomic backgrounds, like I mentioned. So most of the patients' characteristics were introversion and emotional lability. So these were the two things that we found that were most common. So there were some limitations to the study, especially because, like I mentioned, it was a study that was done in Chilu Hospital. It was a single-center study, so more multi-center studies will need to be done to confirm our theory of depression in Graves' disease. And it was a cross-sectional study. Like I mentioned, it was done in Shandong province, in a very beautiful province in China. But we need to do more studies worldwide to get better outcomes. We actually just looked at the risk factors for Graves' disease only, but we didn't focus on the interventions to alleviate the symptoms. We didn't check whether antipsychotics or antidepressants have any role, or psychiatric consultations have any role in these patients. So in the future, we would like to do some studies to see whether certain interventions can help to alleviate symptoms besides just anti-thyroid drugs and beta blockers symptomatic treatment. We would like to try some antidepressants and some antipsychotics. So in order to conclude, I'd like to say that the youth population with untreated Graves' disease in Shandong province had a higher prevalence of depression, like I mentioned, not just in the 20 to 30 years group, but in the 30 to 40 and the 40 to 45 age group. All patients had shown a very high prevalence of depression, especially in the females as compared to males, and especially in the older age groups. Like I mentioned, in the younger age groups, they had more symptoms of the neuropsychiatric manifestations. In the older age groups, they had more symptoms of anxiety and depression, or just depression alone. Older female patients with Graves' disease were more vulnerable to depression. Like I mentioned, there were a lot of factors involved here: the age, marital sex status, the divorce rates, the family functioning, the life event stress. A lot of the confounding factors were involved here, which we did with the logistic regression analysis. We found out the basic confounding factors that could lead to depression. And like I mentioned, age, marital status, level of FT3, TRAB, Graves' ophthalmopathy. Graves' ophthalmopathy is also increasing in its incidence day by day, and could lead to depression. Patients often suffer from exophthalmos, blurry vision, double vision, and this could affect the quality of life in these patients. So these were all risk factors for depression in young patients with Graves' disease. So thank you very much, and I again thank Inovine Conferences for giving me the opportunity to present my paper. And if you have any questions, I'd be glad to answer them.
Any questions to Dr. Suman?
Hello, can you hear me? Can I ask a
yes.
question?
Yes, sir.
Dr. Suman, thank you so much for your wonderful presentation. It's a really interesting one, and actually something that we never knew about. May I just ask you, was there any episode, you thought all the patient has got this depression? In any of your patient, was there any episodes of manic episode? Like, is there any change in pattern of their psychiatric issues? Like, were there any manic episode, like in any of the patients when you followed them up over the period?
Thank you very much, Dr. Reza. You're also working with me and my colleague in Chittagong Diabetic General Hospital. I'd like to thank you for your question. And it's a very relevant point, because we know that Graves' disease usually manifests also with manic depressive disorders. So in our cases, we found 36.3% of patients with showed mood disorders, 27.2% of patients showed manic-like symptoms, like you mentioned, and 15.2% presented with schizophrenia. So besides depression, also there were other psychiatric manifestations of Graves' disease. And to answer yours, is almost 27% of patients presented with manic-like symptoms. Manic more than depressive-like symptoms. Because we know that depression is, why this paper is so important, because we know that depression is more common in patients with hypothyroidism and more or less with patients with hyperthyroidism, because hyperthyroidism have more neuropsychiatric manifestations, more of the manic side of presentation rather than the depressive presentations. So yes, we did find some manic presentations, and we did find some schizophrenias. We did find some bipolar or mood disorder patients. Thank you.
Okay, thank you so much.
Any questions? Any questions from participants? Thanks. Thank you very much, Doctor. We enjoyed your speech. Pleased with your topic. Looking forward to meet you again next time. Thank you very much.
Thank you.
Now we will ask Dr. Rizwal Haider Chaudhary from Changi General Hospital from Singapore to join the event and start presentation.
Thank you.
Yes, you can start.
Can you hear me? Is my mic clear? Can you hear me?
Yes, yes. Yeah. Yes, you can enlarge your PPT.
Okay. Okay. Thank you, Inovine, for giving me the opportunity to share with you an excellent case that I encountered during my endeavor in Changi General Hospital, Singapore. So it's a case of hypophysitis. It's a different one from the thing that we used to know for hypophysitis. Previously, we knew that hypophysitis usually occurs in young female around the age of 30, 40 years during pregnancy and postpartum period. And the patient actually presents with severe headache. And most of the cases, the headache is more severe than what we expect. And the MRI finding, we can see there is diffuse enlargement of the pituitary gland with enhanced uptake of the contrast. But for the last few years, there has been a revolution in the oncology department that we have seen. We have seen increased amount of immunotherapy that has been used as a first-line agents for almost all the cancer patients, especially for stage 4 cancers. So there has been some shifting in the hypophysitis cases and other endocrinopathies that we have seen. This immunotherapy has got this newer term of adverse effect that has involved the endocrine system and endocrine glands of our body. That this is the case that we have encountered, and I would like to share with you this excellent case, and I think it will be helpful because I'm sure that in the next few years we'll be seeing a lot of cases like this, and so we need to keep an eye of the possible consequences of these endocrinopathies. So let us share with you this 61-year-old Chinese gentleman who was has a previous history of allergy to triamcinolone on his drug allergy chart. He actually developed this minor skin rash when this triamcinolone was applied. Patient has this background history of a stage 4 left lower lobe adenocarcinoma. It was a biopsy-proven lung cancer. And one thing that we need to know that whenever we diagnose any patient with cancer, we do some tumor marker one of the tumor marker is PDL1, and we have found out that for this gentleman, the PDL1 tumor marker was positive. And it was complicated by left-sided malignant pleural effusion. So this was the background history of this gentleman. So when we saw the patient in our clinic, he presented to us with this loss of weight, which was significant of about 15 kilo over a period of 4 months. And it was unintentional, and there was no significant change in the appetite of the patient. And in addition to loss of weight, patient had this tiredness and breast pain while he was showering. So this is quite an unusual presentation to any patient. So we are quite worried what's going on. There was no history of any breast discharge, though patient noticed some minimal swelling of the breast for the last 3 months. It was a subjective feeling that he had some swelling of the left breast. No headache, no change in shaving frequency, no polyuria or polydipsia. In the form of drug history, patient had a history of taking this immunotherapy, pembrolizumab. He started this medication 9 months back. The dose was 200 milligram every 3 weeks. It was the first-line therapy. It was started as a first-line therapy for this lung adenocarcinoma. As I said earlier, the tumor marker PDL1 was positive. So whenever the PDL1 tumor marker is positive on the biopsy sample, we can start this specific immunotherapy pembrolizumab. That's why that was the rationale of using this immunotherapy. So far, patient received 11 cycles. Apart from minor skin rashes, patient actually tolerated the immunotherapy well. On examination was patient was absolutely, the vital signs were normal. There was no postural drop, and neurological examination was also unremarkable. And physical development score was 10 or stage 4. From the investigation point of view, we actually did some relevant investigations. The most important one was we found out that sodium was a bit borderline low, 135. As we are thinking that there might be some progression of the cancer, that's why the patient presented to us. So we thought it's better to have a look at whether there is any progression or not. But the CAT scan of the chest, abdomen, and pelvis, it shows that it was a stable disease. There was no progression whatsoever. After that, we actually requested for a prolactin level because of the subjective complaint of the breast pain, and we found out that the prolactin level was high. And then we actually discussed with our oncologist, and there was some sort of consultation with us, the endocrinologist, and we found out that based on this raised prolactin level, we need to have a look at the anterior pituitary level as well. So if we go through the anterior pituitary function for this gentleman, we can see that there is evidence of central hypocortisolism, which is the cortisol level was low and the ACTH level was inappropriately low as well. And patient actually failed the ACTH stimulation test. There's also evidence of central hypothyroidism. The TSH, FT4, FT3, all of them were low. And other anterior pituitary function was normal, and the testosterone level was also within normal range. So initially, our thought was whether there was any metastasis to the central nervous system. If you see the first picture on the left side, we can see that this one was done as a staging scan before we start the patient on immunotherapy. This is the normal protocol for any patient with cancer to stage the cancer beforehand. If you can see that the pituitary gland is normal in size in the first picture, there is posterior pituitary bright spot, there is fine thin stalk and optic chiasma above that. So this was a normal pituitary gland that we saw well before starting the patient on immunotherapy. On the second picture, if you look at the picture, if you compare with the first picture, we can see that the second picture, the pituitary gland is actually enlarged, and this is a T1 post-contrast MRI scan of the brain, and there is diffuse enhancement of the contrast in the pituitary gland, as evidenced by this green arrow. So this one is the MRI when the patient presented to us with this weight loss and this change change in the breast size. So we diagnosed this case as a case of hypophysitis, which was due to this pembrolizumab. We need to keep in mind that any patient receiving immunotherapy, and if you find this pituitary gland, in some of the cases, the pituitary, it may seems like a case of pituitary adenoma, but we need to keep in mind that this pituitary adenoma, one of the differential diagnoses can also be hypophysitis. So the more we'll be seeing this immunotherapy in the next few years, we will be seeing this hypophysitis more often. So if we have a discussion about these immune checkpoints, it's quite an interesting one actually. So if we go back to our physiology, what is these immune checkpoints? So our immune system has got this excellent system of regulation. Our immune system tries to check and balance the whole environment. Whenever our immune system is overactive, it results in self-destruction, such as these autoimmune disorders, the SLE, rheumatoid arthritis, type 1 diabetes, Graves' disease. All these autoimmune disorders are due to this overactivity of our immune system. In contrast to that, if our immune system is underactive, all the harmful cells has got the tendency to escape the surveillance system of our immune system. So if the immune system is underactive, it means that there is a possibility of spreading of the cancer and development of the cancer itself. So if we just simplify with this wonderful picture, I'd like to draw your attention to this wonderful picture. So if the yellow ones are the T cells, there are two T cells, and the one with the spectacles is the cancer cell. Our T cell has got this ability to detect and destroy the cancer cells effectively. But recently, scientists have found that if the cancer cell has got this specific molecule called PDL1, and if they present this specific molecule PDL1 to our T cell, it actually binds with specific receptor on our T cell called PD1 and B71. Whenever there is interaction with PDL1 from the cancer cell and B71 from the B7-1 and PD-1 from the T cells, there is down regulation of the T cells. That means the T cells allow our cancer cell to replicate and spread throughout the body. So if we can block this interaction between this PDL1 and PD1 pathway by any form of drugs, then we can actually inhibit the inhibitors of our immune system. It's kind of unleashing the immune system to attack the cancer cells. That is what these immune checkpoint inhibitors are. They are actually these monoclonal antibodies. They actually block this PDL1 and PD1 pathway. So they actually enhance our immune response to the tumor cells or any foreign cells, which is interesting in that sense that for the chemotherapy actually kills all the rapidly dividing cells. As a result, there is a chance that all the good cells of our body may be destroyed by the chemotherapy. So the immune therapy is a highly sophisticated way to deal with these cancer patients. And then, what are those immunotherapy that we are discussing about? I can assure you that the number of immunotherapy is increasing day by day, and over the next few years, the list will be millions. I can say that. If you, this is just the simplest form that I have shared with you. This NTPD1, pembrolizumab, nivolumab, PDL1, durvalumab, evolumab, all this immunotherapy has been used for metastatic melanoma, renal cell carcinoma, non-small cell lung cancer, breast cancer, urothelial cancer, and the list is going on every single day. And there has been so many researches, so many studies regarding this immunotherapy. And we can use it individually, but also in combination. And there has been some studies that shows that if we use this immunotherapy in combination, the chance of cure of cancer gets higher. So everything has got this black side, I mean the dark side of it. So with the advancements of the immunotherapy, we are now seeing these immune related adverse events, and in most of the cases it's a kind of autoimmune like manifestation. As I said earlier, whenever the immune system is activated, there is a chance of destruction of our own cells. So what happens if our immune system is highly active and it is destroying the cancer cell, and as a result it has got the propensity to destroy our own cells as well. So if in the skin, it can cause this rash, vitiligo, on the GI tract, colitis, pancreatitis, hepatitis, from the renal point of view, nephritis. From the endocrine system, it can actually affect the thyroid gland and results in hypothyroidism. Hypothyroidism can involve the pituitary gland, resulting in hypophysitis. Adrenal insufficiency can concur, and the adrenal insufficiency can be primary or secondary, and it can also destroy the beta cell of the pancreas, and the patient may present to us in the form of with the same picture of type 1 diabetes, insulin dependent diabetes. And we have also seen cases like diabetic ketoacidosis, patient presenting with features of diabetic ketoacidosis after getting this immunotherapy. So how common is this hypophysitis related to this immunotherapy? it's not that uncommon, to be honest. It's about 10 to 15% of the patient can be affected. Most of the cases is 2 to 3 months after starting the immunotherapy. And the interesting point is that older age and male gender, which is quite different from the usual hypophysitis that we see, that usually the female gender and young age group are mostly affected by this lymphocytic hypophysitis. But for this immune related hypophysitis, it's mostly the older age and male gender that are being affected more commonly. Though the month, 2 to 3 months after starting therapy is most common, but we have seen patients who presented to us with this central adrenal insufficiency even after 2 years after starting the immunotherapy. So the timing may not be common for all the patients that we have encountered. The common presentation for any patient with presenting with this immune-related adverse event and hypophysitis, it's interesting that 45% patient can be completely asymptomatic. So no symptom at all. And the other symptoms, fatigue, headache, myalgia, nausea, if you can see that in any patient with cancer and who is receiving any form of treatment, these symptoms, fatigue, headache, myalgia, nausea, are quite non-specific. You actually cannot say or cannot demarcate whether it's related to the disease progression or whether it's related to other causes. So we need to have a very high index of suspicion for any patient who is on immunotherapy, because the patient can be completely asymptomatic. And if we don't treat the patient who has got this adverse event like hypophysitis, we may lose the patient. So this is extremely important to keep a clear eye and to screen those patients. In fact, it has been a common practice protocol for any patient receiving immunotherapy to have their endocrine system checked before each cycle of immunotherapy. So in Singapore, we are actually practicing this recently. Previously, we actually missed some of the cases. That's why it has become a common practice to check the endocrine system in the form of at least thyroid function, adrenal function, and whether the patient developed any form of diabetes or not for any patient who is receiving this immunotherapy. And for any patient for the patient who is receiving this immunotherapy, the most commonly involved that gland is adrenal gland, and this is secondary adrenal insufficiency from the reduced ACTH secretion. In 60 to 80% cases, there is central hypothyroidism and secondary hypogonadism, and growth hormone deficiency is actually quite rare. For the treatment is actually quite straightforward. Steroid. It can be in the form of IV or per oral. Whether to start IV or whether to give oral, it depends upon the severity of the patient. For example, if the patient is really sick, patient has got hypotension, or there is postural drop, and patient is actively vomiting, unable to take orally, in that case, we should use the IV steroid. And if the patient is stable, the patient can take orally, there is no hypotension or hypoglycemia, we can start the patient on oral steroid. In the form of outcome, recovery of the adrenal function is uncommon. So the thing that we need to keep in mind that recovery is not that common. Though the MRI changes that we see on any patient with hypophysitis, it results in less than 40 days. So in less than 40 days, we'll be seeing that the MRI finding may be completely normal. But in reality, the endocrine function may not recover at all. So whenever we start the patient on any patient with this hypophysitis, we need to give the patient on a steroid. And studies have shown that steroids do not appear to negatively influence the immunotherapy benefits, because our oncology colleagues might be wondering whether they should start the patient on immunotherapy afterwards while the patient is on steroid therapy. So there is some kind of dilemma. Some of the oncologists, they don't want to start the patient on immunotherapy while the patient is on steroid, but the studies actually didn't show any negative influence of immunotherapy benefits. And the other point is that hypophysitis can be a predictor of favorable response. So what it means that hypophysitis means our immune system is actually working very well. So if our immune system is working very well, that means that our immunotherapy is working very well. As a result, there is a chance of favorable outcome with the cancer therapy. So whenever we find this adverse event, we tend to think that, okay, for this gentleman, the immunotherapy like pembrolizumab that we have prescribed is actually working for the primary cancer, like this left-sided adenocarcinoma. So this is a kind of interesting point that this is a predictor of favorable response. So if you go back to our case, what happened to our patient? We actually stopped the pembrolizumab and we discussed with the patient about the treatment plan. And the patient actually opted for a treatment break because he was really tired and he just needed a break and to have some time off. So we did that, and we started the patient on prednisolone 1 milligram per kilo instead of hydrocortisone, because there's some cross reactivity with hydrocortisone and triamcinolone. And fortunately, the patient actually responded to the prednisolone well. We tried to taper to physiological replacement dose over a period of 6 to 8 weeks. We did repeat ACTS stimulation test. Unfortunately, patient actually failed to that test. That's why we had to get back to his original steroid replacement dose. It was 0.5 mg per kilo. And we also started the patient on levothyroxine because there was evidence of central hypothyroidism. And if we look at the third picture on the right side, this one is the MRI scan 3 months after we stopped the pembrolizumab. So the first picture was before we start pembrolizumab. It was a normal pituitary gland. And the second picture was when the patient presented to us with those complaints. On the second picture, we showed you that there is diffuse enlargement and enhancement of the pituitary gland. And it looked like a pituitary tumor, but actually this is a hypophysitis. And the patient since the patient was on pembrolizumab, and we stopped the pembrolizumab. On the third picture, you can see that the pituitary gland actually there is no contrast enhancement and the size has reduced and it is almost went back to normal. Though the actual function of the pituitary gland didn't come back, the MRI picture actually resolved. So that what we discussed with you, that in most of the cases, in less than 40 days, the MRI becomes normal. So this is the last take-home points that I would like to share with you. We need to keep in mind that in most of the countries, we are using this immunotherapy, and immunotherapy, they actually revolutionized the way we treat cancer. And this is a smart way of dealing with cancer patients. So we will be seeing more and more immunotherapy in the near future. So as an endocrinologist, we will be seeing more and more endocrinopathy, endocrine-related adverse events, which is due to this immunotherapy. So we need to keep a wide eye regarding these adverse events. And hypophysitis, if a patient has got this hypophysitis related to this immunotherapy, hypopituitarism is very common and that needs replacement. Medical therapy is the first line, and central adrenal insufficiency persists almost invariably in these patients. So these patients will be needing the steroid replacement for quite a long time. And we can also we should also need to keep in mind that recurrence of this hypophysitis is not uncommon at all. And obviously, this hypophysitis, this is a kind of building bridge between the oncologist and endocrinologist. So we need to have a good discussion among our colleagues of oncology department when we are dealing with any patient suspected to have this endocrinopathy in the form of pituitary involvement or in the form of adrenal involvement or thyroid involvement. So we need to have a very good drug history, what the patient has been taking for this duration, what was the dose, how many cycles the patient received. All these things we need to have a clear picture. By that means we'll be able to diagnose those patients and we'll be able to treat them accordingly. I hope that summarized my presentation, and I think we'll be seeing more and more cases like this in the future. And I thought it would be worthwhile to share with you this excellent case that we have encountered. And I'm grateful to my Changi General Hospital for allowing me to be able to participate in this wonderful case, and also
Excuse me.
Inovine Conference for this wonderful opportunity. Thank you all.
Any questions to Dr. Rizwan? Yes, sir. You can go ahead.
Thank you very much, Dr. Rizal Haidar Chaudhry. Excellent presentation. You really made the presentation look very easy, although it was a difficult topic to talk about, and
thank you.
A very interesting topic, a very rare clinical entity. But like you said, right now it is increasing as we speak. Day by day, the incidence is increasing. So somehow what I gathered, the pembrolizumab affects the HPT axis, if I'm not mistaken, the hypothalamus pituitary and the thyroid axis, and that's what is leading to all these endocrine disorders like adrenal disorders. You mentioned about the central hypothyroidism as well as diabetic ketoacidosis. I was very interested to know about that, that even these drugs can cause these kind of adverse metabolic complications of diabetes. So these complications are a result of the pembrolizumab, or they were already coexisting from before? That's my first question. And does pembrolizumab also lead to diabetes complications? You mentioned about diabetic ketoacidosis. What about new onset diabetes? Can it cause new onset diabetes? And since I live in a developing country, I would like to know what is the cost of this 11th cycle of pembrolizumab therapy? Is it feasible in our country?
Thank you, Dr. Shuman, for your wonderful question. And first of all, our patient actually had this only the involvement of the pituitary gland, and there was no involvement of the pancreas. Though in some of the studies that we have seen, the pembrolizumab can cause new onset diabetes as well. And in most of the cases, it's quite interesting. So the immune system actually attacks the cancer cell as well as the beta cell of the pancreas. So some of the cases, they even can destroy the beta cell of the pancreas completely. So some of the patient doesn't have any insulin at all, and they just come present to the A&E department with this severe hyperglycemia and diabetic ketoacidosis and coma. So we have seen a couple of cases like this. Patient actually didn't have any history of diabetes in the past, had this immunotherapy, now presented with this hyperglycemia and ketoacidosis. So this is quite interesting thing that we are seeing for the last few years, I would say. And this new onset diabetes, it can be in the form of absolutely insulin dependent diabetes. But if the beta cell destruction is partial, then in some of the patient, it can be resolved if you stop the immunotherapy. And regarding the cost of pembrolizumab, I would say the cost is really expensive. For one cycle, it cost about 3,000 Singapore dollars, which is quite expensive, to be honest. But for most of the patients in Singapore, they are being supported by the insurance, so they can afford it. But for patients who actually don't have any insurance coverage, I think it would be really difficult to afford this immunotherapy. In addition to that, we actually, for how many cycles the patient will receive this pembrolizumab, the oncologist, some of the cancers, for some of the cancer, they actually prescribe it for quite a long time. And in that case, it's really difficult for the patient if they don't have any insurance policy. So it's quite difficult for developing countries like Bangladesh and our country. Yeah.
Thank you.
Thank you. Thank you. We have hand raised from Dr. Azim Rahan. Hello.
Hello.
Yes, we have got a hand raised from Dr. Azim Rahan. Okay. Thank you very much, Doctor. On behalf of Organizing Committee members of Diabetes Congress 2020, I want to thank you for insight presentation. Looking forward to meet you again next time.
Sure. Thank you.
Now we ask you, Dr. Azim. Yes, thank you, sir. Now we ask Dr. Azim Rahan, King Salman Ham Force Hospital from Saudi Arabia, to join the event and start presentation.
Hello. Yes.
Yes, sir.
I need to share my lecture.
Yes.
Share screen. It's not sharing something.
Yes. You can share it.
Okay. Okay, it's clear now.
Yes, just you can enlarge your PPT, sir. Just you can enlarge it.
Okay.
Yes.
Okay, thank you. Good afternoon. I'm Dr. Hazm Rayan, consultant endocrinologist at King Salman Military Hospital in Tabuk in Kingdom, Saudi Arabia. Thanks for inviting me. It's my pleasure to be with you in this lecture. Inshallah, I will talk about newest medications in our hands we are using. We will review, inshallah, the updated and well known for all of us as endocrinologists updated studies and what's going on in this group of medications as SGLT2 inhibitors. Learning objectives here explain the role of the kidney in the glucose homeostasis, then describe the rational mechanism, clinical consequences of SGLT2 inhibitors, and discuss how to integrate SGLT2 into the management and create individual and what's the advanced recommendation worldwide from multiple authorities and societies in the worldwide. So let us to start today with type 2 diabetes. As you all know, it's cardiovascular and renal disease are closely interconnected together with diabetic patients. Any affected organ, kidney, will lead to affected the heart, and the opposite side, heart disease, will lead to kidney dysfunction in diabetic patients. A lot of studies shows that cardiorenal disease was most common first comorbidity in type 2 diabetic patients. Cardiorenal disease among diabetic patients reaching up to 59%, especially after 5 years of diabetes. Peripheral vascular disease 10%, myocardial infarction 13%, and stroke 18% among those group of patients. If you know that type 2 diabetes management is more than just HbA1c control, you need to control peripheral arterial vascularization, heart, kidneys, and cerebrovascular. Among patients with diabetes type 2, especially after 5 years by the studies, it's international showed that having 16% of those patients peripheral arterial disease with atherosclerosis, 14% of them having some heart failure disease, for 11% of them having myocardial infarction and stroke, etc. So what about kidney function dysfunction? Kidney dysfunction after 15 years follow-up of diabetic patients, albuminuria 38. More than 1/3 of the patients having albuminuria, and renal impairment 30%, near 29 to 30% of those patients having some element of renal impairment. So left ventricular dysfunction it's an yearly complications of type 2 diabetes patients. Among those studies showed 68% of patients with type 2 diabetes have evidence of LV dysfunction by 5 years, and after type 2 diabetes diagnosis, normal 32. And if you know that there is a heart failure with preserved ejection fraction, and there is a heart failure with reduced ejection fraction. So with the systolic dysfunction, 27% of patients after 5 years having some systolic dysfunction, while diastolic dysfunction among those patients, 16%. Systolic and diastolic LV dysfunction shows 1/4 of the patients. But with the preserved ejection fraction, 32% of patients having some element of heart failure with preserved ejection fraction. So this is a serious disease. We should act early as much as possible we can and the protection of the kidney due to the kidney declining function is associated with incidence of heart failure. It's rapid. If you see in this curves showing that rapid progression of the kidney disease with the heart failure and diabetic patients among those comparing with non-heart disease patients. So approximately 2/3 of patients with cardiovascular disease having coronary artery disease among diabetic patients, 2/3, it's a huge number. And the lifespan actually extends in diabetic patients decrease less by 6 years comparing with non-diabetic patients population, while lifespan decreases 12 years less in diabetic with myocardial infarction comparing with those patients who is not having a cardiovascular disease and diabetes. In European Society of Cardiology, they recommend that the patients with diabetes and at least one other cardiovascular risk factors or target organ damage should be considered as very high risk, should be acts as early as much to protect these patients. While in Canadian diabetes recommend that all people with diabetes should receive a comprehensive multifactorial strategy to reduce cardiovascular event risk. So this is recommendations nowadays. As you all know that pre-diabetes or insulin resistance coming as much as early before hyperglycemia started, and 90 to 90% of the patients having type 2 diabetes with declining beta cell function. After the omitis octet 1998 described by the Fronzo that they showed more than 8 organ dysfunctions will lead to diabetes hyperglycemia, not only pancreas and muscles insulin resistance and insulin deficiency. So the multi-organ dysfunction will lead to hyperglycemia. It will recommend us that to think about the medications that affecting or managing those organs to lead to the voice is clear. Complications of diabetes, as known for all of us, it's microalbuminuria, retinopathy, and peripheral arterial disease. 1% reduction of the HbA1c will achieve the reduction of the kidney dysfunction and retinopathy by 37%, amputation of peripheral vascular disease by 43%, and whole this is due to all complications by 22. This is costly effective to reduce the HbA1c. But diabetes, unfortunately, it's not only HbA1c target. Diabetes, it's HbA1c, it's a fasting blood sugar control, it's around the blood sugar control. 3 components should be looked for those patients to achieve that target, not only HbA1c. Because as all of you know that HbA1c can be affected by other factors than hyperglycemia, especially in sickler patients or renal failure patients, blood transfusion patients. So the recommendations worldwide, we are using American Association of Clinical Endocrinology or ADA recommendation to achieve the target to decrease the complications. It's worldwide by the figures known for all of us. What your ideal drug you need from your medication, what you are prescribing. You need effective and lowering HbA1c. You need less hypoglycemia. You need effect on weight loss, or there is no weight gain. Reduce cardiovascular risk, also reduce lipid and blood pressure if you have a medication in your hand, a few or no side effects, and safer drug and the end cost of that drug. So this is the multi-organ dysfunction with multiple diabetic medications we having in our hands that attacking the organs. But nowadays we would like to talk about the medications that are not working through the pancreatic insulin system, out of pancreatic system, through the kidney, decrease renal glucose reabsorption by the kidney. Why? We will go through some physiology of the kidneys by next slides. As you know, what a medication or some interventions we can do to delay or prevent diabetes. By the study showed metformin using in pre-diabetic patients or obese patients only protect by 31% reduce the risk of type 2 diabetes in the next 2.8 years, while the carbos 3.3 years. 25% on the pioglitazone, when the excellent medication, 72% reduction in risk of type 2 diabetes was due to the complications of obesity and other complications it's limiting to use nowadays. And weight loss reduction is very important. Bariatric surgery nowadays is recommended in years follow-up period to reduce the risk of type 2 diabetes by 75%, which is promising effect of bariatric surgery in obese or overweight patients, diabetic patients, or pre-diabetic with high risk genetics. So a lot of medications we are using the mechanism of action, all of them through either insulin resistance or insulin through the pancreas or muscles or adipose tissue. While the newest medication group as GLT2 inhibitors is working only through the kidney. It's not affecting the pancreas or the insulin resistance. So by all means that we have a medication that working through the kidneys despite the pancreatic function. So if we are looking for the effect of those medication according to the cardiovascular, after the events of rosiglitazone, 2004, I think it's long time, and discouraged from the market that FDA not recommending any medication without a cardiovascular efficacy or safety. So we have a new medications we are in the last 4 years, 5 years we are using with a superiority among other medications with the cardiovascular disease effect. So with the next slides, we will show what's going on. What's the physiology of the kidney play an important role in the glucose control? As you know, normal glucose physiology, 180 grams of glucose is filtered each day by the kidney. It's playing a role in the gluconeogenesis. Virtually all glucose reabsorbed in the proximal tubule and re-enters in the circulations. We have a two channels, as sodium glucose co-transporter, two channel. It's in the proximal tubules of the Henle. It's observing around 90% of the glucose, and we have SGLT1 reabsorbing about 10% of the glucose. Virtually no glucose excreted in urine in normal population, while the kidney production around 20% gluconeogenesis playing a role, uses glucose about 10% of total body glucose utilization by the kidney, filter and reabsorb 180 grams of glucose per day. So this is the effect and physiology of the kidney. Increased renal gluconeogenesis following the glucose induction in diabetic patients is found that it's happened, and excessive renal glucose release after a meal in diabetic patients, and increased use of glucose by the kidney during the fasting and postprandial. This is the structure of the nephron and this proximal tubule, as you see here, with SGLT2. This is the main reabsorbing glucose here in this area. And if we are having some medication blocking these channels, the glucose will be excreted by the urine by around roughly 70 to 100 grams per day through the kidney. So by urine. So in this situation, the patient will lose around by 280 to 300 to 400 kilocalories per day. And you know, you need to do some big exercise to do to burn these calories, while if you have some medication can improve and burn these calories by the kidney, which is good for diabetic patients. This is what SGLT2 inhibits acts on the kidney and in the heart. What's the effect of the heart? It's decreased preload due to diuresis effect by the glucose in the urine, decreased left ventricular wall stiffness, decrease the afterload, and increase myocardial energetics. So, and decrease the blood pressure. This is the add-on effect on SGLT2 inhibitor drugs. That diuretic effect, as we mentioned, it's diuretic effect around 300 to 500 ml add-on diuresis per day, natriuresis, glucosuria, and decreases proteinuria, and decrease the plasma glucose and the plasma volume in the situation, would decrease the insulin secretion and increase beta cell function, because you decrease the load of the beta cell if you are improving or utilizing the glucose by the kidney. Decrease body weight. Once you are losing the calories, it may lead to decrease the body weight and the fat, increase insulin sensitivity, decrease inflammation. This is actually indirect effect of SGLT2 inhibitor drugs, which will lead to adding beneficial effect for this group of patients. Actually, as we mentioned, all the medications we have are working either through pancreatic beta cell or insulin resistance, while our medications or SGLT2 inhibitors in our hands working through the kidneys out of insulin system. We should not forget that all medication should be, if we are prescribing a medication, we should look for the GFR. Some medication not recommended if the GFR is declining. For example, metformin after 30% of GFR decline, not recommended at all. Between 40 to 30 to 60, recommended to use half the dose or 1/3 of the dose with the precautions to avoid any complication. The same group of SGLT2 inhibitors, we can use it until the GFR is near 45%. After 45%, not recommended to use those medications. Well, there is some limitation in this group of medications because it can increase UTI, especially in women, and genital infections. Once it's happened, can be managed in one course of antibiotic or antifungal medications, and patient can continue. But if the patient is having severe infection, recurrent infection, or the patient is bedridden, so in this situation, not recommended to use this medication. Actually, dehydration in old age group is not recommended to be used, especially if the patient at risk of dehydration, he is not able to take a water. And this medication, actually, we can use it with other combination medication, including metformin, sulfonylurea, even with the insulin, we can use it with without any precautions. But because the patient that this drug alone, this drug is less hypoglycemic agent compared with other medications. Let us to move to one of the biggest studies, the empiric outcome study. We would like to see the evidence. Is it okay or not? Is it beneficial or not? Was the add-on? This is one of the biggest study, including 7,000 patients in this study. It's multi-centric study. This published in 2015. The conclusion on those or the patients criteria in this study having either cardiovascular disease or events before, and they having antihypertensive or lipid lowering agents, anticoagulation or glucose lowering medication, actually, or are the diabetic patients. The 3 and 1.1 year median observation study. This is 99% of the patients, as we mentioned, having some cardiovascular disease. Will not go in details for the station coordination of the time. Actually, this the inclusion adults with type 2 diabetic, BMI less than 45, HbA1c 7 to 10, and established cardiovascular disease. If GFR less than 30, it's excluded from those group of patients. In conclusion, the patient showed that empiric outcome study cardiovascular risk reduction with those patients comparing with the placebo by 38%. So the death decreased by 38% among those group of patients comparing with the placebo group patients. About the hospitalization from heart failure, and we show that by physiology it's the heuristic effect, so it decreases the cardiac muscle stiffness and improving the cardiac wall functioning and decrease the preload and afterload. It improving the heart failure by 35% comparing with the placebo group of the patients. Among those patients, it showed hospitalization for heart failure and cardiovascular disease decrease in group of patients using empagliflozin by 34% compared with the placebo group. This is a very promising results from the empiric outcome study, actually. And the hospitalization or deaths from heart failure decreased by 39% in a group of patients using empagliflozin compared with the placebo group. It means that this promising drug medications, either it's unique empagliflozin or this is a class effect of the group of SGLT2 inhibitors. If you need my answer, my personal answer, this class effect actually with a plus minus number of the efficacy. So the empiric outcome, the summary of this empagliflozin, in addition to standard care of reduced cardiovascular, improving overall survival in adults with type 2, it's decreasing the 3 MACE by 14%, decrease cardiovascular disease by 38%, and all-cause mortality by 32%, and decrease heart failure hospitalization by 35%. So if you're adding this empagliflozin to other medications, including metformin, sulfonylurea, you can achieve the HbA1c reduction reaching up to 3.7%. So that by efficacy-wise, with reduction HbA1c, reduction fasting, and random blood sugar, is a promising drug, actually, and we are using it safely with our patients. Systolic blood pressure due to diuretic effect, it decreases the systolic blood pressure by 5 millimeters, which is good for our patients, and improving the blood pressure control among diabetic patients. So in conclusion, this study, patients with type 2 diabetic with higher cardiovascular risk, empagliflozin given in addition to standard of care, reduce heart failure hospitalization or cardiac risk with consistent benefits observation in both those with or without heart failure at baseline. This is actually not our talk from one group of company that they recommended the study. This is nowadays all societies recommend this medication. So what about the kidney protection? Empagliflozin or SGLT2 inhibitor, all groups of SGLT2 inhibitor, why all studies canvas declare and empiric outcome study is to reduce the relative risk of incidence of worsening nephropathy by 39% on top of a standard of care, which is good efficacy wise. What let us to go through rapidly through declare outcome study. Declare, it's one of the biggest studies actually. It's published finally by in 2019, included more than 17,000 patients. Among patients, is the primary safety endpoints is comprehensive of cardiovascular disease, non-fatal MI or non-fatal ischemic strokes, And the primary efficacy endpoints 3 myths and the composite of hospitalization of heart failure or cardiovascular, and there is secondary and additional safety endpoints observed in this study. This study actually, if you are comparing with the declare with the empiric outcomes, the number of patients is bigger here. The ejection fraction, the cardiac disease in the same patients is multiple more than 2 risk, more than 55 years old, more than 60 years with all females, plus at least with cardiovascular disease, dyslipidemia, hypertension, current smoking, or 40 years with established atherosclerotic cardiovascular disease. And the patients with declared trials had a better baseline renal function than with empiric outcome or canvas study. This is some difference between other studies. But the conclusion of the results, that's the primary endpoint of composite of heart failure, hospitalization due to heart failure or cardiovascular disease declined by 17% relative risk reduction with the DABA 10 milligram compared with the placebo group, while composite of heart hospitalization due to heart failure or cardiovascular death and individual components that showed reduction from 17 reaching up to 27% relative risk reduction in cardiovascular death comparing to placebo group actually. In conclusion of declared studies that, however, dapagliflozin prevent hospitalization heart failure consistently across the broad range of type 2 diabetic patients, regardless of the history of cardiovascular disease or heart failure, reaching up to 36% relative risk reduction. So this is our conclusion in the declared study. Actually, the relative risk reduction reaching up to 38% in group of heart failure hospitalization and death of heart failure hospitalization, and in cardiovascular, this decreased by 45% is relative risk reduction actually. Concluded the declared study, the primary composite outcome of hospitalization from heart failure or cardiovascular disease was significantly reduced with DABA. Risk for heart failure hospitalization was reduced irrespective of history of heart failure, presence of or absence of established atherosclerotic cardiovascular disease or ejection fraction. If fewer MACE events were observed in patients receiving DABA than placebo, however, this did not reach statistical significance. A pre-specific subgroup of patients with the prior amide demonstrated a significant reduction in MACE with dapagliflozin, and the reduction in renal outcome in the dapagliflozin group was observed with normal significance, with nominal significance. Fewer patients with dapagliflozin group than in a placebo group reported a serious adverse events, fewer, 34 comparing with 36 in DABA group, so it's a fewer. So this is their conclusion from their studies. So in final, if we are comparing the empiric outcome, comparing with canvas study, comparing with declared study, a primary endpoint 3 MACE reduction in empiric and in canvas 14% relative risk reduction, but in declared did not show anything, any primary endpoint. Cardiovascular did 38% declining by a relative risk reduction in empiric, and all-cause mortality 32 in empiric, while hospitalization of heart failure, all 3 groups, all medications showing promising effect to relative risk reduction of the hospitalization from the heart failure. So we can conclude that SGLT2 inhibitor is not a diuresis, it's improving cardiac bioenergetics, it's in inhibition of renal and cardiac sodium hydrogen exchange, so improving the cardiac and renal function, improving renal function and cardiac physiology, and reduce preload and afterload of the heart, and reduce interstitial edema due to diuresis. Since 2016, actually, Canadian diabetic recommendation that the second line after metformin to be started as SGLT2 inhibitor if the patient, according to the degree of hyperglycemia, risk of hypoglycemia, overweight, obese patients, cardiovascular disease patients with multiple risk factor comorbidities, even before declare coming with these results, actually. And they put this guideline like picture to show how to start when and how and when to start metformin plus SGLT2 inhibitors if HbA1 according to HbA1c and according to the results and characteristics of each patient individualization. American Association of Clinical Endocrinology came later after 2017. They recommend and they put the guidelines that HbA1c less than 7.5 when you start metformin as monotherapy, plus or SGLB or SGL2 or DB4 inhibitors. So they are putting in the top of the list GLB or SGLT2 inhibitors due to the cardiovascular benefit effect and this hypoglycemia effect. Then diabetic care 2016, as mentioned, 17, 18, they had special recommendation as GL2 inhibitor provide of insulin independent glucose lowering. This agent to provide modest weight loss and blood pressure reduction. Empagliflozin and liraglutide should be considered as they have been shown to reduce the cardiovascular and all-cause mortality, which is efficacious and incorporate an agent to proven to reduce major adverse cardiovascular events and cardiovascular mortality. Currently, empagliflozin and liraglutide 2018 diabetic care is written clearly in their boxes. European Society 2019, they recommend as SGLT2 inhibitors first line therapy before metformin, even in patients with cardiovascular disease or heart failure patients. So they started putting it in top of a line in medication management before even metformin. So this is their recommendation in the European Society of Cardiology guidelines in diabetes, pre-diabetic and cardiovascular disease recommendation SGL2 and GLB used before metformin in high risk or very high risk patients. So this is a promising drug. So a lot of global clinical guidelines have been updated as a result of this new evidence actually. And they are putting dual therapy lifestyle management metformin plus adding additional agents for patients with atherosclerotic cardiovascular disease to be added as either a GLT or GLB agonist. And 2019 American Cardiac Society recommend and they are putting in type 2 control through diet and exercise diabetic patients metformin for a primary therapy, then SGLT2 inhibitors or GLB1 are secondary therapy. So this is put in top of bottoms. Again here the ADE 2020, it's a few months ago, a standard of care, and ADE said is going on now. Consistency reports reflects the evidence for a GLB and SGLT2 inhibitor and type 2 diabetic patients with cardiovascular disease with established high risk cardiovascular disease. So they recommend GLB or SGLT2 as a second line management after metformin nowadays. Actually, dapagliflozin in EMA in Europe was being approved in 2019 as a medication for type 1 diabetic patients, but we should be cautious for the occurrence. It's 1 in each 1,000 patients, 0.1% of subjects of all group having some element of diabetic ketoacidosis when they are using this medication. So we should be cautious with using, but nowadays they are using it in type 2 in type 1 diabetic patients, especially those who have those obese with insulin resistance. This is the recommendations nowadays. It's empiric outcome canvas and declare they recommend to use the SGLT2 inhibitor and second line therapy. In our conclusion of these studies, we can conclude that type 2 diabetic patients and cardiovascular and renal disease are closely connected. Cardiorenal disease, heart failure, and CKD is the most common first complication of type 2 diabetic and is associated with an increasing mortality risk. The treatment of type 2 is evolving as the guidelines are recognize the importance of addressing cardiovascular and renal disease. SGLT not only provides safe and efficacious glucose control and it offers cardioprotective and renal protective effect. Using SGLT in high cardiovascular risk patients with type 2 diabetes primary prior MI to reduce the MACE is very important. And preventing heart failure, hospitalization, heart failure events, or renal disease progression with SGL2 before this disease develops presents with huge opportunity to reduce morbidity and mortality among type 2 diabetic patients. And thank you. Any questions?
Yes. Any questions to Dr. Hazim Ryan?
No.
Yes.
Yes. Can I ask a question?
Yes, yes, sir.
Thank you very much, Dr. Hazim, for this nice, informative review. As you said, in addition to its cardioprotective effect, it reduces blood pressure and weight. This empagliflozin, I have used it for more than 100 patients. It is actually very effective and safe medication. The only remark and education to give to the patient is better to take it in the morning because it induces excessive urination. So also to educate them to drink a lot of water, especially in the first week of treatment. I have no any UTI or genital infection among more than 100 patients which are under my care. Only one patient, he developed UTI. I think in our Islamic societies and Islamic education hygiene, we are taking care of hygiene in the bathroom. So this side effect is insignificant in comparison with the Western country, which is about 5%. My question about ketoacidosis in the type 2. What is the pathophysiology for this side effect? I didn't face this problem, but they said it has this side effects, although it is a rare one. What is the pathophysiology of this ketoacidosis?
Actually, it's complicated pathophysiology. It's not clearly well, but we as understood that the pathophysiology, if the patient is losing the glucose by the urine, and it will stimulate other pathways to get glucose from the body. Free fatty acid release from the adipose tissue will lead to convert to beta hydroxybutyrate, and the end can lead to acetoacetate and acetone. This is one of the theories that, and I believe this is the correct real theory that our understanding that this is the reason. So the body is in need for glucose in sometimes, especially in type 1 diabetic patients. If they are not having and they are not eating and not getting from outside, the endogenous gluconeogenesis will come from the free fatty acid adipose tissue. And if the patient is having insulin deficiency, utilization will be less. So the pathway will go to acetoacetate and ketones. This is, I think, the pathophysiology of this complication.
Sorry, you mentioned it can be used in type 1. Why?
Yeah.
Type 1 in the obese patient of type 1? Because they are.
Yeah, but type 1 diabetic patients, after sometimes they are using big dose of insulins now, and in EMA and European societies, they approved SGLT2 inhibitors to be used in type 1 diabetic patients with the precautions of DKA. This is the reason. This is only precaution of the DKA. But otherwise, in type 2, we are using it and we are not facing. But in type 1, 0.1%, when it means 1 per 1,000 patients can develop this complication, but it's very rare actually.
What is the percentage in type 2?
In type 2, it's very rare. It's not mentioned. Even we did not face any patients with it, unless the patient is malnourished, sick, septic, or is unable to eat, not taking calories, and he is then so in this situation he can get this complication, but it's very rare. It's not mentioned.
Thank you.
Hello.
Any questions?
Yeah, I have a question.
Yes.
Actually, another comment. Yeah. Right. So the thing with the SGLT2 inhibitors is it really focuses on just hyperglycemia. The link between really the cardiovascular outcomes and this is also questioned in Lancet recently. And so in a sense, this is almost like doing a dialysis, which is probably maybe most painful, but most cumbersome, but probably least problematic of having some side effects. So, and it doesn't actually remove the underlying issues of insulin resistance in muscle and other tissues, which are already starved of not getting the right amount of glucose properly. So I feel that this is the wrong direction to go, just merely focusing on hyperglycemia. And that is really the wrong approach. I think this has a case in very, very early stages, pre-diabetic stage, maybe to reduce insulin resistance. So other than that, I think this is incorrect direction. I mean,
Hello, Dr. Azim.
Yeah. I have no comment about Dr. Ravi opinion. But my understanding that you are against the way that we are using the medication that lead to glucosuria to avoid hyperglycemia. By my understanding, this is the way you are going through.
Yeah. I think, I mean, as I will talk about this, I think hyperglycemia is an effect of other things. And so there is excessive focus, and our therapeutic should be refocusing. And obviously the drug companies want to push what they want. I mean, this is going to be a chronic use of, I mean, it is a lifelong use of SGLT2s, and just like insulin, just like any other thing. So,
but Dr. Ravi, in our hands, we have an evidence that it's multi-organ improvement with using SGLT2 inhibitor, including cardiovascular, renal protection, including glucose improvement, insulin sensitivity, indirect weight. It's actually, and this medication actually it's a natural. It's from Apple Park medication they use, and since long time the story started. It's not 1898 like this started the story. Then the development of the story started in 2000. Then they developed those medications. So I think the medication with the glucosuric effect, with indirect pathway to the cardiovascular and renal protection, it's very helpful. And if you are using for your patients and you observing your patients, you will get the benefit, and you will feel how the patients are very happy with using these medications. Let us to see our practice instead of thinking about physiology and pathophysiology.
I understand about patient being happy temporarily, because these drugs are only 10 years old maximum. And but most drugs in diabetes are at least 100 years old. So including metformin and all of them. So it's not like it's not like how old they are, but it's what they are doing and what they are going to do. And that's what is important.
Correct.
So, I mean, clearly we need to reduce hyperglycemia, but it should be more like an effect of addressing the underlying issues. Okay, anyways.
Thank you.
Any more questions to Dr. Azim? Okay, thank you very much, Doctor. On behalf of all organizing committee members of Diabetes Congress 2020.
Sorry, just as a comment.
Yes, sir.
We can combine this sodium glucose transport inhibitor with metformin, so we can have synergistic effect of both. So we can tackle many target in the organs. Just to answer the comments of our second colleague. Now we are using combination of medication. Isn't it, Dr. Hazem?
Yes, correct. We are using correct, and the efficacy with HbA1c reduction reaching more than 3%. Very.
To answer the question of our colleague, the objection of using it, because it is only treating the hyperglycemia. The metformin we can use with metformin to get also the benefit of both.
There are patients who are typically at least 5 points above the A1C, normal A1C. So the metformin doesn't reduce more than 1% really. And SGLT2 inhibitors are also not contributing much. And collectively, they are not synergetic. So
I mean, metformin, if you combine it with sodium glucose transporter inhibitor, the benefit will be more if the patient will take one of them alone. This is well documented.
Yes, I mean, they are simply additive. Anyway.
Okay. Of course, plus lifestyle modification, the other diet, exercise, plus combination of these two drugs, two medications. I found it in my clinical practice. It is very effective. And it is also for the patient to take one medication instead of two is much easier for especially elderly patient for their convenience. And instead of taking two different medication, to take one tablet combined will be easier and more favorable and effective.
Okay.
Okay.
Yes, yes, doctor.
Thank you.
Thank you for thanks.
Yes, doctor. Thank you very much, doctor.
Thank you
for insight presentation. Looking forward to meet you again in the next time.
Inshallah. Thank you.
Yes, doctor. Now we asked Dr. Hannah Tariq El Zawevi from Alexandria University of Egypt to join the event and start presentation. Yes, madam. Just you can upload your PPT. Yes.
Okay. Bismillah ar-Rahman ar-Rahim. I'm Dr. Hannah Tariq El Zawevi, Assistant Professor of Endocrinology, Faculty of Medicine, Alexandria University. It's my pleasure to participate in this distinguished virtual Endocrinology and Diabetes Congress. And I'd like to thank Inovine Scientific Committee for their kind invitation and for their well organization of the conference, wishing the conference all success, inshallah. My topic today is cardiometabolic risk factors, control, and diabetes, new perspectives. My presentation will include a short introduction about diabetes mellitus, epidemiology and magnitude of the problem, cardiometabolic risk factors, and finally the effect of controlling cardiometabolic risk factors on the course of diabetes mellitus. Diabetes mellitus is a metabolic disorder characterized by chronic hyperglycemia resulting from defects in insulin secretion, insulin action, or both. Diabetes mellitus is a major public health problem associated with serious complications that can be life-threatening. Even prediabetes has shown to be associated with various complications, including increased cardiovascular risk. Regarding epidemiology and the global burden of diabetes, diabetes mellitus and its complications have contributed tremendously to the burden of mortality and disability worldwide. Diabetes mellitus is identified as the 7th cause of death. The incidence of disability caused by diabetes mellitus has increased, particularly among people aged 15 to 69 years. Moreover, with the rising prevalence of childhood obesity in many countries, the prevalence of type 2 diabetes mellitus is increasing in the pediatric population as well. Over the past few years, the prevalence of diabetes mellitus increased so much worldwide, and data from the IDF 2019 showed highest prevalence in the Middle East area and the North Africa, with a percentage of 12.2% in 2019, and this percentage is expected to be increased by the year 2030 to be 13.3% and to be 13.9% in the year 2045. Also, data from the IDF found that the majority of people living with diabetes are of the working age group between 20 and 64 years old, and this number is expected to be increased by the year 2030 and much more increased by the year 2045. And this, in fact, generates an expanding strain on productivity and economic growth in the coming decades. In Egypt, diabetes mellitus is a major public health problem with a significant impact on the Egyptian economy. Also, data from the IDF found that the number of people with diabetes in Egypt is expected to be quadrupled from the year 2010 to the year 2045. Egypt is one of the top 10 countries worldwide suffering from diabetes, and it has the 9th position worldwide by the year 2019, and this position is expected to be the 8th position by the year 2030 and to be the 7th position by the year 2045. This emphasizes the presence of a major public health problem worldwide and specifically in Egypt, and the current estimates and the prevalences and of diabetes and the health impacts of this disease stresses on studying the pathogenesis of diabetes mellitus and the cardiometabolic risk factors leading to this disease and finding a solution. The main underlying pathophysiology of diabetes mellitus is the result of interplay between insulin resistance and beta cell dysfunction. Insulin resistance contributes to the increased production of glucose from the liver and decreased glucose uptake in the muscle and adipose tissue. Beta cell dysfunction results in reduced insulin release, resulting in be insufficient for maintaining normal glucose levels. Metabolic syndrome is defined as a group of metabolic disorders, including central obesity, dyslipidemia, and diabetes mellitus that can lead to developing cardiovascular diseases. The global prevalence of cardiovascular diseases and metabolic syndrome has increased over the past 20 years. A central distribution of body fat or visceral obesity is associated with increased cardiac risk independently of the BMI. Central adiposity is the dominant risk factor for the development of insulin resistance and type 2 diabetes mellitus, which routinely clusters with atherosclerosis and the cardiometabolic risk. The IDF definition of metabolic syndrome emphasizes the presence of central obesity, the hallmark for diagnosis of metabolic syndrome, with waist circumference more than or equal 94 centimeters for men or more than or equal 80 centimeters for women, plus 2 or more of triglycerides more than or equal 150 milligram per deciliter, HDL less than 40 milligram per deciliter in males, and less than 50 milligram per deciliter in females, and the blood pressure greater than or equal 130/85, or treatment for hypertension, fasting plasma glucose more than or equal 100, or type 2 diabetes. In fact, cardiometabolic risk factors are numerous. They include non-modifiable group, which is the age, race, sex, and family history, and modifiable group of risk factors. These include the inflammatory states, the hypertension, smoking, stress, physical inactivity, unhealthy eating habits, and overweight and obesity, which is a very important cardiometabolic risk factor as it precipitates and helps in the pathogenesis of insulin resistance, which further leads to dyslipidemia, increased blood pressure, increased blood glucose, and can eventually lead to diabetes mellitus, which further augments the cardiometabolic risk. So obesity, or specifically central obesity, is a major cardiometabolic risk factor. Obesity is a disease with genetic, environmental, and behavioral determinants that confers increased morbidity and mortality, especially the central obesity or the visceral obesity. Obesity is considered by the WHO as a worldwide pandemic, or epidemic, and highest prevalence of obesity is in the Middle East area, including Egypt, and in North America. Obesity is defined as BMI greater than or equal 30 kilograms per meter square, or a new definition, the American Association of Clinical Endocrinologists and American College of Endocrinology in 2014 settled a new definition for obesity as BMI greater than or equal 25 kilograms per meter square in the presence of one or more obesity-related complications, including type 2 diabetes mellitus. So, if the patient has BMI greater than or equal 25, not 30, plus diabetes mellitus, the patient is considered to be obese, according to the American Association of Clinical Endocrinologists guideline. Obesity poses multiple risks with many adverse clinical consequences, including risk of type 2 diabetes, cardiovascular disease, dyslipidemia, hypertension, and many other risks. Altered glucose homeostasis due to obesity, leading altered glucose homeostasis, the result of hyperinsulinemia and insulin resistance, is a very important, prominent feature of obesity. Also, the American Heart Association and National Institute of Health have recognized obesity as a major modifiable risk factor for coronary heart disease. In fact, adipocyte is an endocrine organ with many secretory products secreting leptin, insulin, resistin, free fatty acids, tumor necrosis factor alpha, interleukin 6, and many other adipokines. Obesity can induce insulin resistance through the release of these adipokines, including tumor necrosis factor alpha, and specifically also the release of free fatty acids. A second mechanism is ectopic fat deposition, particularly in the liver and skeletal muscle, and finally by mitochondrial dysfunction. So obesity or central obesity, fatty food, unhealthy eating habits, stress, hypertension, all are cardiometabolic risk factors that can result in high blood pressure, dyslipidemia in the form of high triglycerides, high LDL, low HDL, presence of the release of inflammatory markers, intra-abdominal adiposity, insulin resistance. All these lead to cardiovascular risk in addition to precipitation of type 2 diabetes mellitus, which further augments the cardiovascular risk and perpetuates a vicious circle. So how can we stop or even prevent this vicious circle? This can be achieved through targeting the cardiometabolic risk factors. The most important is obesity. To stop obesity is a very important point in targeting cardiometabolic risk factors to stop the vicious circle of diabetes and the cardiovascular risk. This is a paper published in the Journal of American Heart Association 2019 concluded that maintaining weight loss was better for all risk factors, and losing more than or equal 75% of weight has the greatest benefit. And they emphasized and concluded that not only weight loss, but weight loss maintenance. This was very important, maintaining weight loss, not just achieving weight loss, but maintaining. This is because every BMI 1 unit reduction results in 1.25 millimeter mercury reduction in systolic blood pressure and 1.5 milligram per deciliter reduction in triglycerides. Also, every 1 unit reduction of weight results in increased HDL by 0.5 milligram per deciliter and the decrease in triglycerides by 2.8 milligram per deciliter. Endocrine Society Clinical Practice Guidelines recommended that patients with type 2 diabetes who are overweight or obese use anti-diabetic medications having additional actions to promote weight loss, like the GLP-1 analogs and sodium glucose transporter inhibitors, in addition to metformin, to get the utmost benefit of weight loss and the cardiovascular protection. Also, the guidelines allowed the use of weight loss medications to maintain weight loss in patients with BMI greater than or equal 27 kilograms per meter square with diabetes. The guidelines recommended bariatric surgery for those with BMI greater than or equal 35 kilograms per meter square with comorbidity like type 2 diabetes. All these in order to lose weight and reduce body weight to obtain the beneficial cardiovascular effects of weight loss in diabetic patients. Bariatric surgery results in controlling hyperglycemia in obese diabetic type 2 diabetes mellitus patients. Even diabetes mellitus remission can be achieved, and in a large percentage of people, diabetes mellitus remission can occur in up to 78% of cases doing bariatric surgery. Not only bariatric surgery can induce diabetes mellitus remission, but also intensive lifestyle intervention has now shown to dramatically improve diabetes mellitus, or even cure or induce remission in diabetes mellitus. Many studies in the recent era have focused on this, particularly in the management of diabetes through dietary and lifestyle modification. And the key feature is to maintain this dietary and lifestyle intervention to be permanent change in diet and lifestyle. This is a study, the Look Ahead study. This is a mega study done over more than 5,000 patients, comparing the effect of intensive lifestyle intervention, which is 7% weight loss in addition to 175 minutes per week exercise among people who are overweight type 2 diabetic, compared to control group just receiving diabetes support and the education program. These are 3 sessions per year for social awareness about diabetes. And they found, although they did not find a significant difference in cardiovascular morbidity and mortality between the study groups, yet they demonstrated significant difference in weight loss regarding the improved glycemic control. So weight loss dramatically improved glycemic control in the group with the intensive lifestyle intervention. Another study is the diabetes prevention program. This program started from 1996 till 2001, compared the people receiving intensive lifestyle intervention in the form of exercise and weight loss, compared to those receiving metformin and those receiving placebo, to examine or to investigate the incidence of occurrence of diabetes among the 3 groups. We found that after 3 years, those receiving intensive lifestyle intervention have lowered the chances of developing type 2 diabetes mellitus by up to 58% compared to those receiving placebo. Also, patients receiving metformin had lower chances, but only by 31% compared to those receiving placebo. So this emphasizes the effect of intensive lifestyle intervention and weight loss that has a better effect even than metformin. This is another trial, the DIRECT trial. This is a research study investigating whether offering an intensive program of weight loss and weight loss maintenance would be a viable tool to achieve diabetes mellitus remission. This was applied on diabetic patients, and they found that those who achieved and maintained more than or equal 15.5 kilogram weight loss showed diabetes mellitus remission. And this is a dramatic benefit of weight loss. Finally, my application in 2019 with Dr. Magdi Allam, titled Type 2 Diabetes Mellitus Non-Surgical Remission, a Possible Remission, which means that non-surgical, non-bariatric surgery remission of diabetes is possible through application of the intensive lifestyle intervention. We conducted a retrospective cohort study on type 2 diabetes mellitus patients out of 670 patients who were eligible. We found that 28 patients showed complete remission. Complete remission means 2 consecutive hemoglobin A1C was less than 5.7% over a period of 12 months while stopping the anti-diabetic medication. And about 35 patients showed partial remission. Partial remission means that the 2 consecutive hemoglobin A1C between 5.7 and 6.4% over a period of 12 months after stopping anti-diabetic. So when we investigated those patients who showed remission, we found that there were several criteria that influence remission in those patients. This included female sex, age less than 50 years, short duration since diagnosis of diabetes, less than 5 years, a baseline hemoglobin A1C less than 8.5%, and HDL more than 45.6 milligram per deciliter. Therefore, we concluded that in our study, our mission in Egyptian type 2 diabetes mellitus patients is that with these criteria is to achieve diabetes mellitus remission as a treatment target through the intensive lifestyle modification in association with daily metformin. My take-home message: diabetes is a complex chronic illness with multifactorial risk reduction strategies beyond the glycemic control. Obesity stands out as a major controllable contributor to diabetes mellitus, stopping obesity through bariatric surgery or intensive lifestyle intervention has a dramatic effect on glycemic control and type 2 diabetes mellitus remission. And finally, controlling cardiometabolic profile in Egyptian patients with type 2 diabetes mellitus can offer a cost-effective approach to managing diabetes in Egypt. Thank you.
Any questions? Any questions to Dr. Hannah Tariq? Okay. Thank you very much, Doctor. On behalf of Organizing Committee of Diabetes Congress 2020, I want to thank you for an insight presentation.
Thank you.
Looking forward to meet you again next time.
Inshallah.
Yes. Now we ask Dr. Makdi Muhammad Ahlam from Alexandria University Student Hospital from Egypt to join the event and start presentation.
Assalamu alaikum.
Yeah, yes.
Okay. I will share my slides.
Yes.
Okay.
Yes, sir.
I want to thank all organizing committee
Thank you very much.
and and scientific committee for this excellent virtual. Okay, sorry. Okay. Assalamu alaikum. I want to thank all organizing committee and scientific committee for this elegant virtual diabetes congress to present my paper. Also, I want to thank my colleagues who participate in this study. My study is about community pharmacist intervention in type 2 diabetes mellitus management in Ramadan. Should be considered in Egypt or not? The Middle East and the MENA region has estimate of 35 million diabetics, of whom 9 million exist in Egypt. Ramadan, the month of fasting for Muslims. The pre-Ramadan patient education and the clinical evaluation targeting patient safety is important, as there is 5-time increase in incidence of severe hyperglycemia and 5-point-time increase in incidence of hypoglycemia. Chronic care model is a method of restructured health care services through interaction between health system and communities. Altogether based on raising patient knowledge, aiming to enable patients to control diabetes, emphasizing the person-centered close follow-up and adherence to treatment. Due to their accessibility and flexibility, community pharmacies are well suited for support and reach out to this vulnerable group about optimal diabetic care, especially in circumstances such as COVID-19. In Egypt, there are many disparate areas. As we see in the map, most of people are concentrated in the Delta and Nile River, and most of Egypt have disparate areas. Discrete area communities have high prevalence of illiteracy and low socioeconomic states, leading to unhealthy lifestyle and may affect the diabetes course and the progression, especially in Ramadan. So we conducted this study to evaluate community pharmacy-based chronic care diabetic patient on diabetes control in discrete area of Alexandria government. Also to assess simple and feasible diabetes care model related to Egyptian culture in Ramadan. So at the baseline and at the end of each phase of study, we targeted patient, the target patient have subjected to many measures, which chooses the target patient based on they were above 18 years old with uncontrolled diabetes, more than 7%, resident within pharmacy catchment area and didn't have health insurance. We excluded patients had mental and physical disability, included dementia, stroke, advanced retinopathy or blindness, deafness or muteness, pregnant and lactating female, decompensated liver, renal, and heart failure. This is a flow chart of study. As we see, this is a cluster randomized controlled study, 2x2 crossover study, consisted of 2 phases. The first phase of 3 months, 2 months pre-Ramadan and Ramadan, and the next one also 3 months, 2 months pre-Ramadan and Ramadan month. Eligible patients were recruited by 10 pharmacies, each one composed of a cluster, each cluster composed of 10 patients. Each group divided into 5 pharmacy. Each pharmacy, each group have 15 patients. Each group conducted the study for 3 months. Then after that, they crossed over with a washout period for 1 year. So, in the preparation of that study, after face-to-face training of the pharmacist, they provide face-to-face patient education for 45 minutes for the intervention group, and the control group received the usual care based on IDF recommendation for Ramadan. The patient-oriented diabetic care model was constructed according to IDF guidelines. Ramadan included educational pictorial posters of diabetes and its complication, non-pharmacological part in the form of lifestyle changes, comparison of nutritional therapy, smoking habit, physical exercise, including Taraweeh, pharmacological part in the form of medication for type, doses, and frequency, regular visit of the intervention patient to their assigned pharmacies for 45 minutes in the first visit, and once weekly for 15 minutes in the followed visits, for consolidation of education, goal of reviewing, and drug adherence, while usual care had monthly visits. The measurement items included history, clinical assessment included blood pressure, body mass index, waist circumference, physical activity, which consisted of 5 categories: light, moderate, heavy, and non-physical activity that Taraweeh included in moderate. Also, filling all forms of study questionnaires and laboratory investigation. Study questionnaires included level of patient knowledge of diabetes management, patient adherence to treatment using Morosky adherence score, patient self-efficacy by 6-item self-efficacy scale, and patient satisfaction using 18-item short-term patient satisfaction questionnaire. All of these questionnaires were included in the baseline and after end of each phase. Laboratory investigation, glycated hemoglobin, lipid profile, glomerular filtration rate, and protein creatinine ratio. So, Regarding socio-demographic data, there is no significant difference between two groups in these data, but there is a dominance of age group between 40 and 60 years and dominance of female sex. Most patients had poor socioeconomic state, and they were non-smoker, and there is no physical activity in the most of them. The most prevalent comorbidities were hypertension. The age of onset and duration of diabetes mellitus was similar in both groups. The age of onset around 38 years old, and the duration of type 2 diabetes was around 9 years old. Regarding the blood pressure, in spite of insignificant difference in the baseline, after application of the intervention, there is a significant reduction in systolic blood pressure, about 7 millimeter mercury in the intervention group versus the usual care group. Also, the systolic blood pressure was significantly lower in the intervention group by 3.3 millimeters mercury versus the usual care group. Regarding the waist circumference, there is a significant reduction in the waist circumference in the intervention group by 5.8 centimeter versus increase in the usual care by 2.1 centimeter, and a significant reduction in the BMI in the intervention group by 1.86 kilogram per meter square versus increase in usual care. Regarding the HbA1c, the significant reduction in the HbA1c in spite of insignificant difference in the baseline, mainly in the intervention group by around 2% and increase around 2% in the usual care group. Regarding the lipid profile, significant reduction in the triglyceride, LDL, total cholesterol, without any significant change in HDL, PCR, and GFR, which mainly related to short period of follow-up. Regarding the questionnaire assessment, knowledge were significantly improved after the intervention. Self-management score was significantly improved after the intervention. Patient satisfaction all significantly improved, except the accessibility and convenience, as both groups have the same accessibility item. Regarding the more risk score adherence, there is a significant shift of adherence from the low to moderate and high adherence in intervention group versus the usual care group. When we did a multivariate regression analysis of factors affecting diabetes control and lipid profile control in those patients, the HbA1c was significantly related to patient satisfaction and the baseline HbA1c, also eating habit. Also, the LDL was significantly dependent on eating habit and patient knowledge score. Triglyceride was significantly dependent on waist circumference and baseline HbA1c and knowledge score. When we do a economic analysis for this study, after calculating that the training costs of pharmacists and print and flyers, also absenteeism of patient from the work, consultation of doctors, hospitalization, and diabetes-related medication, the gross cost was significantly lower in intervention group versus the usual care group by 5,000 Egyptian pound. Also, when we calculate the incremental cost effectiveness ratio, there is a significant decrease in the cost of the reduction of HbA1c by intervention group by 1,581 Egyptian pound. So to conclude, this is the first randomized controlled trial in Egypt, revealing that the community pharmacy-based intervention can deliver a simplified, convenient, and cost-effectiveness guided care to local type 2 diabetes mellitus patient using a pictorial patient-centered diabetes care model in Ramadan. Also, this improves patients' behavior, knowledge, self-efficacy, and adherence to treatment, which in turn control their glycemic and cardiometabolic parameters. Thank you.
Yeah. So, any questions to Dr. Maghrib Muhammad Alam? Any questions?
Thank you.
Thank you very much, sir. We have enjoyed your speech, pleased with your topic. Looking forward to meeting you again next time.
Me too. Me too.
Yes, thank you very much, sir. Now we ask Dr. Dahiria Camacho Monoclova from University of Puerto Rico to join the event and start the presentation. Yes, ma'am. Just you can upload your PPT and start the presentation.
Hi, sorry. Yeah.
Oh, okay, no problem.
So, hello everyone. My name is Dayanira Camacho. I'm from the University of Puerto Rico Medical Sciences campus. And yeah, I want to thank you all for giving this space for us to share our projects. And I just want to make the disclaimer that I was a volunteer in the project I'm about to present. I'm presenting on behalf of the study team. So if you have any suggestions or questions I may not answer, then you can just direct them to me and I will contact you later with the answers. But feedback is super welcome. So I'm gonna start now. So yeah, this is about social and behavioral factors associated with the occurrence of moderate or severe periodontal disease in individuals with type 2 diabetes. This doesn't have to be explained, but type 2 diabetes is a chronic condition that affects the way glucose is metabolized in the body, and it also makes the body resist the effects of insulin or doesn't produce enough of it to control glucose. And in America, well, in the United States, 34 million people have diabetes, and out of those, a vast majority of 95%, 90 to 95, have type 2 diabetes. Periodontal disease is a chronic inflammation in the mouth, in the gums, mainly caused by anaerobic gram-negative microorganisms that adhere to the teeth, and it affects the gingival, periodontal, ligament, and alveolar bone tissue supporting the tooth, and it can lead to tooth loss. This includes gingivitis, dental plaque-induced gingivitis, and non-plaque-induced gingivitis. And chronic periodontitis is irreversible and is the most common form of periodontitis. Its clinic is significant after age 30, and the disease progresses slowly and sporadically. The prevalence depends on the criteria used. Using the Centers for Disease Control and the American Academy of Pediatrics definition, in the United States, among dentate adults aged 30 years or more, 47% are affected by periodontitis, and 8.5% are affected with severe periodontitis and 30 with moderate periodontitis. And risk factors include smoking, diabetes, age, gender, obesity, education level. And And just to make the clarification that that definition of what is considered mild, moderate, and severe periodontitis is not specifically like established. So in our study, we decided what to consider moderate to severe, and I will explain to you later. The problem, statement of our problem that we were contemplating, studies have shown that individuals with diabetes tend to have inadequate knowledge and attitudes towards oral health, including fewer dental visits, and oral education and dentist referrals by physicians or care providers have been associated with improved oral health behaviors among patients. So which social factors or lifestyle habits are associated with a higher prevalence of moderate or severe periodontitis in individuals with type 2 diabetes? And this is in a community of Puerto Ricans. This study is based in here. So it's very novel. No one like this hasn't been studied in this population. So our significance determining the factors that are found to be associated with periodontitis might help address the underlying behavioral patterns behind the higher disease prevalence, and understanding these relationships among individuals with type 2 diabetes can serve as base for further disease control. Because there is a debate whether periodontitis like aggravates other systemic inflammations or other systemic disease, or is it the other way around? Specific aims of this is to describe the population based on social and behavioral factors, and to assess the individual associations between these social and behavioral factors and the prevalence of moderate to severe PD in individuals that have type 2 diabetes. The study population of our project, it's a sample of 260 volunteers that have type 2 diabetes, aged between 40 and 65 years, non-institutionalized residents of Puerto Rico, or they are working in Puerto Rico. And we also retrieved some participants from a cohort study called SOLS, which it's a San Juan overweight adults longitudinal study. We recruited them from the general population by advertisements and word of mouth, and we also got a list of patients from collaborating centers as described there. The inclusion criteria was very strict, so we had to reach out to different institutions to reach our sample. The exclusion criteria, having less than 4 natural teeth, having braces or other orthodontic appliances, needing to take antibiotic prior to dental exam, taking steroids or other anti-inflammatory drugs, regular use for 2 weeks or more within 1 month prior to clinical examination of antibiotics or medication known to affect periodontal status, taking medications, TCDs or glitazone type 2 diabetes medications, or having systemic conditions like history of heart disease, systemic complications, chronic inflammatory diseases, hemophilia, dialysis patients. So we conducted the study in the PRC-TRC, which is the Puerto Rico Clinical Translational Research Consortium. It's right next to the Medical Sciences campus. And upon the arrival of participants, we confirmed their eligibility, the informed consent, completed pulse and blood pressure measurements, blood draw, anthropometric measures on the neck, waist, and hip. Breakfast, we gave them breakfast because they had to come fasting. And we did an interview-based questionnaire, an oral and dental examination. And then at the end, we gave them a general pep talk about health. It's training. And an incentive of $50. And we gave them a report of the results and referrals if needed, if there was any extraordinary case. In the interview-based questionnaire, we assessed socio-demographic information, general health status, primary health insurance plan, a list of the medications used with the dosage and the frequency, the medications to lower cholesterol, the duration of use, dates, the oral health status, number of visits to the dentist in the past year, report of gums bleeding when brushing or flossing, PD treatment, and lifestyle and health habits, smoking, alcohol habits, oral hygiene practices, and address information like where they buy their medication. All the data extracted from the questionnaire was stored in RedCap, which is an online database where we can store the information and then extract it for analysis. And we retrieved also information. The variables most important to us were age, gender, education, BMI, smoking and alcohol habits, dental visits, and dental flossing habits. And yeah, all participants underwent a clinical dental examination where we addressed a number of tooth losses, a plaque index on 6 selected teeth, gingival recession, probing pocket depth, bleeding on probing. We collected samples on GCF, which is a gingival-crevicular fluid, and subgingival plaque sample collection. So probing pocket depth was measured at 6 sites per tooth, excluding the third molars, and moderate to severe PD was defined as having a high percent of tooth sites with a probing pocket depth of 4 millimeters or more. That's our threshold, and that's what we consider to be moderate or severe PD, that depth on probing. So the statistical design, we described the study population, the periodontal status, age, gender, education, BMI, smoking, and alcohol status and frequency of dental visits and flossing habits. And then we used a multivariate logistic regression model and using as predictors those variables and using the periodontitis status as our outcome. And the significance level was set at 0.05 of the p-value. So this is our population. As you can see, the mean age was 55, 55% was female, 45% was male. The majority had education higher than high school. And the majority also never smoked, but 1/4 were former smokers and 11% are current smokers. Also, 43% are current alcohol drinkers, 1/4 abstained from drinking, and 32% have had drunk alcohol. The BMI, the mean BMI was 35, and the majority has visited the dentist at least once within the last year. But the majority doesn't floss regularly. They floss less than once a day. Percent.
Hello.
Yeah.
Proceed, ma'am.
Yes, you can proceed your presentation, madam.
Okay. So at the age range of 40 to 49, 25% more, there are a majority that have PD moderate or severe as opposed to mild or no PD. And the same goes to the
Hello. Sorry, madam, we are unable to hear your voice. Hello. Hello. Hello, Dr. Dahaniri. Hello. Okay, okay, sir. So we came to know Dr. Dahaniri Camacho got the PowerPoint cut, so she's unable to present at talk. So now we welcome Dr. Rafilo Pilla from St. Joseph of God Hospital from Italy to join the event and start presentation. Yes, sir, you can start your presentation.
Are you talking to me?
Yes, yes, yes.
Perfect. Sorry about that.
Yes. So we got information that from Dr. Dahaniri had got the power cut.
Yes.
Yes.
Okay, cool. First of all, getting started, I just wanted to thank you all for this opportunity, and my apologies not to be here earlier. And you know, I usually work many hours a day, so I just got off of work, so I apologize. I'm gonna share my screen real quick, and we're gonna get started with my presentation. So I hope you can see my screen. Today I'm going to talk about the therapeutic ketosis and its applications in a number of pathologies. Among them, we also find diabetes type 1 and type 2. Although I'm not going to focus on this specifically, but I wanted to introduce this topic into this conference because it is very much related. So I am going to start with my experience in research, especially when I started my last portion of my research experience. So I am a pharmacist right now, and I have been working in physiology as a physiology researcher up to my postdoc. I have been working in France and then in the United States. I am from Italy. So now I'm back to Italy. So I'm going to start discussing about what was my experience in the United States back in 2010. I've been working with the Office of Naval Research. So basically these guys from the US Navy are very much committed to attack or defense mission and submarine rescue, as you can see from these pictures. Notably, the Office of Naval Research, ONR, is the one in charge of getting the research out of the Navy. So basically, it's the research section, the science section from the Navy. What we used to have was a gas palace. It was basically a place where we used to stock our gas tanks, and we were able to mimic the Navy SEAL dives thanks to these tanks. We were able to do hyperbaric chambers dives, mimicking the real dives. I don't know how many of you are divers. I hope that some of you are, but if you're not, just going to tell you quick concepts about diving. Here on the land, we're breathing about 21% oxygen and 79% nitrogen, approximately. When we go down, when we are under pressure, these gases, of course, are under pressure too. And as we use oxygen, as we metabolize oxygen in a perfect way, we cannot metabolize nitrogen as it is an inert gas. So when we surface after a dive, if we do not let the nitrogen out in a proper way slowly, we're going to get bends. I mean, likely we're going to get bends. Bends are accumulation of nitrogen in some tissues. So best case scenario, we get nitrogen accumulation into our joints. And if we get that, we get a lot of pain. And the only way to get rid of it is to get back in a hyperbaric chamber. But we also can get nitrogen accumulation on the optic nerve, for example, and unfortunately this can make us blind, or this can get accumulated into the spine and can make us paralyzed. There's so many options, unfortunately. But in best case scenario, it can get just accumulated into the joints. So in order to avoid that, back in the 60s, the Navy started increasing the amount of oxygen in the tank. So to kick off the nitrogen. So started off at 21%, got up to 20 to 28, 33, 35, and eventually got up to 100% with the rebreather. Now, this was good because that allowed the divers to stay a longer time on the bottom and they could surface very quickly. But at the same time, this caused a lot of problems in terms of reactive oxygen species production. And so this led to seizures. So basically it's like epileptic-like seizures. You might wonder when this can happen. When this happens, when we have hyperbaric chamber treatment and deep dives with the Navy SEALs, as you can see in these pictures. But now I want to show you what happens when we are under the water and we're breathing pure oxygen. Now, this is just an experiment, as you can see. This is a hyperbaric chamber, and the guy on the left is breathing pure oxygen. Now, I'm going to show you what happens. The guy breathing pure oxygen on the left and the guy on the right is a physician, he's breathing air. They are both under pressure. Now the guy on the left is feeling dizzy, so he's going to take off his mask, he's going to lose his consciousness, and he's going to lay down. In a few seconds, you are going to see his tonic-clonic spasms, like in epilepsy. Have a look at his legs right here. In 3, 2, 1, go. There we go. He's having tonic-clonic seizures. He's not remembering anything because he lost his consciousness. So when he will wake up, he will not remember a thing. But imagine if this happens under the water. I mean, in this case, nothing happens, but if it happens under the water and during a military mission, most likely the divers would die. So I got into the lab of Tampa Bay in Florida, University of South Florida, and I joined this team that was working on studying basically what happened to the solitary complex cardiorespiratory neurons when hyperexcited with the hyperbaric oxygen. When I got there, we started to translate this research onto whole animal research, and we implanted Sprague Valley rats with the hyperbaric telemetry modules, as you can see here in the right-hand side picture. These modules were able to tell us in real time electroencephalogram data, electromyogram data, electrocardiogram data, body temperature and physical activity before, during, and after a dive. So we would dive them in a hyperbaric chamber, of course, we would not throw them in the water. But this would allow us to understand physiologically what would happen right before the onset of seizures, so we could communicate the Navy SEALs what did they have to take care about. This is how a rat would seize. See on the right panel, you're going to see a rat seizing. And this rat is going to have tonic-clonic spasms of his forelimb and head, as you can see. At this point, we would stop the experiments and we would record all this data in real time. So this is just an example of the data we would collect after one experiment. What we found, and we published back in 2013, was that 3 to 5 minutes before the onset of seizures, the tidal volume, which is the volume that a rat would breathe, and the respiratory frequency, which is the number of times that the rat would breathe per minute, they would both increase right before the onset of seizures. So we told the Navy, when this is going to happen, make sure you surface as soon as possible in a safe place. Of course, this has been implemented later on some devices, but this was the main information. Now, moving on, not only we wanted to understand what was going on before the seizure, we also wanted to find a way to prevent this to happen. And how could we do that? Well, using antioxidant drug, anti-epileptic drugs, or even starvation ketosis. Now, antioxidants are very mild, so they wouldn't work. Anti-epileptic drugs, well, you might probably know that these drugs have a lot of side effects, so it was out of option. But starvation ketosis was our best option at this point. Now, you might wonder, what has starvation to do, I mean fasting, to do with prevention of epileptic attacks? Well, it does have a lot of connections, actually. In fact, I don't know if you heard of the ketogenic diet. I'm going to explain what a ketogenic diet is in a few seconds. But a ketogenic diet is basically taking off our carbohydrates out of the diet. So pasta, pizza, bread, fruit, just take them all off and stay with high-fat kind of foods, such as meat, fish, olive oil, butter, nuts, and so forth. This kind of diet would increase our body ketones, and that would prevent seizures to happen. That would neuroprotect our brain. So we could not put the Navy SEALs on a, on a ketogenic diet, which is kind of stressful because you can take off all the comfort food out of their diet. So we had to come up with something that would let us reach the same level of ketosis, but without putting them on a ketogenic diet. In order to do so, the only way to do so was to synthesize a ketone ester, a non-ionized precursor of ketone bodies, and gavage gave our rats intragastrically this compound so that the ketosis would be spiked up in 30 minutes. And that's what we did. But let's step back to the nutritional ketosis first. So how we do sustain nutritional ketosis? We should follow a diet that is about 75% fat, 20% protein, and only 5% carbohydrates. So what could we eat? As I said, meat, fish, bacon, eggs, olive oil, butter, nuts. This is the type of food that we could eat. We should avoid pasta, pizza, bread, chocolate, fruit in general, with some exceptions. But still, this would spike down the glucose and insulin. What is the nutritional and therapeutic ketosis optimal level? Well, it has been published a few times, especially by Jeff Volek and this group, that the best level of ketosis would be in between 2 and 5 millimolar. Over 5 millimolar, we would step into a dangerous area, which is that one of ketoacidosis, but definitely we would not reach that area if we have a functioning kidneys and liver. There is no way we can get there. So what are the advantages of getting to keto adaptation? The keto adaptation would be kind of hard to obtain, like about 2 to 3 weeks. But once we get to that point, our concentration gets much higher. Our capacity of sustaining efforts would be much higher. Our concentration would be much better. And we would have a decreased central fatigue, an enhanced brain metabolism, a decreased reactive oxygen species production, an increased biogenesis in mitochondria, an increased insulin sensitivity, and less lactate in muscles. We have a lot of benefits out of it. So you might think that this is a new story. This is something new. Actually, it is not at all. It was published back in 1922 for the first time by the Los Angeles Times at the Johns Hopkins Hospital in Baltimore. The alternative official therapy, for the consensus for children affected by refractory epilepsy, which is the epilepsy in which children are not responsive to drugs, to medications. In this type of epilepsy, children would be kept in a ketogenic diet, so no sugar, and they would be in many cases out of seizures, completely out of seizures. In 1/3 of cases, that would be considerably better, and in just only 1/3 of cases, it wouldn't be working. So we might think that this would be the first example of publication on ketogenic diet, but it is not at all. If we go back to 400 before Christ, we go to Hippocrates, and he was the one that was the first describing starvation, fasting, as a process to heal the epileptic subjects. Of course, back in 400 before Christ, we wouldn't have a diagnosis of epilepsy, but we had people that were possessed by the devil. These people were put on isolation for a few days, and no food was provided. So they were put on isolation and fasting. After 3 days, 4 days, as he describes, these people were not possessed anymore. what did this mean? That this means that basically these people were affected by epilepsy first, but the fact that they were put in isolation without food would take them off of seizures. So 400 before Christ. If you want to have a complete idea of what ketosis does to your metabolism, I would strongly suggest you to go check. This is a very comprehensive review by George Cahill. It was published back in 2006. So back to our experiment. We wanted to understand if this compound that would mimic a ketogenic diet would be able to let them resist longer against seizures. And we found that this compound was able to let them resist 600% longer. Say that a first rat would seize after 10 minutes. After this compound, the ketone ester, the rat would be able to seize after 60 minutes, actually would seize after 60 minutes. 10 minutes versus 60 minutes. It's a huge amelioration, a huge improvement. So we published this paper still in 2013, and we found that there were 3 ketone bodies. The 3 ketone bodies were responsible for the neuroprotective effect: beta hydroxybutyrate, acetoacetone, and acetoacetate, and acetone. But most of them, acetone was the most responsible compound of the anti-epileptic activity. Then I got back to Italy, and I've been working with Dr. Coppola and Dr. Vigiano at University of Salerno. I've been testing the same compound, the ketone ester, on 2 different models of pentylenetrazole, which is a very well-known model for epilepsy. And we've been finding that even in these 2 models, the ketone ester was able to considerably increase the resistance against the epileptic attacks of these rats. So we published 2 papers back in 2015 and 16, finding that this was a very valid model. But there are so many applications for the ketogenic diet and the effect of ketones. First of all, he was born as Atkins diet for bodybuilders to lose weight before a competition. But then he got adapted for obesity. And then he got adapted for Alzheimer, Parkinson, and Lou Gehrig disease, ALS. Why? Because of their neuroprotective effect. So basically it would prevent a neurodegeneration. But again, it's been used for NHL in the United States for traumatic brain injury. And moreover, it was used in a few cancer types, especially those who are, who happen in the brain cancers, like glioblastoma multiforme, one of the most aggressive brain cancers that could exist in this world. Well, as you probably know, cancer cells cannot get fed out of fats, of fatty acids, of ketone bodies. Only healthy cells would be. So basically, healthy cells would try to get nutrition out of glucose. If glucose is missing, they would start attacking ketone bodies. So the fat would produce ketone bodies, and the ketone bodies would be used by the body as alternative fuel. This doesn't happen for cancer cells because they have some defects in the mitochondria that wouldn't allow them to use ketone bodies for energy. So the result is that if we put an oncologic patient on a ketogenic diet, not for all cancers, but for brain cancers and for some other cancers, we can get a starvation of cancer cells and nutrition, selective nutrition of healthy cells. Then the cancer can be removed. I mean, there are many cases that have been, studied and published in the literature. And last but not least, of course, epilepsy, as I was telling you. Briefly, I want to introduce you to Mike Dancer. Mike Dancer is a good friend of mine. He's from England. He was diagnosed epileptic grand mal seizure at the age of 34. He was put on anti-epileptic medications for 4 years. And after 4 years, he just decided to stop because he was having so many side effects. But he started the ketogenic diet. His neurologist told him he wouldn't have survived 6 months since that point. But actually, not only survived 6 months, not only, he was feeling much better, he's been living now for 12 years. And he didn't have one single seizure, one single epileptic attack since then. So can you imagine how powerful this can be? So I got back to Italy and I needed to find something to get patients involved. As a pharmacist, I see many people every day, and many of them might need the benefits of a ketogenic diet. So I started advising ketogenic diet for those who might follow it. But I needed something to increase the compliance, because go tell an Italian to get rid of pasta, pizza, sugar, dessert, fruit, it's impossible. So I had to find something that could give the same nutritional effect, the same satisfaction, but wasn't composed in the same way. I found this company that was able to produce food items with very low amount of carbohydrates and high fat. And I started working with them. So a lot of patients might actually get a much better compliance. In addition, I've been publishing a few videos on YouTube for common people, for profane people, for people who might not understand much about metabolism, but they might actually benefit out of a ketogenic diet. I've been publishing these videos with the intent of helping them finding their way. And it's been actually very successful. Plus, I've been publishing a few reviews on ketosis and ketogenic diet and its variety of applications, among which also diabetes type 2 and diabetes type 1. In fact, in diabetes type 2, I have colleagues not too far from where I live that have a lot of patients, diabetes type 2 patients. They are able to get them off of insulin completely. In some other cases, diabetes type 1, they're able to waive about 70% of the original insulin. I mean, they cannot take completely off, but it is astonishing that they're having amazing results. So back to this product, we were able during these years to obtain Ministry of Health authorization for providing them to epileptic patients and GLUT1 deficiency patients, so they don't have to pay for this anymore. A very quick overview on cancer patients. We had many patients. I'm just going to present the best cases here. Marco, 63 years old with prostate cancer, was put on a mild ketogenic diet 3-to-1. His prostate-specific antigen, PSA, went down from 162 to 1, and he's been on 2 years out on a ketogenic diet, and he didn't have any cancer recurrence since then. Mario, 66 years old, he had pancreatic cancer, put on a very strict ketogenic diet. His cancer antigen went down from 43.69 to 9.84. He's been on a ketogenic diet for 2.5 years and didn't have any evidence of cancer recurrence. This guy is 47 years old, glial lesions, put on a very strict ketogenic diet 4-to-1. 9 months on this diet, and he had the reduction of the edema of the tumor mass and the glial lesions extension, sorry. Matteo, 45 years old, he had a colon adenocarcinoma at stage 4, put on a strict ketogenic diet. He was able to get fantastic results, and he had the reduction of adenocarcinoma lesions, but also glycogenosis. In fact, this guy, for 25 years old, he had a lot of spasm and pain. Thanks to the ketogenic diet, he was able, in only 1 year, in 2 months, actually, even less than that, he was able to go back to work. He didn't feel no pain anymore and could go back to exercise. Giancarlo, he had glioblastoma multiforme, but I encourage you to go check the literature about that, because there's a lot about ketogenic diet and glioblastoma multiforme. Was put on a very strict ketogenic diet, and after 8 months on this diet, he had no cancer recurrence. So in order to sensibilize the registered dietitians that use this kind of diet, in association and collaboration with this Professor Anna Tagliabue from the University of Pavia in Northern Italy, we organize every year a specific course for registered dietitians. Not this year, of course, because of COVID-19, but the previous one, it was organized. And now I'm getting to the very last part of my presentation, which is about Parkinson's disease. Very quickly, just want to introduce that to you. Not many research groups have been discussing, have been analyzing and researching on that, because ketogenic diet can cause constipation. It's one of the very few side effects. And constipation for Parkinson patient might be a big deal, especially if they are at advanced stages. So we know, as a matter of fact, the MPTP neurotoxin is responsible for the neurodegeneration, and that beta-hydroxybutyrate, one of the ketone bodies, actually is able to contrast the MPTP action on these patients. There is not much literature on that, as I said, because not many physicians want to take the responsibility on these patients. So we have to go through the very small amount of literature on Parkinson's disease and go through the data that were available. So we started a study on a stage 1 Parkinson patients on this clinic in very close to the place where I live. And this study is not over yet because of COVID-19. Now it's been interrupted. So we have started analyzing the patient's speaking abilities, facial expression, tremors, rigidity, hand mobility, leg agility, posture, before, during, and after 3 months on a ketogenic diet. So we've been analyzing their autonomic dysfunction, the sleep troubles, neuropsychiatric disturbances, and other troubles like respiratory troubles, like pain, like falling, and so forth. And we've been using the G-walk test, the time up and go with torsion test, and the 10-meter walking test. We've been analyzing their memory, their concentration, and their phonemic and semantic fluency, the way they could speak. This is just an example of how a test would work. We asked the patients to remember a pattern that we indicated them. Also, we asked the patients to select the right pattern on these shapes, as you can see here in this, these drawings, and they had to select the right one. So we would actually stimulate them and trying to understand if the ketogenic diet was having some positive effects on that. Then we would analyze the data. Now the data are not complete, so we do not have the information to give you, but the study is ongoing. We hope to get back on our test as soon as possible. So we've been evaluating their cognitive performances, decline, their motor and non-motor conditions. And we are in line so far with this study published in 2018 from Dr. Phillips in New Zealand. He randomized, he put on a ketogenic diet a group of randomized 47 patients. Only 38 of them completed the study. He found that after 2 months on a ketogenic diet for these 38 patients, he found a decrease in urinary problems, decrease in pain, a decrease in fatigue, general fatigue, a decrease in daytime sleepiness, and a decrease in the cognitive impairment, which is a great result, but most of everything. He demonstrated that the ketogenic diet is safe to be followed for even 2 months. It's safe, completely safe. There's no contraindication. So, long story short, we are in line with the study in terms of decrease in urinary problems. In fact, our patients didn't complain about urinary problems anymore. On top of that, we organize every year a run for Parkinson with these patients. So we ask them to come and join other patients to make them walk from point A to point B. And it's kind of nice to get together. What is our next step? Our next step is to use the ketone ester on these patients to avoid them to be on a ketogenic diet, which is kind of hard, and get them straight to the optimal level of ketosis, giving them the ketone ester several times a day. This is our next step. We hope to be able to do so. Now, I just quickly want to thank the Italian Global Deficit Association and the rareconnect.org, which I encourage you to go check. This is a website for rare disease that put in communication families with, patients having rare diseases. I have to thank Dr. Casimira Cusano for helping me with the ketogenic diet and in the application of a wide number of pathologies that you can see listed here on the right-hand side of this slide. And last but not least, I want to suggest to you, if you're interested, 4 movies that tells us about how bad sugar is for us, especially Fed Up. This is of high interest for the diabetes field, because this movie explains that pretty much if the diet habits, the dieting habits, the nutrition habits of Americans will continue in this way, in 2050, they expect to have about 1/3 of people having diabetes type 2, especially consuming high amounts of high fructose corn syrup. Diabetes is spiking up in the States, but actually pretty much in the world. So this movie explains how bad sugar is for us. These other movies from Australia, that's Sugar Film. In this movie, the main character tries on himself, on his body, the bad effects of sugar. He goes and has excess of sugar in different ways. This other movie is very interesting. The Magic Pill is still from the United States. Explains actually that we could actually have a much better nutrition habits if we change something. And this is the last movie, which is a homemade movie. Butter Makes My Pants Fall Off, and explains how having a high-fat diet, this guy, who had also diabetes type 2, was able to get back to the way that you can see in this picture. This is kind of amazing. So thank you to all my colleagues back in the United States, in Italy, in France, and thank you so much for your attention. If you have any questions, I will be very happy to answer. Thank you.
Any questions to Dr. Raffaele Pilla? Any questions? Thanks, Dr. We have handled your speech. Pleased with your topic.
Thank you. Thank you very much.
Yes, looking forward to meet you again next time.
Me too. Thank you.
Yes. Thank you very much for taking a lot of time. So we asked Dr. Dahenia Camacho from Monclova, University of Puerto Rico, to rejoin the event and start remaining presentation, as we have got disconnected due to technical issue.
Yes, sorry about that.
Yes, we have.
You can hear it's raining and there's a lot of lightning and.
Yes, madam, we do understand.
I don't have much left, so I'll try to be brief. So yeah, we were talking about social and behavioral factors that could affect the prevalence of severe moderate periodontitis in individuals with type 2 diabetes. And we were describing the population, and we were in this table where we described the prevalence or the occurrence of moderate to severe PD by characteristic. So you can see in the age range of 40 to 49, more people had moderate to severe PD compared to no PD or mild PD. And the same happened with the age group of 50 to 65 years. In the male gender, the majority have PD moderate or severe as opposed to mild PD or no PD. And in the case of the female gender, you can see that the majority had were likely to not have moderate to severe PD. And in the educational level, having less than a high school diploma, people were more likely to have severe moderate PD, and having more than a high school education, people were more likely to not have PD. And in this, it's the same case with moderate to severe PD in former smokers and current smokers. And the same to alcohol status. If they are drinkers or former drinkers, they tend to be on this side of the PD, moderate to severe. And the same goes to overweight and obese individuals. As you can see, the majority tend to be on this side, more likely to have PD, severe moderate PD, as opposed to mild or no PD. When people visit their dentist at least once within the last year, they're more likely to not have PD or have a mild case, as opposed to people who went to the dentist less than once in a year. And with the dental flossing, you can see that people who floss at least once a day tend to have moderate to severe PD as opposed to no PD. And it's the same case. It's not the same case, sorry. It's people that floss less than once a day tend to not have PD. But this is an interesting variable because we hypothesize that, you know, people that floss once a day, you can see here, that tend to have moderate to severe PD, but that might be the people who got diagnosed PD, moderate to severe PD, tend to floss more now after knowing their PD status. So we can see that there is a significant association when we adjusted the analysis for all these variables in the female gender, with the female gender, and at the education level, and the dental visits. So we can discuss and we can conclude from this study that females, the gender female, were 53% less likely to have moderate to severe PD compared to males, and that those with higher education, like higher than high school diplomas, were 51% less likely to have moderate to severe PD compared to those with less education. And those who visited their dentist more frequently were 53% less likely to have moderate to severe PD compared to those who visited their dentist less often. The other variables, age, smoking status, alcohol status, did not show any significant associations with the occurrence or prevalence of severe to moderate periodontitis. And as this is the explanation of the dental flossing, that although it was marginally significant, the estimate suggested that it was not a protective factor because they had an award greater than 1. And that might be due to individuals flossing more when they're aware of their PD status. So the strengths of this study is that it evaluated rigorously the periodontitis classification into mild and no periodontitis and moderate and severe, and it garnered different possible contributing factors that can be, some of them can be modifiable. And not many studies assess a collection of social and behavioral factors that are associated with moderate to severe periodontitis specifically, and in Puerto Ricans with type 2 diabetes. The limitations is that the sample was drawn by convenience and results may not be generalized to adult diabetic individuals. It would need to be a greater sample. We only had 260, and then we had to exclude some participants, and then it was further reduced to 248. And as with any cross-sectional study, there's recall bias and temporal issues. So in conclusion, the female gender having a higher educational level and visiting the dentist at least once a year may be associated with a reduced occurrence of moderate to severe periodontitis in individuals with type 2 diabetes. But it is recommended that type 2 diabetes individuals with moderate to severe periodontitis, especially men, be educated on the importance of their dental visits and oral hygiene practices. And yeah.
Yes.
That's it. Thank you so much. And sorry
Yes.
for the inconvenience.
Yes, doctor. Any questions to Dr. Dahineria Camacho? So, thanks very much, doctor. We enjoyed your speech. Pleased with the topic. Looking forward to meet you your next time in physical event 2021.
Thank you.
Thank you very much, doctor. So almost we have completed most of the talks. 2 more talks are left over for the day. So they'll be joining tomorrow. So finally, We take this opportunity and extend our most sincere thanks to all keynote speakers, plenary speakers, students, general collaborators, media partners who have come to join from different destinations around the globe for this support and cooperation. Let us thank speakers who have responded so well to our invitations to participate in this conference. We have received several papers which will inform on the basis of our discussion in these various sessions. Let us thank for all associating with this conference by your presence. A special thanks to Program Manager Ms. Lizahan for her continuous effort in putting all us together under one platform in this online event. We will join at same time as joined today and complete day 2 remaining speakers presentation. We will be sending officially through mail electronic certificate and a handbook. Finally, we extend our appreciation to each of you for your participation in this online conference. Thanks again. Have a nice day. Bye.